Let's hear it from the chairperson of the workshop and symposium.
I would like to call upon Professor Manoj Kumar sir to guide us through the highlights and objective of today's event and give us a brief introduction.
Sir.
Thank you for inviting me as a introductory person. Very warm welcome to all of you. After yesterday, very broad brainstorming session, now we will witness today a very fabulous and complex topic today, delivered by stalwart of the in these fields, and we are fortunate enough to have Dr. Durgesh Dwivedi here, who arranged these special topics, and the speakers are from abroad, India, and they are doing their best in their fields. And today we will have a 6 session, including the basics and fundas of the MRI, sequences, how it is taken, how it is done, and about the basic pulse sequences, functional MRI, MR spectroscopy, and even MRF. And you will also in between learn some basic advanced cardiac and perfusion techniques also. And these are the basic, I think the among in your question paper in an MD residents in their 4th paper, we ask about the recent advancement, and I think there will you will have at least 2 questions from these topics. I assure you. So better you read and go through again. You repeat these topics as tell by the orators, and the last session will be hands-on session like yesterday, and don't just forget this one. And it is basically designed for new frontiers and the residents and the technicians, and it will be very important for your viva also, because we ask about the small things which comes from the knowledge and the when you handle the machine. So stay with us and enjoy the today's this brainstorming sessions. At last we will have a prize distribution and group photographs. So please stay with us and have a great memory. Thank you. And I handed this mic to the again organizing committee.
Thank you, sir. Now to start with our session of plenary and introductory lectures, I would like to invite Professor Hardeep Malhotra, sir, to speak few words about the session. Sir.
Good morning, everyone, and I hope everyone has had a tea and is geared up for the sessions. So it is my esteemed honor and privilege to extend a warm welcome to each and everyone who is here attending the session on physics of the CT and MRI. I am profoundly excited to witness the convergence of brilliant minds and cutting-edge research in the field of physics and medical imaging. And it is really, heartwarming to see the participation, the involvement of the speakers, and the magnitude of involvement along with the expertise. So, as we know that the significance of CT and MR in modern healthcare, it cannot be overstated. And when it comes to basic physics, which is amalgamated with artificial intelligence, we know that right from the basic lab diagnostics to what we have seen in the recent, Booker Prize is writing a book, artificial intelligence has moved into everything. And with the revolutionary imaging modalities, which has transformed the diagnostic landscape, it enables us to peer inside everything, be it any part of the body, with the diagnostic modalities like a MR or a CT, based on their relative principles of magnetization or attenuation based on the X-ray. So as of now, be it a tumor, be it a traumatic brain injury, something which is related to a cardiovascular or a cerebrovascular health, it has been helping us to diagnose and improve the health outcomes of the patients. So today we have the privilege of exploring these intricate details, uncovering the mysteries that lie beneath the surface inside our body, related to our body, with these remarkable imaging techniques. Together we have the power to shape the future of medical imaging and paving our way for breakthroughs that will impact lives and transform healthcare delivery for possibly generations to come. I extend my heartfelt appreciation to the organizers. We have, Dr. Anit, Dr. Neeraj has joined us, Dr. Arvind, Dr. Manoj is here. We have, besides Dr. Durgesh, his team, who's supported in the form of coordinating the sessions. I appreciate everyone, and their tireless efforts have actually, brought this workshop to force, which was, I think, they had been planning for quite some time, and commend all the participants too for their dedication towards advancing in the field of CT and MRI physics. May this workshop be a catalyst for inspiration, innovation, and meaningful collaboration. Thank you, and I wish you all the fruitful and enlightening experience ahead with the expert, which we have on board, as well as the coordinators here. Thank you so much.
Thank you, sir. Sir, please be seated as the chairperson. I also invite Professor Vishwajit Singh, sir, Professor, Department of Urology, KGMU, to kindly commence the session and introduce the speakers.
Should we start the session? So, I suppose we can start the session. Yes, to start the session, we would like that there should be no delay. So, session 1 on the plenary and the introductory lectures. The first presentation that we have is on artificial intelligence and advanced diffusion imaging, diffusion MRI in neuroimaging. And to deliver his lecture, we have Dr. Yogesh Rathi. He is Associate Professor of Psychiatry and Radiology from the Harvard Medical School, Boston. He is an Associate Director of the Psychiatry Neuroimaging Laboratory, PNL. His research interests lie in developing smart imaging techniques to understand the brain's structure and function. He has developed several algorithms for fast imaging of diffusion MRI, a technology that is now being used to obtain advanced MRI scans of children with ADHD, that is attention deficit hyperactivity disorder. His current research focus is on ultra-high resolution diffusion imaging, combining acquisition and reconstruction, estimating tissue microstructure from biophysical and stochastic models of diffusion, time series analysis for understanding functional connectivity using functional MRI, EEG, or the MEG data, that is the magnetoencephalography. His clinical research focus includes using and developing sophisticated tractography algorithms for precise targeting of DBS, deep brain stimulation, and transcranial magnetic stimulation in patients with OCD. Other areas that are involved in this evaluation are Parkinson's disease and major depressive disorders. His broad research focus is in the areas of signal and image processing, statistics, control theory, machine learning, computer vision, and related applications to solve inverse problems in medical imaging. He has had his publications in high impact journals and is very active in the area of machine learning and artificial intelligence. This I invite Dr. Yogesh Rathi to initiate his lecture. Dr. Yogesh Rathi.
Thank you. To the organizers, can everyone hear me?
Yeah, please go ahead. We can hear you.
All right, great. Thank you everyone for being here for the talk. I'd like to kind of continue, do my talk and then leave some time for question answers so that there is a bit of an interaction. So we'll leave it at the end so that I'll continue and finish up the talk because it will be difficult otherwise being remote. Next time hopefully I can be in person and we can do this much more in a more interactive way. So to begin, I'm delighted to be at this workshop on exploring new frontiers in MRI and CT. So the basic outline of my talk is, I'll just cover very basics of diffusion, then connect how diffusion MRI is used in the brain, how it's used for getting the connectivity of the brain, and then how AI, artificial intelligence, diffusion MRI can be used in combination, and then some very short future directions of how it can be used in the clinic. So some basics of diffusion MRI. Water, as you know, is the main constant in the human body, and at room temperature, water experiences thermal motion or random walk, as we call it. You can see some of that picture of basically diffusion of the ink in water, and this is basically the main process through which diffusion MRI is used. So here you see some sort of molecules of water here, the different colors facing random paths and colliding with each other and so on. And this motion is what we tag in diffusion MRI. So what happens is each of these arrows inside this sort of blue ball here, you can see it's experiencing random motion. And these arrows that are outside are the way in which we acquire the diffusion MRI data. So what we do is we say, in this particular direction, how much is the water diffusing? In this particular direction, how much is the water diffusing? So if it is isotropic, it's like, let's say pretty much water can go wherever it wants, it will be isotropic diffusion signal, as you can see in the sphere below. But if it is in a cylinder, then water can only go, but the majority of the diffusion or motion of water happens in one direction, which is the longer direction of the cylinder. The other directions are restricted. They do experience some motion, but it's very restricted. So we can get anisotropic motion of water. And this is the basic principle of diffusion. So why is that important? So here you can see, let's start with the tissue paper here. You just put an ink here and you wait it for some time. And this is tissue paper. So you can see it doesn't have any kind of structure to it. It does have a structure, but it's not sort of fibrous structure in a particular direction. So you see the ink is diffusing equally in all directions. But if you take a newspaper, this is how you see on the right side here, and you put ink, it has some fibrous structure to it, and so the ink will go more in one direction than the other. So again, explaining the main principle here. So you see here a picture of the brain. You have axons. The axons are kind of cylinders or white matter. Is essentially a bunch of cylinders, or at least that's how we model it. And they're not exactly cylinders, we all know that. But at least for the case of diffusion, they look like that, and you can model it that way. So along the cylinder, the water will diffuse in that direction, and essentially what it means is that the water is diffusing along the axons, and that allows you to essentially measure multiple things from that water diffusion. So essentially, you can measure as anisotropy, you can measure which way the axons are oriented, and so on. So diffusion MRI came into being very early on. It was used very much, very quickly adopted into the clinic. It this is in year 2000. You can see on the top it's CT, on the bottom you can see the same brain, but imaged with diffusion MRI, the ADC map, and you can see that the stroke is very, very clearly visible compared to the CT. And so no contrast agent needed, and scan can be very quick for ADC map. Same thing even with T2 weighted images. You might have seen some of these images on the top. You don't see much of the stroke lesion there or edema there, but in diffusion ADC map, you can see that on the bottom. So essentially, as you can see, because diffusion is very sensitive to the microstructure, the contrast shows up. And this is an important point to note, and that's why it's being used predominantly in stroke, because it's very easy to see the contrast. Another place where it's very, very often used is for the diagnosis of tumor, and here in the orange box you can see edema that is around the tumor, which is not seen in the other modalities that are green blobs are tumors that were segmented, and you can see that the tracks, the cryptography is able to trace them around them as well as through them if it's possible. So it tells you whether there are tracks present there or not, and useful in surgical dissection. So after this, we move to what are the things that artificial intelligence or machine learning, deep learning can bring to the table, and how it can help with diffusion MRI. So I'm going to give, I don't have time because it's, I think we have about 20, total time was about 20-25 minutes. I didn't want to give a detailed lecture on just one aspect, but give you a broad overview of what is possible and what people have done, including some from our lab and some from others. So artificial intelligence can be used for data acquisition and reconstruction. Also, how do you harmonize data from different scanners and vendors? How do you solve these inverse problems of the orientation, fiber orientation problem that I mentioned earlier? Also, tissue microstructure estimation. And when I say tissue microstructure, it means estimating, for example, axon diameter. How do you estimate that? How do you use AI for large-scale population analysis so you can understand multiple brain disorders? And how do you combine that with um, uh, sorry, how do you combine that with multiple uh, modalities as well as local? I think I'm getting some kind of disturbance. Not sure why. All right. So the first thing is you can use AI for data acquisition. And here is a paper that is a very nice paper on, which is called MR0. So it uses a supervised learning technique to automatically generate MR sequences. Imagine that, right? And reconstruction based on the target contrast that you want. So if you're interested in looking at a particular contrast, then this is beginning. I mean, this is 2021, but this is beginning to pick up, and this is really fascinating. So here we show some results from our own lab. The data was acquired by moving the field of view, rotating the field of view, which is shown on the left, in a certain way. So you acquire the data by rotating at a certain degree of angle, and then you combine all of data using a deep learning method, which is using a implicit neural network to reconstruct the data, and finally you can get the entire data at a much higher resolution than you already acquired. So here you can see if a simple bicubic or least squares fitting was done versus our neural network based acquisition gives much cleaner data set. Sorry. Then again, one of the main things I would like to point out is that while for contrast it's probably fine to use to take data from, say, a Siemens vendor or a GE vendor or a Philips vendor or a United scanner. But if you want to do quantitative MRI, which means you want to really measure exact numbers, just like, say, blood glucose level or blood pressure or something, which is much more quantitative, you have to make sure that it's calibrated so that the numbers are the same across scanners, and that's not currently the case. You can't say that I'll get the exact same numbers for the same subject across scanners. So we are developing methods to harmonize data across scanners, and here deep learning based methods are coming in handy. You can see here at the right side, a convolution neural network was used so that it can predict data from another scanner, and the difference in the predicted scanner is below, which is pretty much no structure there, which means it's mostly noise. As I mentioned earlier, fiber orientations, quantifying uncertainty in their orientation is also very important. So how do you know exactly whether your orientation distribution functions are whether the orientations of the fibers are really correct. So you need to quantify that uncertainty. Uncertainty means how confident you are that that orientation is the one that you got. Maybe there is some kind of confidence interval that you need to know, and that allows you to make sure that your estimation is correct. So this is very important to know. And as I mentioned, another part that is important is microstructure estimation. And here, deep learning methods for solving inverse problems comes in handy. At the top, you can see some kind of a deep learning architecture where we take in data from different B values and whole brain, and then at each voxel, we try to estimate what are the number of fibers and what are the sort of parameters of the model. And at the bottom, you can see fractional anisotropy, which is standard, but also which is not typically easy to estimate. And this is where the uncertainty quantification comes in handy, is the standard deviation in FA. So it's not a standard deviation across a region, it is each voxel. So you can see in the gray matter, the standard deviation is high, which tells you that the confidence in your estimation of FA in that region is low. So you shouldn't, when you do some kind of statistics for quantitative analysis, you should trust that region. If you use that region for your analysis, then you should trust it much lower. Also at the boundary of different tissue types. So the same principle applies. Large scale population analysis, you can see here, this is a very, very recent paper. As you can see, it just came out on February 14th, a few days ago. And what this paper tries to do is use genetics and clinical correlates for AI-based brain aging patterns to discover them. So you have something like 27,400 individuals here from age 45 to 85, and they try to figure out how many different types of groups you can find in terms of how the aging changes with how the brain changes with age. And they found about 3 different types of patterns, one which was typical and 2 groups that showed accelerated aging. And you can, because there were all associations with cognitive decline or cardiovascular risk and so on. So you can see the other part that is interesting is they're connecting so many other factors, cardiovascular risk and genetics and so on, that are not necessarily part of the brain, but feed into the fact that they are connected with how the brain ages as well. So this is where large-scale population analysis can be used. And then I'd like to go quickly just to show people how in the future we see low field MRI. This is a 6.5 millitesla scan. I mean, this is really, really very, very, I mean, we are used to 3 Tesla and 7 Tesla and 11 Tesla and so on. And this is, 1,000 times smaller than those kind of magnetic fields. And, on the top, it shows deep learning based reconstruction of the data. You can imagine these type of scanners being available in the ICU or to image patients where, all you need to know is whether there's a stroke or not, or what type of abnormality, if any, you can see. So the data quality may be bad, but it can give you a very quick sort of first line of understanding of what might be going wrong. And in detailed analysis, if available, could be done elsewhere. But in the field, you can imagine this to be available in, say, semi-urban centers or rural centers. At the bottom, you see the same image that was acquired, that was just done reconstruction using standard techniques, but this is just within 11 minutes of scan time with using deep learning method. So finally, coming to the last sort of point here, where do I see diffusion MRI useful in the clinic? I see that it could be used, for example, to develop a risk calculator for neuropsychiatric disorders. Potentially could be used in other body organs as well for early detection of disease, and also in drug development and disease progression tracking. And with that, I would like to thank, most of this work is done by the students I mentor them, and these are all few names that are currently working with me, and there are many others that I didn't list here. And also, I definitely would like to acknowledge all the funding that I have received from the National Institute of Health for doing all these super interesting work. I haven't gone too much into detail about acquisition on all of those things, where we have vendor neutral platforms that I'm developing. But that's, I guess, another topic for another day when we get a chance to do that. And thank you very much, everyone. I'm delighted to be here again, and I'm happy to answer questions. No question?
Thank you, Dr. Rathi, for an excellent lecture. So if there are any questions, we can have a couple of questions if there are any.
Yogesh, this is Durgesh.
Oh, yes.
Wonderful. Thank you. Such a scintillating talk, and you covered so marvelously. It's such a complicated topic. It's a very wide topic also. So thank you so much, and I appreciate like you are spending time with us because it's like around 11 night over there. So I have a question. Could you just like to the audience level, like because you guys are like stalwarts in harmonizing also. So why there is no need of that? And little bit on to this audience because we have a lot of neurologists amongst us, radiologists also. Like the way future is going to work for low field MRI.
Yeah. So thank you, Durgesh. And so for harmonization, I think the main question is, for if you're looking for contrast, I think it doesn't matter. Just looking at, if you're looking to see where is the tumor or where is the stroke, that is probably not a problem at all. But if you're looking for quantitative numbers, which is where things are going to go in the future, where you are looking at exact numbers for example, the T1 value or the T2 value or the diffusion MRI FA, then each scanner does its own thing. So Philips does its own way. So if somebody were to do a scan, so if I was getting scanned on a Philips scanner, let's say it's 1.5 Tesla, and if I go on a GE scanner that is 3 Tesla, and I go on a Siemens scanner that is another 3 Tesla, each one of them will give me a different number. And then even AI will not work, or even we will not be able to say whether this particular place or region is having a problem or not. So that's why we need harmonization, so that the numbers that we get out of the scanner are going to be pretty much the same.
Awesome.
And yes, and then the second question. You mentioned Durgesh was
The reason is because there is another workshop going on parallelly because I kind of coincided with them in Delhi also, so I just attend like
right.
now. There, Derek and all the vascular team is there, so they are working on accessible MRI. Especially the rural population, they are catering like African population. Those are LMIC country, very poor countries, including India also. Not although we are not in the poor country list, but they are looking to provide all the Andrew Webb and all. They are everyone is here, so they are working to provide the low field like the 0.33 Tesla MRI. Just to solve the issue of rural area because there is no MRI, and now they do have power supply, but there are huge challenges of radiologists and other challenges. You understand that rural setting. So could you comment on that also? Yeah.
Yes, so I think this is where the things will be going, and I'm glad there was a workshop in New Delhi about it, and I regret that I couldn't join, but. I think we are also developing many things on that particular aspect. So going to low field, as I said, is going to the field, going to rural areas. What would be the research areas of the questions that are open there is, how do you build them to scale? How do you make sure that at least basic things are available? But also, what kind of contrast you would like, and developing sort of MRI sequences that can work on these sort of custom type of MRI scanners. So developing vendor neutral platform, which means that develop a platform in MATLAB or Python or any other programming language so that you can run the sequence on any of these scanners. And again, I think developing more and more of these type of low field MRI, which can give you some quick information about neurological disorder of any kind, would be a key player for sort of getting MRI to the masses.
Thank you. Thank you so much. Any other questions?
So,
Neeraj?
any other question? If there are no further questions, I think we can move on to the next topic. I'll hand over the session to my co-chair, Professor Vishwajit Singh. Sir.
Thank you. Should I move now? My privilege to introduce Dr. Durga Uday Kumar. Right now she is Assistant Professor in Department of Radiology, UT Southwestern Medical Center, Dallas, USA. Dr. Uday Kumar research interests are focused on radiogenomics with emphasis on identifying quantitative imaging measures as a non-invasive tool to predict alterations in molecular and metabolic characteristics in kidney and breast cancers. Her research interests also include deciphering molecular drivers of breast cancer and bone metastasis with the goal of identifying and targeting specific orthotopic factors. Her work spans for the tissue characterization, preclinical animal model, preclinical imaging to human imaging. She utilizes advanced magnetic resonance imaging and positron emission tomography method to answer these questions. Her area of interest is cancer biology, quantitative imaging, molecular imaging, metastatic mechanism. Her publications, particularly in the Nature, has drawn worldwide attention. She has received prestigious Lottie Award in her best oral presentation in magnetic resonance imaging in main scientific session in 2001. So with this brief introduction, I invite Dr. Durga Uday Kumar for her presentation. Thank you.
Thank you so much for the kind invitation. Do you hear me clearly?
Yes, please continue.
Okay, thank you. So, do you see my slide as well?
No, they are not visible as of now.
Okay. Let me try to project again. Okay. Yeah. Do you see my screen?
Yes.
Okay. Wait. Sorry, 1 second. Okay. Do you see my PowerPoint slide now?
I think there is something, but we can't see your PPT.
Oh, PPT, okay. Okay, let me do one more down.
Yeah, something is going on. Yeah, I guess.
Yes.
No,
Okay.
again is. Again, we are not able to see your.
Not this screen? You're not seeing my PowerPoint?
No.
Okay.
I think the.
Would it be,
You are
I'm
saying
sorry?
something? You are saying something?
yeah. So let me see if I can do by Zoom again, like how you did, or
So what time is it over there?
right now it's 10:20.
10:20. All right, if we can start with Zoom, then we are fine. Yeah, we can go with Zoom also. If you quickly just send me the link and then, or just try one more time and then we can go ahead
Yeah.
with Zoom. Yeah.
So let me try. Let me try to switch to presentation mode. If you don't see it, you don't see it now, right?
No, I think the same problem Yogesh
Okay.
had earlier. Yeah.
Okay, but first time when we connected, it was okay. But let me try one more time. I'm going to try a different way.
Is Anand not with you?
Oh, let me see. Yeah, I think he is there. Entire screen. Okay, let me see this way. Hold on 1 second.
Yeah,
Okay,
we can
I
see.
think you see my entire screen now,
Yeah, we
right?
can see your screen. Yeah, entire monitor. Yeah.
Yes, the entire monitor. And now I'm going to open the PowerPoint. Now can you see it?
Wonderful. Yes, just put it in slide
Okay,
mode.
perfect. Okay. So
Thank
this
you
is
so much.
good?
Yeah.
Okay, perfect. So let me start. Thank you for the kind introduction, and and thank you for the organizers and Dr. Dukesh to invite me to this presentation. So my talk, the title of my talk is the basics of MR perfusion imaging applications in breast and kidneys, mostly focused on oncology applications. So I will provide a brief outline showing some of the basics of tissue perfusion in the context of pathophysiology, followed by outline some of the imaging methods to measure the tissue perfusion. Let me set the timer aside now. Okay, so, and also I'll particularly for this educational talk, I'll focus predominantly on the contrast enhanced MRI methods, and again provide some overview on the clinical application in the context of oncology in the breast cancer and the kidney cancer, and then provide some take-home points. So since this is an educational talk, I provided some learning objectives for today. At the conclusion of this talk, the participants will be able to gain some basic principles, techniques with relevance to clinical applications of perfusion MRI, specifically DCE MRI, and able to engage in discussions pertaining to DCE MRI in providing insights how DCE MRI is used in tissue perfusion and provide on vascularity and in the context of oncology, and also able to recognize the clinical potential of DCE MRI, and if they are not applying this into their clinical practice, think about the possibility of adopting into the clinical practice. So what is tissue perfusion basically? Tissue perfusion is a process how the blood passes from the arterial supply to the venous drainage. So, through this process, it goes through the microcirculation, microcapillary, and the capillary beds. And this is a very crucial and important process, physiological process that exchanges important things like oxygen and nutrients such as amino acid, glucose, and water. And also it's a way to remove waste products such as carbon dioxide from the tissues. So this particular process in physiology is tightly regulated, as you all know, and any disruption in this tissue perfusion process leads to myocardial infarction, stroke, and chronic kidney diseases where the tissue perfusion goes down. In the tumor arena, it's totally an opposite scenario. So this is a scanning electron microscope images of a normal vasculature and a tumor vasculature. As you can appreciate, in a normal vasculature, the microvascular structure is intact, the arterioles, capillaries, and venules. You can see some nice structural details. Whereas due to increase in perfusion in the tumor and due to tumor angiogenesis, in tumor vasculature, this kind of nice architectural pattern is disrupted. that leads to disorganization of these microvascular structures that loses the arterial, capillary, and venous differentiation. So normally, this kind of pathophysiology is often clinically evaluated through biopsies. They take the biopsy out, do the molecular testing, or doing histopathology. But the challenges are with the biopsy is that you may all know that it is quite invasive and it is very complicated to do in patient population with comorbidities, and especially it is very complicated in the metastatic settings to get some biopsy tissues. So in the scenario when the biopsy is not possible, then what in that case is where the imaging comes into play. So the non-invasive perfusion imaging will be clinically impactful in this scenario for diagnosis, prognosis, and therapy response assessments. So I'm just outlining some of the imaging methods to measure tissue perfusion. SPECT perfusion using radionucleotide agent, PET imaging agent using molecular PET or 15 labeled water, which is considered a gold standard in some cases, and CT perfusion using iodinated contrast agent. And all these either requires a contrast agent as well as and CT contrast agent or it's having radionucleotide or radioactive agents injected. On the other hand, MR perfusion uses gadolinium as a contrast-based agent, and some of the techniques on MR perfusion using GAD contrast agents are dynamic susceptibility contrast, DCE, dynamic contrast enhancement, DCE. Both are using exogenous contrast, gadolinium. There is another technique that is very novel and still in the technical development field, which is called arterial spin labeling, which is a non-contrast perfusion in the sense that the contrast comes from the endogenous contrast. Water in the body is used to label to get the images. So this, I'm not going into detail on this today because this is a very upcoming field. It's widely used in the neuro application, but with limited clinical application in the body because it's still in the technical development phase. So today's talk, I'll focus on the dynamic contrast enhancement, DCE, using GAD-based contrast. So contrast enhancement typically, in clinically, GAD is a bolus injection into anticubital vein on the arm at 1.1 to 0.2 millimole per kilogram in about 10 to 20 ml volume, and then followed by a 20 ml of saline flush. So in this case, without the contrast, the T1 relaxation is longer for the blood, hence it recovers slowly. Whereas once the contrast is in the circulation, the T1 relaxation time becomes shorter, and then the recovery times becomes longer. As a result of this, the blood will appear bright in the contrast images. So this is the only brain image I'm going to show. So here you can see there is left brain, it's pre-contrast, and the right is the post-contrast image. And I hope you can appreciate after the contrast, you can see a nice delineation of the tumor in the brain. So once the gadolinium contrast goes into the body, it goes through the lungs and the heart, and then it goes to the rest of the circulation. So typically and clinically, the injection protocols are often kept the same across different anatomical regions. So this is another example for contrast-enhanced MR angiography. As you can see, the carotid arteries in the brain shows nice contrast enhancement. There's a pointer, yeah. So you can see the nice contrast enhancement here, and this is another example of the carotid artery in the brain. This is a time-resolved MR angiography, also known as dynamic MRI. You can, over time, you can see the contrast enhancement in the arteries in the brain. And then this is the abdominal aorta and the renal arteries, showing very nice contrast enhancements. And this is the peripheral angiography of the entire body. So basically, these are all in the normal physiology and novel anatomy. So extension of this is applied for the oncologic imaging called DCE MRI. So basically, my next step would be to extend some of the basic concepts and principles in the context of breast cancer. So dynamic contrast enhancement MRI in breast cancer. What is unique about this? So for the dynamic contrast enhanced MRI, in addition to the visualization, it is very important in breast cancer to characterize the tumors as well, because benign breast tumors and malignant breast tumors do have, even though they both enhance, they do have different contrast properties. Like in the left panel, you see that there is the benign area, there is the malignant area, they both enhance, but as you see in this graph, that the enhancement percentage is quite different and the enhancement patterns are quite different. So what would DC MRI add value in breast cancer? So the first one, it is known, it has been established that in high-risk screening populations, the DC MRI seems to be superior to mammography and ultrasound in identifying breast cancer at a very significant early stage. Another key important value for DC MRI is that the high negative predictor value. That is the ability to correctly predict the absence of the disease, the ability to tell the patients that you don't have a cancer at a final pathological examination is very clinically impactful. And also differentiating the benign from the malignant lesions, and also it has a well-established role in evaluating therapy response. So this is a basic DC MRI protocol for a breast study. So basically a pre-contrast phase is occurred at 180 seconds, there is a contrast injection happens, that is a 30-second lag, and then the post-contrast phases are acquired. Basically 3 different post-contrast phases are acquired generally. So what is important about this? So breast lesions have different contrast enhancement characteristics. So basically this contrast enhancement characteristic is used to differentiate with benign versus malignant. So the American College of Radiology recommends BIRAT's time intensity curve. This is what it is, the time intensity curves here, as a classifier for benign versus malignant lesion. So I will walk you through this graph. So the red shows a very rapid washing time and also a washout time. And the yellow one shows a rapid washing time, but it has sustained signal in enhancement. Both these graphs phenotype falls for very malignant cancer phenotype, very malignant cancer characteristics. So basically it shows that the tumor is aggressive, it keeps growing, and then another set of tumor is so aggressive that it forms necrotic area inside and also causes a leaky vasculature that leads to these 2 kind of patterns in aggressive malignant tumors. Whereas in the green, you see there is some kind of a flat, even enhancement pattern that 70% of the benign lesions have. So like in this way, looking at the time intensity curves, you'll be able to differentiate between the malignant and the brain, where DC MRI is useful. The second area where DC MRI will be useful in the breast is to differentiate breast cancer subtypes. So in panel A, you see this nice lesion here, and it has a very slow washing rate. I would say it's a moderately slow washing rate, and then a steady enhancement. And then in this lesion right here, which is very much looks similar to the other lesions visually, but you see a fast washing rate and a more slower washout rate. So later on the pathology confirmation, it was shown that the first pattern represents the ductal cancer, which is ER negative, PR negative, and the second pattern represents the lobular cancer, which is ER positive, PR positive. So this is very interesting because this gives you a qualitative assessment, and with only 3 phases, it becomes challenging to do a quantitative assessment in this setting. So to do a quantitative assessment, several groups have developed something called eye temporal resolution acquisitions that gives more of a quantitative assessment. Basically what it means is that the schematic shows that the little circles are the GAD that is extravasating from the intravascular space outside. To explain that further, that principle can be applied in the pharmacokinetic modeling that's called TOPS model. So I'm not going to go into the details of this equation, but there are key things that you may want to note is the K-trans, KEP, and the VE. Basically, this is a voxel because K is a transfer constant or permeability surface area product per unit volume of the tissue. So consider on the schematic on your left is a voxel of tissues, and what you see is the flow of blood, plasma, through the voxel of the tissues, and you see the volume of the plasma, VP, and the V is the volume of the extracellular or extravascular space. And what you see is the GAD, K trans represents the transfer constant of the GAD from the VP to the VE space, and the KEP represents the transfer constant back from the VE extracellular space into the vascular space. So this kind of modeling can be used to characterize the tumor perfusion. So as you see this example here, this is the pre-contrast space, this is the post-contrast space. You see a nice lesion, big lesion here, and then K-trans and KEP values can be computed from this. Again, this is even not perfect still. There is a lot of work going on in characterizing TOFS model, especially in body applications where we'll encounter a lot of motion artifacts. So another parameter, just you need to, it's important to note down, it's called an arterial input function, which is a known concentration of the GAD in the blood and plasma. If you know this value, the TOFS models can be used to characterize the tumor perfusion. So what is the challenge of using arterial input function? So how is it estimated? So arterial input function estimation relies on the vessels that coming into the next to the tumors. So if there is a nice leading artery coming in, then the tumor, this is an example of a sarcoma, that can be nicely, arterial input function can be estimated. However, it's going to be difficult in case of breast tumor, where we don't know whether, it's very hard to have a discernible feeding vessels coming into the breast tumor. So to overcome some of these setbacks while the TOFS model is being perfected, there are other semi-quantitative analysis methods that is being used in several literatures. Some of them is initial area under the curve, or looking at maximum signal intensity or time of peak enhancement, rate of peak enhancement, etc. So for some of the studies even show that the semi-quantitative analysis performs even better than the quantitative analysis. For this example, K-trans, KEP, and VE does not show much difference in the benign and malignant, unlike SER, which is a signal enhancement ratio, shows a good distinguish between malignant and benign lesions. Especially that is reflective in the higher sensitivity by achieving higher AUC curves through the semi-quantitative analysis. So again, there are several literatures. We recently published a review article reviewing several of these literatures as well, showing that semi-quantitative analysis equally good in distinguishing benign from malignant analysis. Basically, these are semi-quantitative analysis from the DCE images. So switching gears, so I explained the concepts a little bit, keeping in the breast cancer application as an examples. Now I'm going to switch gear and show some of our own finding on the kidney cancer, but application in terms of totally on the biological tissue characteristics as well as therapy response. So renal cell carcinoma is a type of kidney cancer. It arises from the proximal convoluted tubule, distal convoluted tubules, and it has a lot of histological subtypes. Clear cell is the most common subtypes, and frequently 70 to 80% of the tumors are clear cell, RCC. We normally call CC-RCC. It is basically occurs due to deletion of chromosome 3p and causes inactivation of the VHL genes, leads to a lot of other mutations in the genes. So there is a lot of efforts, work is going on to come up with targeted inhibitors for this RCC. The top of the line, the recent one that is FDA approved is the HIF2 inhibitor, because CC-RCC, there's a gene called HIF2, and the VHL and the VEGF axis is important. So, and then there are a lot of anti-angiogenic therapies, such as sunitinib, axitinib. Also, there are like immunotherapies like Nivo, AP, Pembro. However, all of these therapies, although they are effective in some patients, they are not curative. They causes resistance and also they causes progressive disease. So again, coming back to the lack of biopsy or the disadvantages of biopsy, especially in the malignant setting in this case, so the advantages of us using a DCE MRI or other perfusion MRI or other multiparametric MRI is to basically spatially and non-invasively do imaging characterization and to guide appropriate treatment strategies. So this is our typical DCE MRI protocol for a kidney study. We do pre-contrast phase. We do this for the kidney because of lot of motion. We do more of a 15-second acquisitions, then contrast and a free breathing for 15% acquisition, and a 5-second interval for the 3 contrast phases, and then a 15-second breath hold followed by a 15-second free breathing. So then we follow it with a corticomedullary phase, nephrographic phase, and a delayed phase. So basically, once they occur on the research protocol, basically we take these phases and then they match with the clinically acquired multiphasic image, and we label this as CM, which is a corticomedullary, ENG is early nephrographic, and NG is a late nephrographic phase. So I want to highlight this paper where Dr. Durgesh played a really vital role. It's a multidisciplinary project. A lot of expertise were needed for this project, from the imaging end, from the molecular biology end, from the pathology end. So I want to highlight this paper, and I'm going to show few data from this paper. This is the platform we developed, radiogenomic platform, where basically we have DCE images on pre-contrast with post-contrast phases. Before the surgery for the patients, these images are collected. We identify the regions of interest within the image, and then the percentage enhancement is calculated from this image. After this imaging section, the patient go into surgery. The tumors come out, and then the tumors are by half. One half of the tumors goes into pathology workflow, that is a clinical workflow. The other half of the tumor, we collect the tissues, we snap freeze them, we extract DNA, RNA, and protein, and then we do a transcriptome analysis, isoprot RNA-seq, and we get the normalized gene expression data, and then we correlate with percentage enhancement values. The next 3 slides, I'm just going to show you some data that supports the notion that the DC MRI enables prediction at the tissue level characteristic very non-invasively. Basically, this slide shows that in those tissue samples, the transcript levels of the primary kidney tumors is very distinct expression levels from the nearby renal parenchyma, and we got several differentially expressed genes. And what we did is that these genes, we correlated each one of these genes. It was about 20,000 genes that are total genes, and some of them were significantly correlated. But all these genes individually, we run a correlation, a Spearman correlation with the corticomedullary enhancement, ENG enhancement, and NG enhancement. So this is just a waterfall plot to represent that. So our final results show that the DCE MRI can identify within this tumor the regions that are angiogenic and inflammatory just based on how the DCE enhancement occurs. So this is also the semi-supervised heat map. As you can see, I can walk you through this. So this is the percentage DCE enhancement. You can see this, it's going up in the color curve in the green. That means higher the green, intensity of the green, higher the percentage enhancement. These are the very significant genes that pass the FDR cutoff. And as you can see, when the percentage enhancement is higher, it correlated to high expression of angiogenesis and vascular development genes. And then if the DC enhancement is lower, it correlated in inflammatory response gene. In other words, it's immune response genes. We always molecular finding with the CE-MRI data. We always validate again the histopathology on these corresponding tissues. Basically, this histopathology data shows that, as you could see, this is a stain. CD31 is a stain for vascular marker. In this patient, where there is a high enhancement, it's stained very high for vascular markers, very low for CD163, which is an immune marker, it's a macrophage marker. Whereas in the low enhancement, the macrophage marker is high. Basically, CE-MRI is able to predict on the tissue level whether the regions that are high enhancing are more angiogenic and the regions that are low enhancing are more inflammatory. So on the tissue level, then we extend it into clinical applicability in the metastatic CCRCC to look at the therapy response. Will CE-MRI able to predict response to therapy? So this is a retrospective IRB approved protocol. The inclusion criteria is we selected patients who received first-line monotherapy with either anti-angiogenic or immunotherapy, which is immuno-oncology therapies. And these patients' inclusion would be that the pre-treatment CE-MRI, they should have a pre-treatment CE-MRI, and the post-follow-up MR or CT in 2 to 3 months. And the percentage area enhancement is calculated as high and low based on the median cutoff across all lesions. Basically, we took about 19 patients, we selected about 19 patients, out of which 12 patients who has 22 lesions. That means one patient may have more than one lesion, who underwent anti-angiogenic, 7 patients underwent IO. Some of these lesions were further characterized by high enhancing or low enhancing. So this is an example of how the CE-MRI can identify phenotypes of response to therapy. This is one patient who underwent anti-angiogenic therapy, pazopanib. As you see, there were 3 lesions in this patient. 2 lesions were classified as low enhancing, 1 lesion were high enhancing. The lesions 1 and 3 classified as low enhancing showed a progressive disease, whereas the lesion that classified as high enhancing showed a decrease in the tumor. This is an example for low enhancing immunotherapy, patient treated with immunotherapy that shows that baseline MRI shows a very hyperintense, and then at 2 months follow-up, it still remained hyperintense but showed a partial response. Basically, this summarizes the data that shows this is a Kaplan-Meier plot representing the progression-free survival of all lesions. As you can see, the lesions that were classified as high enhancement from CE-MRI and went to anti-angiogenic therapy showed a really good progression-free survival. Comparatively, high enhancing lesion who went through IO, immunotherapy, did not show a good progression-free survival. So, some of the take-home points for today. In vivo perfusion measurements will enable tissue characterization, and DCMRI has emerged as a robust in vivo perfusion imaging method. There are different methodologies available for analysis. It can be qualitative, semi-quantitative, and quantitative. And also DCMRI is routinely used in various clinical applications. It is a cornerstone for breast cancer imaging, and it provides spatial mapping of molecular subtypes, and it is nicely correlated to the biopsy tissue level findings, and DCMRI identifies phenotypes of response to therapies in metastatic RCC. So I would like to acknowledge our Department of Radiology and UT Southwestern Medical Center, the Kidney Cancer Program, for their resources and the funding support. And I would like, I like to highlight this clinical review articles that we recently published. So I have a chapter in this. It's a nice collection of clinical reviews, review articles on MR perfusion. I think would be of interest for this audience. Thank you.
Thank you. Thank you, Dr. Uday Kumar, for very nice presentation. It was very informative. May I take some questions?
Okay, thank you.
May I take
Yeah, I'll be happy to
from
take
audience?
questions, yes.
Any question? Dr. Durgesh, Dr. Anit?
Hi, ma'am.
Yes, yeah, go ahead.
Even though it's a absolute quantified method, is there any quantified value for the K-trans, permeability for breast imaging? Quantified K-trans value, reference value?
Oh, reference value for K-trans. So first of all, so for the breast imaging, they are still working on this K-trans. Okay, the TOFS model is very complicated. I think Durgesh may be able to say that. This is modeling and, they are still working on the reference standard. These are all ongoing in the field.
One more question. You said it is based on the pharmacokinetic model. So any other relevant model is there for calculating, for qualitative analysis as such?
Quantitative analysis other than so far this TOPS model is a predominantly used model for quantitative analysis.
Thank you, Durga. So just to add to your answer, so there are a couple of models like TOFS model. There are some other variants like extended TOFS model, and there are so many other models are also there, but they are not being used because they have not been validated.
Yeah. So there are a lot of studies going on, but not all these models are having a strong foothold to enough validation to go into clinical.
Thank you so much. I know that shows your commitment also, Dr. Durga, for your time also. We wanted to have you in person. Maybe next time we'll call you here and along with Anant also. That would be more, kind of exciting session also. So I just wanted to ask like a short question, like, just tell us like what other areas you are working on, like new in kidney cancer also, or like you guys have also started doing ultra fast imaging also, or something like that. Thank you.
No, actually we have not gone in that direction. From my end, as far as I know, we have not gone in that direction yet.
And kidney cancer, any new stuff going on?
Kidney cancer, new stuff. So, well, again, there is a big question here, right? Whether our imaging method can spatially, within the same tumor, can show intratumoral heterogeneity. So when you are here, that was a big question we are trying to address. We are still trying to address the same question. So if the DCMRA is capable of showing at that microscopic resolution what we see in the biopsies, in terms of that. So that's still, we are working on it. We are collecting tumors in bigger sections and trying to do spatial profiling on them.
Got it.
I think, and more number of tumors and everything. So yeah, so let's see how it goes next year.
All right, got it. Thank you so much. Thank you so much for your time.
Thank you so much for having me, and thank you for the organizers and everybody listening to this. Thank you so much.
Thank you. Thank you, everyone. I think we have come to the end of this first session 1. Thank you.
Ladies and gentlemen, as we conclude this session, we extend our heartfelt felicitation to the chairpersons. For this, we would like to invite Professor Anit Parihar sir to felicitate Professor Hardeep Malhotra sir.
Professor Manoj Kumar sir to felicitate Professor Vishwajit Singh sir.
Professor Durgesh Kumar Dwivedi sir to Professor Himanshu Reddy sir.
Thank you, sir. Taking this journey of insight and exchange further, I would like to call upon the dais the chairperson for our next session on steady-state MRI and liver MRI. Please join your hands together to welcome Dr. Rajnikant Yadav, sir, Additional Professor, Department of Radiodiagnosis, SGPGI, Lucknow.
Professor Amit Nandadhar Dwivedi, sir, Professor and Head, Department of Radiodiagnosis, BHU.
Professor Gaurav Raj, sir, Professor and Head, Department of Radiodiagnosis, RML IMS, Lucknow.
Can we start the next session? Yeah. I'm most honored to invite now the next speaker of the day, that is Dr. Anit Parihar. We all know about him. He's the professor and head and the organizing main person of this workshop and symposium. So he's speaking on a very interesting topic and which is very, very pertinent for most students here, and most students find it very difficult to comprehend. And I thank the organizers for taking up such a interesting topic. Sir, the dais is yours.
Thank you, Dr. Gaurav, for the kind introduction. So I'll begin my talk. So what does steady state MRI means? There are a number of sequences in which normally what happens, the net magnetism vector is after the in position of the RF pulse is shifted from the Y plane into the x-axis. But here what is happening is there is no shifting of the net magnetism vector. The net magnetism vector remains in its own position, and it has got very interesting applications. So I will touch upon the physics behind it and a small bit on the applications of the steady state MRI sequence. This is very important because it is now has become a workhorse for many of the advanced imaging or body imaging you are doing. So if you see, the Stern-Gerlach experiment opened a very new field of magnetic MRI, where they brought about this that the protons have got a magnetic spin. The odd number of protons in molecules have got a magnetic spin. So what information these magnetic spins carry? They carry two types of information. One in frequency, and if you process this frequency information by a technique called Fourier transform, you do convolute the data, then you will get your images. The other thing what you can do is you can keep the frequency information and display it as a spectroscopy. The second information which you have got, a phase information, which we use for making our phase contrast MR such kind of images, or knowing out whether this is a calcification or a bleed. So here we are using the phase information. Also, we can do some tinkering in the readout direction, and where if you are not refocusing the whatever information is given, the net magnetism is going, and you are not trying to refocus the spins, then you get a signal which is called free induction decay. Clinically, most of the we are not using this free induction decay. What we are using is we are refocusing the pulses by a 180-degree RF pulse and using the information as an echo to form our spin echo images. The other important technique is the GRE images, where we are, instead of using a 180-degree RF pulse, we are reversing the polarity of our gradients to get the signal back, and that is called a gradient recalled echo. Or we can do some weighing. We can use different duration, strengths of the between the RF pulses, or we can some tinkering in the gradient images to get a different kind of aging. So most important is like T1 weighted images. We are using more of the longitudinal magnetic relaxation properties, or we are using more of the diffusing properties of T2, or we are using information from the number of protons, that is proton density. Or there are also sequences where we can add extra gradients like in diffusion weighted sensitized gradients to get our DWI imaging, or we can use the susceptibility information to get our SWI images. Other mechanism to produce a contrast without actually injecting contrast would be to use the IR pulses, where we are flipping the net potential vector into the negative domain and then allow it to relax, and then getting data at time points which we need, like in flare or in stir. Or we can use the magnetization transfer contrast, we are using in off residence pulses. The other would be used to use a motion information. Here we can get, if you are using the directional information, then you can get our top images, or a random information from the motion, then you can get your DWI images. So this is one of the simple way to say what are the different kinds of pulses we are generating. From here, one of the most important sequences would be a gradient recalled echo sequence. And this gradient recalled echo sequence is, initially it was a fast sequence and has got some properties of like a magnetic response to magnetic susceptibility, and we are using this as a workforce along with the spin echo sequence. Later on, we began to realize that we can use the transverse magnetization signal to our advantage, either by spoiling it or by refocusing it, and from there on, I think mostly after 2000s, we have begun to use more and more of the steady sequences. So here, what is a gradient recalled echo sequence? Gradient recalled echo sequence is a sequence where we give a RF pulse, but we don't need to flip the net magnetization vector towards from 90 degrees. We can flip it less than 90 degrees, though the RF angle is said to be alpha degree, which is less than 90 degree. And what we do is, we don't use a 180 degree second RF pulse to refocus the echoes. We just reverse the polarity and get the echo back. So this is a pulse example of pulse sequence. What you are doing, you have got a RF pulse which is not 90 degrees. That is the strength and duration not sufficient to flip the net magnetization vector through 90 degree. And we are using gradients in the slice selection direction, and during the collection of the echo, we are using the phase encoding will be done for this, and really in the frequency encoding direction, we try to get the signal by reversing the polarity. So there is also a transverse magnetization vector. What we can do, we can spoil any signal coming from that to get our T1 weighted sequences, or we can use the transverse magnetization information to get a T2 type of sequence. So the transverse magnetization gives more information about the T2, and if we are getting back most of the signal, then we get an image which is more of a T2 weighted. And you can see, then the modification which was done to produce steady state sequence in the GRE sequence was that there repeated trains of RF pulses were given. Repeated trains of RF pulses were sequenced, and after the second or third RF pulse, you began to get signals which we try to form a image. So let us see. So this is any diagram where the net magnetization vector you can see at the beginning is mostly directed into Y plane or Z plane here as shown. So this is mostly of the longitudinal magnetization. You give an RF pulse, you flip the net magnetization vector by some angle. Now if you see your mathematics on your vector diagram, this flipped net magnetization vector has got two components. One is in the Z direction, which is your longitudinal magnetization, and one in the transverse direction, which is the transverse magnetization. And after say 180 degree pulse, you can see it can rotate it through this directions. This is from E to F. What has happened is we have used a train of RF pulses, and we are flipping with each RF pulse. With each RF pulse, what we are doing is this sequence is being broken into this direction and is remaining here steady. It is remaining here steady. It is not moving. Normally what happens, it gets, the longitudinal gets back to Z direction, and the transverse is here, and then it gets diffused. But not, we are giving repeated pulses to maintain it into a steady state, this transverse magnetization. So how we do it? Again, see that GRE sequence diagram. So there was an RF1 pulse, then this is the RF2, that is alpha, and after RF2 we are collecting back our echoes. This echo can be collected into a number of ways, which will give you the different types of steady state sequence. So the first type is, you use extra steps like phase encoding. So what we are doing is, you are using another phase encoding steps in opposite polarity, and you are getting back, collecting back the signal. So what we are doing, remember what we are doing is, we are not using the extra step into the slice selection direction or the readout direction. And so what we got is a FID type of signal. We are getting a free induction decay. The signal has not been refocused. The signal has not been recollected. So you get a decay type, FID type of signals, which is also, if you see your books, you will get, it is labeled as S plus sometimes. Some time after that, if you try to collect your signal and you use extra gradients in the slice and frequency encoding direction, then you will get another signal, which is basically a, now what you have done here is, you have refocused your echoes in the frequency encoding direction, also in the slice direction. But the most important step is that you are refocusing your echoes in the frequency encoded direction, and you are using this second RF alpha pulse to refocus. So it becomes a very much a spin echo sequence. And what is the weighting? The weighting is, because you are collecting the transverse magnetization, it is a T2 weighted sequence. So now you get what kind of contrast will be generated. The first, the contrast is generated is a decay type of contrast, which is T2 star weighted, it is a FID. The second is, you are collecting back, refocusing the signal. So it will be a spin echo type of sequence, because this is being done for mostly for the transverse magnetization, it is a T2 weighted. Another thing you can do is, you can collect some vendors and some sequences are there, which collect both the sequences. So you get also a FID signal, and you get a spin echo sequence. They have what then they did? They have used to add these two signals and to produce one kind of signal, or they have used to use it arithmetically in the raw data domain and produce another type of signal. So this we have done. And the last is this, where they have done everything. They have used a phase encoding, opposite polarity phase encoding, they have done opposite polarity slice selection, and opposite polarity of frequency and direction. And that's what gives it, because the echo from all the directions is now refocused. What is get? You will get a balanced type of FFE. So you get balanced, all the echoes have been refocused in all the directions. You get a balanced FFE. So this is the physics behind, and just a summary. So you can do just after the RF2, if you are collecting back the signal, it is a FID signal. Some distance away from that, you are getting is a spin echo sequence, and you can also, for fully refocused steady state sequence, you can get both a FID and a spin echo sequence. So this is your physics behind it. So what we are doing, again, for a FID sequence, what we have done, you have used an extra phase encoding gradient with opposite polarity, and you have got a T2 star weighted sequence. Because you didn't refocus the echoes, it is a, where dephasing is still going on, and it is very susceptibility to inhomogeneity. It is a T2 star weighted image. It is T2, so it will, the CSF will be bright. Because you have not refocused, it is very sensitive to motion. The blood vessels where there are flowing spins, it will appear black. But still here what you will get is a gray-white matter contrast, and gray matter white differentiation will be possible. The second collection was of spin echo type of sequence, where they reverse the gradients in the both the slice selection and the readout gradient. Now what we have done, it is appearing somewhat later in the course of disease, so T becomes large, it means larger than the TR. And so only tissues with a large T will be able to get back the signal, like the CSF or the fluid. It is a very heavily T2 weighted kind of sequence. It is motion sensitivity, and there is now only T2 signal is being returned, T1 is already dead, so the gray-white matter differentiation is not possible. In fully refocused signals, what is happening? you are getting back the echoes from all the phase, all the directions. So what happens, even the blood is bright here, because you are trying to refocus every kind of spin. So even the blood will be, it is a white blood, non-contrast white blood technique. And here the signal depends upon T2 by T1, and so only fat and water are able to give the signal. It is motion insensitive because you are refocusing all the gradients, all the types of gradients you are refocusing, so it is motion insensitive. So the advantage, what are the advantage of steady state sequence? Because it is based on a gradient GRE sequence, it is fast. It is a GRE phase sequence, so it will be fast. You are collecting back by application of second RF2, you are collecting back the signal, you are using the whatever information there to the fullest. So as signal is very high, SNR is very high. It has got high speed again because it is GRE sequence, and with the amount of the temporal resolution you are having, you can even visualize physiological motion. So it is very good for where there motion is a big issue, like heart. If you are trying to image heart, temporal resolution is very important, so it becomes very good for temporal. You want to image fetus is always moving, it becomes a very good sequence. And because it is very T2 weighted images, so CSF, myelogram, etc. will be very easy to image. And at least the balanced FFP sequences are very insensitive to motions. So this is a summary slide where what you have done. So what I told you, GRE based sequences have got two types of signals can be got. One is by spoiling the transmutation. So you get here your T1 weighted sequence, and by recollecting you can get a FID weight sequence, which we are mostly using for cartilage and meniscal evaluation, or we can use a T2 weighted image like CSF flow studies, or a balanced study where motion is not a problem for cardiac, abdominal and fetal imaging. Just a few images, just names of the few of the sequences given by different vendors. So for a T1 weighted spoiled gradient sequence, your Siemens calls it flash, GE calls it SPGR, MPGR, and Philips calls it T1 free-fold echo. For a post-excitation, that is spin echo type of sequence, the Siemens called is free induction in steady precision, FISP. Then GE has got a GRASS, and Philips has got FFE. For Siemens, pre-excitation refocus sequence is inverse of FISP. So because they have needed PSIF. And in G, which we have got a machine here, on our machine it is called SSFP, steady state. So it is a steady state sequence, so steady state free precision. For Philips, this is a very heavy, they have named it because it is a very heavily T2 weighted sequence, they have named it T2 FFP. And if you have got everything refocused, so Siemens is saying it is a true FISP. G has a name of Fiesta, and Philips has got balanced. We have balanced everything, so it is a balanced FFP. So this is where they have named their different steady state sequences. So just to go through a few images, as I told you, so FID based sequences have got a good amount of the start, that is the susceptibility, so you can use it for detecting hemorrhages, and also for MSK for evaluation of cartilage and meniscus, because they can give you information about water, where cartilage is there, some water is there, and the bone, there is, it appears very dark. So it is very good for along the borders of meniscus and cartilages. And the refocus sequences are good for CSF, and like here in the I've shown you, for heart, for every aspects of cardiac imaging it is useful. If you want to see the chambers, the walls, it is good, and especially it is good for the congenital heart disease, where you want to see the shunts, or you want to measure the velocity across the shunts, or you want to see the great vessels coming out and they are malpositioned. It is also good for valvular heart disease. It can show you the thin, because it has got very good contrast. So even with a lot of blood around, a small valve is seen, even though it is very thin in thickness, and you can see whether it is stenosed or not stenosed. You can, because it is fast sequence, you can see the movement of the valves, and you can measure it, so you can use it for scene imaging. You can measure the velocities across the valvular stenosis. For cardiomyopathies, again, it is good contrast, means the muscles appear very black, and by giving contrast or something, you can see that there is any abnormal enhancement, late gadolinium enhancement or something like that. So it is good for cardiomyopathies, and you can see the thin, even a thin pericardium you can see because of high contrast with adjacent fluid. So it is a good for differentiating between constructive pericarditis and restrictive cardiomyopathy. It is good for evaluating ventricle fraction, as I told you. You can see the chambers and you can see the velocities, and myocardial viability by seeing even a small bit of contrast enhancement of gadolinium, late gadolinium enhancement you can see, and see whether it is a myocardial viability is there or there is fibrosis which is taking up contrast lately. So just an example, we have seen a kind of image. Okay, it is not playing. Again, so this is just so amount. You see, you can see the amount of contrast. You can see the walls are seen very clearly, and the blood is seen clearly. There is no artifact at the borders of the two different kind of tissues. Abdominal imaging, again, because it is got a good high temporal resolution, good contrast, and also if you are using the fully refocused, you will get your blood as white. So for example, here you can see the portal vein. If it was thrombosed, you will see the thrombus lying within the portal vein. And for fetal imaging also, because it is moving, see the great, like even it is fetus, we are using a sequences which we cannot devote a lot of time, we cannot devote a lot of necks. Even then, it gives a very good contrast to evaluate the ventricles, the gray matter, or anything structures around it. And it is also good for interventional MRI, where you need to image because it has got, if you are using a susceptibility sequence like T2 weighted, then you show your needles, etc. And it is physiological motion, movement, it is high, it has got high speed. So it is good for interventional procedures, and also to see while we are ablating the tumors. And there are some other modifications also have come up, like CIS is a famous sequence, you should know about it. So the Fiesta, the fully balanced sequence, another train has been added. In fully balanced sequence, they are using RF alpha in the one direction, opposite polarity RF alpha negative for the first train, RF train, and then they use another RF train which has got a consistent flip angle of alpha, and they have added that sequence together to produce a constructive interference in steady state, which is called the Fiesta C, and which we employ a lot of in our imaging of the nerves passing through the systems. Whenever we have to evaluate for trigeminal neuralgia or any nerve problem, cranial nerves, we use Fiesta C sequence. So this is a modification of your fully balanced sequence. You see the optic nerve sheath you want to see, or you want to see ventricles, or you have created a ventriculostomy, third ventriculostomy, and you want to see the movement of the CSF through that, whether there is already it has the adhesions have closed the ventriculostomy, you can assess by a Fiesta C sequence. And there is another modification which is called the double echo steady state sequence, where the data from the FID and the SE sequence is used together to give you in the image direction, and it is basically used for cartilage and meniscus. Then also you can use some modification in the readout direction, like EPI type of sequence, or you can use different type of trajectory, radial, etc. to create new sequence, like here one of the sequences is the spider sequence. So to conclude, steady state sequences provide high quality images with a very good SNR, with a very good temporal resolution, and they have become the workhorse for body imaging, like in abdominal imaging or fetal imaging, or even if you want to CSF, myelogram or interventional procedures. Thank you. These are my references, and Dr. Sir. Thank you. Any questions?
Thank you, sir, for that excellent presentation. You showed a nice depiction of when to use what steady state sequence, particularly the Fiesta sequence, which is a fully refocused steady state sequence. So I want to know whether you're using a lot of this in your enterographies and in abdominal imaging, whether you're using this in enterography.
So right now we are using, actually in India, one of the common problems is tuberculosis. So in tuberculosis we are, or the other differential would be a Crohn's disease. So we are also very, we want to know about the activity of the lesion. and enhancement and the lymph node status. So now, right now, we are mostly using for enterographic T1 weight sequences are using with negative contrast.
Okay, so but this will actually usually tend to help whenever you are trying to see an obstruction. So using this sequence, you can try to see whether there is a proper obstruction or not. Usually, you can use the cine mode. The
Yes,
cine
sir.
mode is very well used on these kind of
Yes.
sequences, like you're
Yes.
studying for the heart.
So again, the
And
advantage is
same
good
thing can
signal
be used
and
in,
motions.
for
We are using
studying
it.
the
Huh.
bowel also.
Ball also.
Are there any more questions from the audience?
Just adding to that, Rajnikant, we are using, trying to use rather MR enterography for Crohn's disease and ulcerative colitis because you do not want to radiate the young patients who keep coming for Crohn's disease. And MR enterography is the investigation of choice, and when you have these kinds of Fiesta Cine mode, you can actually differentiate very small strictures from peristalsis, and it becomes very, very useful.
Also on, I think we must be using these on deficograms.
Huh.
On deficogram also, I think this is a
It
very
is
good
cine-based
sequence
sequence.
for
It
the,
is based sequence.
and
yes.
it gives a very good contrast, and I mean, in about 180 seconds or something, you are able to do an entire deficogram. And
Yes, sir. And that is the time usually that it takes for the process, certification process, squeeze or stress, something like that we can use.
Thank you. Any more questions? Okay, thank you, Dr. Anil.
Thank you.
We'll,
Thank you.
Call on the next speaker.
So now it's my privilege to invite our next speaker, Dr. Bhanupriya. Some of her credentials, she is currently working as assistant professor in RML Lucknow. So credentials of Dr. Bhanupriya is that she is neuroradiology fellowship at NIMHANS, recipient of Kishore Tawri Gold Medal, Dr. VP Lakhanpal Gold Medal, and she has been a regular contributor in ECR and RSNA. She has to her credit some 18 original research papers, and she has conducted many workshops and invited lectures. So I would like to invite Dr. Bhanupriya. She'll be delivering her lecture on liver MR methods.
Thank you so much, sir, for the kind introduction. Very good morning to respected seniors on and off the dais. And let's start with our topic today, liver MRI methods and its application. So this is just a diagrammatic graphic representation of how the T1 signal relaxation time, how it increases with time, and it is seen as signal in pre and post contrast of various lesions. Like for instance, the first column would show a pre-contrast hemangioma with post-contrast peripheral puddling, and how different lesions on post-contrast alter the T1 relaxation time differently. So this is as compared to metastasis, where it would appear as hypointense on T1 and would show differential enhancement predominantly peripherally. This second image shows how the T2 relaxation time is altered, and it is shown differently in different liver lesions. So the things to consider overall while starting to image the liver is the patient that is walking in, is it symptomatic or is it incidentally detected? Next comes the history of hepatitis, if there is any ongoing history or any known history of extrahepatic malignant tumor. Then comes what are the liver function tests, and is the patient a known cirrhotic or non-cirrhotic. The common lesions that we encounter, we well know, are the benign lesions that include hemangioma, focal nodular hyperplasia, adenoma, and cysts. The malignant ones can be hepatocellular carcinoma, fibrolamellar carcinoma, cholangiocarcinoma, and metastasis. So the circumstances in which we pick up lesion, if it's incidental in a non-cirrhotic background, more commonly it would be a benign lesion like hemangioma, focal nodular hyperplasia, or adenoma. If incidentally we pick up a malignant lesion, more likely it would be metastasis or fibrolamellar carcinoma. In second scenario, in symptomatic patient who's non-cirrhotic, The non-cirrhotic malignant lesions are again METs or FLC, and in background of cirrhosis and chronic liver disease, the common lesions that we encounter: hepatocellular carcinoma, dysplastic nodule, and regenerative nodules. So this is a diagram showing the dual nature of blood supply in the liver, where the hepatic artery constitutes to approximately 40% and portal vein to approximately 60% of the liver blood supply. Now we'd be seeing the imaging appearances on MR. So for a few words about HCC is that it's the fifth most common tumor and rarely occurs before 40, and peak incidence is around 70. Male to female ratio is 4:1, and cirrhosis is a very strong predisposing factor. So what happens basically is most of the hepatocellular carcinoma develop as a multi-step progression from a low-grade dysplastic nodule to a high-grade dysplastic nodule to dysplastic nodule with a focus of hepatocellular carcinoma, and finally a overt HCC. This diagram shows the same progression of the disease process. The thing to note here is that as the disease progresses from low grade to high grade dysplastic nodule, its blood supply alters. So for regenerative nodule and low grade dysplastic nodule, the blood supply is still predominantly from the portal vein. As it becomes a high grade dysplastic nodule, small HCC and frank HCC, it takes up more and more blood supply from the hepatic artery with the neovascularization. This slide shows the imaging appearance of regenerative nodules. The non-contrast image is of importance here, and it's predominantly well-demarcated nodular. So that's why, because they have a predominant surrounding septa to it, and they mostly contain metal deposition like copper or iron. So they are basically siderotic nodules. They have a variable appearance on T1, may appear hyper depending on the metal content, and are typically hypo on T2, and they bloom on gradient echo images. This image again shows the various phasic acquisition of liver MR. So this is a pre-contrast image that's predominantly hypo, well defined with some hyper intensity, might be bleed, might be proteinaceous content, and on arterial phase how it's comparatively homogeneously enhancing with some non-enhancing internal areas, and then sequential washout on portovenous and delayed phases. So this was a HCC known case. Cirrhotic liver are characterized by irreversible remodeling of the hepatic architecture that is included by bridging fibrosis and spectrum of the nodules that we just discussed. The ability to differentiate the malignant from benign nodules is our aim with imaging. Regenerative nodule and low-grade dysplastic nodules have predominantly portal blood supply, and high-grade dysplastic nodules and HCCs have more and more neo-arterialization. So high-grade dysplastic nodules and early HCC can be hypovascular because still the newer arteries are being formed. Early small HCCs are usually composed of well-differentiated hepatocytes, and the challenging diagnosis is on basis of dynamic imaging, and biopsy results are confirmatory. Small HCC nodules demonstrate hypervascularity as now the frank neovascularization has occurred, and they show classical washout on portovenous and delayed phases. So this is a recapitulation of the above discussed findings. And on post-contrast image acquisition, we can acquire dynamic images. There are some hepatobiliary specific excretory contrast material, and another important is superparamagnetic iron oxide contrast agents. So again, regenerative nodules are basically cirrhotic nodules, and they are because of the continuous injury of the liver parenchyma, and they appear as innumerable benign nodules, and basically on post-contrast they show as much or slightly less enhancement as compared to the normal parenchyma, and they have normal hepatocytes and normal phagocytic functions, and they enhance to the same degree on delayed T1 images in SPIO or superparamagnetic iron oxide images. So this again, this MR image, here it shows the T1 isointense nodule, which is comparatively again isointense and showing equal enhancement as compared to the background liver parenchyma. The other type of regenerative nodules can be steatotic and siderotic. Steatotic is classically with more and more fat deposition, so that would appear classically more hyperintense on T1, and they would get suppressed on in phase and on opposed phased images as compared to in phase images. Now this image here, it shows the siderotic nodules. So they are classically, they show the loss of signal on T1, and they can sometimes appear more hypointense on in phase images. In this case, we are also seeing ascites in the background. Low grade dysplastic nodule. So histologically, the low grade is characterized by preserved hepatic architecture. Low grade cytologic atapia is seen. What it means is there are varying number of portal tracts and inconsistent increase in the number of unpaired arterioles. So they have malignant potential but comparatively lower. So how are they seen? They are similar to regenerative nodules on imaging, and the low grade dysplastic nodules have variable signal intensity on T1 depending on the content, and iso to hypo on T2, and they demonstrate enhancement similar to that of the background liver parenchyma. High grade histologically are more show more atypia, and basically they are pre-malignant, and they are difficult to differentiate between from high grade dysplastic nodule and well differentiated hepatocellular carcinoma. So there's reduced number of portal tracts, more progressive sinusoidal capillarization, and increased number of unpaired arteries. On MRI, they demonstrate variable signal intensity on T1 depending on their content, and iso to hypo on T2. So this here again we are seeing just 1 second. So we are seeing this axial T1 and T2. Here we are seeing iso in, comparatively defined but iso-intense lesion that is showing enhancement on arterial phase and washout on delayed phases. So this is again, this was a high-grade dysplastic nodule that was hypo-intense on T2, and on T1 it was hyper-intense, and it was enhancing similar to the background liver parenchyma, and on equilibrium phase also there was no frank washout. So this was high-grade dysplastic nodule. Now nodule in nodule appearance. A dysplastic nodule may harbor a focus of hepatocellular carcinoma. At T2 weighted MR images, such nodules appear hypointense with the same degree of enhancement as the surrounding parenchyma, and they show a high signal intensity foci on arterial enhancement. This finding is known as nodule in nodule appearance, and it is comparatively uncommon and seen in approximately 6% of the dysplastic nodules. So here what we are seeing, a comparatively hypointense nodule on T2 image that is comparatively hyperintense on T1. On post contrast on arterial phase, the anterior portion of the nodule is showing more enhancement as compared to the rest of the nodule, and on delayed phases we are seeing that there's preferential washout of this arterial enhancing foci within the nodule. So this was the harbor of HCC within a whole dysplastic nodule, giving nodule in nodule appearance. Now the smaller HCCs, they are defined by size as less than 2 centimeters, and they are divided into early small HCC, which are indistinct, and they have a ill-defined margin, or a progressed small HCC that are comparatively well-defined. So histologically, early HCCs are well-defined with frank neoplastic cells, and the portal tracts may be present, and it is difficult to differentiate their margin with surrounding parenchyma histologically. The invasion of portal tracts is frequently visible, and the finding helps in diagnosing HCC from high-grade dysplastic nodules. However, in small HCCs, microvascular infiltration is less common. That's why 5-year survival rate is approximately 89%, which is comparatively good. So the imaging finding in early HCC demonstrate a arterial hypervascularity, and they may be iso to hypointense on arterial phase if there is still not as much neovascularization, and they show washout and appear hypointense on portal phase. Hypovascularity is by loss or because of the loss of portal vascularization and still insufficient development of unpaired arteries. So on hepatobiliary MR phases, liver parenchyma contains functioning hepatocytes and they demonstrate enhancement. HCC contains malfunctioning hepatocytes, so they appear less enhancing as compared to the background parenchyma on hepatobiliary contrast agents. So close follow-up is recommended in such patients, and they may progress to larger HCC if they follow the dedifferentiation pathway. Microscopic vessel infiltration is present in nearly 27% of the cases in larger HCC, and the tumor infiltration into the portal vein and microvessels decrease the 5-year survival rate to approximately 50%. Now the progressed HCC, these lesions are comparatively well defined, and they are round to oval with variable signal intensity on T1 and hyperintense on T2. Most nodular HCCs have typical finding of administration of contrast that show arterial hyperenhancement with washout on delayed phases. Here we are seeing small HCC. So that is so that is comparatively well defined, and isointense on T2, hypointense on T1, that is showing enhancement, hyperenhancement on arterial phases and washout on portovenous phase. Large HCC, so that's larger than 2 centimeter, and they appear moderately hyperintense on T2 with arterial enhancement and again washout as we discussed, and the atypical manifestations are uncommon, and how they commonly present is heterogeneous or mosaic kind of intensity on plain T2 images with variable post-contrast enhancement that could be secondary to the ongoing central necrosis. So here again we are seeing enhancement, frank enhancement on arterial phase with washout on portovenous phase, and giving a pseudocapsule because of the peripheral enhancement of the normal liver in the delayed phases. Now coming to few benign liver lesions that we encounter, hepatic hemangioma. So basically it's a benign vascular lesion of the liver, and it's one of the commonest to encounter, and is on autopsy found to be in approximately 1 to 20% of the patients, and is picked up in 3rd to 5th decade of life, and it is thought to arise from the congenital hematomas, that is abnormal growth of normal tissue, and these are dilated blood vessels. So this is histologic picture that is showing endothelium lined dilated vascular spaces marked by fibrous septa. So how they show the pattern of enhancement on imaging. So on non-contrast image, hemangiomas just show a well-defined margin. Then on arterial phase, they show peripheral puddling, and they show then sequential centripetal fill-in of contrast on portovenous and delayed phases, means from outside to in it fills up the contrast, and so that pattern is followed on CT as well as MRI, and on MRI it appears well defined and hypointense on T1 and markedly hyperintense on T2. So this is the image that is showing comparatively well-defined margins on T1, and that is showing this peripheral puddling with sequential fill-in of contrast on delayed phase. This is a large lesion that was proven to be hemangioma. So any lesion that outgrows and becomes very large, then the imaging finding of different lesions overlap. So basically the gold standard would be histopath in that scenario. So this is a large exophytic lesion, and it was showing, see how it's showing enhancement, peripheral puddling, and then centripetal little fill-in of contrast. There are some non-enhancing areas also, but that's because any large lesion would eventually outgrow its blood supply. Now coming to next lesion, focal nodular hyperplasia. It's basically a benign nodule arising in the liver parenchyma and is the second most common benign hepatic lesion. It occurs commonly in young to middle-aged women, and the male to female ratio is 5:17. Usually it is asymptomatic, may cause minimal pain, and the response to it is basically response of liver parenchyma to vascular malformation or portal duct injury. That's the proposed hypothesis for its formation. So FNH, so this is a gross specimen and a histologic picture of how it looks. What happens is, so there's hyperplasia with this central stellate scar that radiates to the periphery and gives a nodular-like pattern. The ductal differentiation and malformed vessels are also seen. Rarely it can be encapsulated and pedunculated. Biliary structures may or may not be involved, and then due to mass effect it could cause maybe something in the biliary tree. Now on CT, how does FNH look? Basically the central scar is its defining feature. It shows brisk homogeneous enhancement, is comparatively well defined and comparatively homogeneously enhancing, and the hypodense band that arise from the central scar are seen radiating from it, and on delayed phases this central scar remains hyperattenuating and there's no peripheral enhancement in this, as in contrast to the HCC. So here again we are seeing a kind of central scar can sometimes also be appreciated on non-contrast images. On arterial phase, a brisk homogeneous enhancement is seen, which eventually washes off, but then on arterial phase the central scar doesn't enhance, and as the lesion washes off, the central scar enhances on delayed phases. This same enhancement pattern is also followed on MRI. So here again we are seeing this comparatively iso-intense nodule in the right lobe of liver, and on a delayed enhancement we are seeing this enhancing central scar. So this was a case of FNH. Similar, another case of FNH that was showing a brisk homogeneous enhancement with a non-enhancing central scar and comparatively, these thin black lines radiating the fibrous septa, and that's showing washout, and then on delayed it's showing enhancement of that non-enhancing central scar. Sometimes it can have atypical presentation, like we were discussing, any lesion that outgrows and is very large, so then biopsy remains the gold standard. Now hepatic adenoma, it's again a comparatively rarer tumor and is seen more commonly in women from 20 to 40 age group and is associated with intake of oral contraceptive, can be solitary. It is associated with upper quadrant pain in some cases when it is large enough to stretch the liver capsule. There's obvious risk of rupture, hemorrhage or malignant transformation within hepatic adenoma as well, although it's a benign tumor. There's classically no infiltration of the portal tract, central veins or bile ducts, and surgical resection is generally advised. So on ultrasound, it can have a non-specific, may appear a hyper-echoic. On CT, it is well circumscribed without lobulation. It appears heterogeneous because of the mixed component, because it can internally have fat, hemorrhage as well as necrosis. And diffuse heterogeneous arterial enhancement is seen on delayed images. MR follows the same enhancement pattern, and on T1, because of fat, hemorrhage and necrosis of varying degrees, it can be iso-intense to hyper-intense, and on T2 it is hyper-intense. So this is a case of hepatic adenoma that is showing, that is comparatively well defined, centrally non-enhancing, and showing enhancement on CT. And this is a exophytic hepatic adenoma in the right lobe that is comparatively well defined, non-nodular like, and it is showing homogeneous, comparatively homogeneous enhancement, although it is intrinsically heterogeneous lesion on T1 itself. Now coming on to another application of liver MRI, that is MRI elastography. That basically shows how much stiff the liver tissue is, and if there is any lesion, any difference in the stiffness of the lesion as compared to the normal hepatic parenchyma. So it's what it needs is a mechanical driver that is put typically in the xiphisternum level, because that is where the largest cross-section area of liver can be directly put in close contact to the passive driver. So this generates a good image. This is how it looks. There's an active driver within the MRI room, and this basically this generates the vibration that is passed on via this plastic tube, and through this passive driver it is transmitted into the xiphisternum and the body of the patient. So MR elastography is performed with 3 steps. So the first is the source vibration and how these vibrations are transmitted by the driver that is put on the body of the patient. Then next is this special MR elastography pulse sequence, where we see synchronized motion, and these wavelength or wave-like image is generated, and this this is the spectra, with this yellow and orange being the more hard end of the spectrum and blue being the less hard. So this is a wavelength image that is generated after the pulse is transmitted through the mechanical driver, and then using these two images, the elastogram images are superimposed and generated. This again shows the same 3-step process of image generation in MR elastography. Thing to note is the peripheral portion of the liver can be affected by respiration. So that is generally even the wave image is not very well formed, just done in this. So the elastography is also not that precise peripherally. To map how we can do is we can geographically outline the area of interest, or in a circular fashion. What we have to do is we have to spare the periphery of the liver capsule, and we have to spare the large vessels to generate a good signal. One thing to note is that elastography or the stiffness reading is not very well affected by contrast. So in this fibrosis in a background of hepatitis B, the same stiffness is seen on pre-contrast and post-contrast MR elastography images, and this shows a sequential increase in the stiffness in with increasing fibrosis in liver elastography. Thank you.
Thank you very much, Dr. Singh. It was a very nice lecture on a very important topic of liver MR methods. Any question from the audience? Since it's a very pertinent for the residents to know about liver MR and the upcoming advances. So could you please elaborate something about what are the advantage of liver MR over this triple phase CT in characterizing LIRADS in cases of hepatocellular tumor, if there's any distinct advantage in equivocal cases?
Yes, sir. So basically these cases are to be followed up. So for the obvious reason of decrease in the radiation dose, MR would obviously be preferred. Then, sir, while like we discussed, differentiating the regenerative nodules, low-grade dysplastic and high-grade dysplastic nodules, their intensity and their enhancement patterns are very well better appreciated on triple phase MR images.
So that is very important for the residents to note that how in equivocal cases you can better utilize the liver MR over triple phase CT. So if there are any more questions from the audience?
Doing a contrast CT, contrast MRI, especially the triple phase MRI, is time consuming also, and most of the time we get hemangiomas and those things. So how good is multi-T sequence for the hemangioma, and just can we do away with the contrast in most of the cases? So how effective only the routine T1, T2 sequence, multi-sequences, or do we have to give a contrast in most cases?
No, sir, if the findings are consistent and if it's not very large, mimicking other features of other lesions, then we can very well define it on non-contrast images also, non-contrast MR also.
So multi-T sequence is good enough
yes, sir.
for most of the cases.
Yes.
And in fact, most of the benign lesions can be differentiated on
Yes,
the
sir.
T1, T2 basis.
Yes.
So if there are no more questions, we'll close the session then.
Thank you so much.
What an informative time we all had. Thanks to our beloved teachers.
Now let us invite the chairperson to felicitate the speaker on the dais. I request everyone to give them a warm round of applause. I invite Professor Anit Parihar sir to kindly come on the dais. I invite all the chairpersons to felicitate the speakers on the dais. I invite Professor Anit Parihar sir to kindly come.
Now I would like to invite Dr. Bhanupriya Singh ma'am. We extend our deepest gratitude to the chairpersons for steering the session with grace. For that, I would like to invite Professor Manoj Kumar sir to felicitate Dr. Rajnikant Yadav sir.
Professor Durgesh Trivedi sir to felicitate Professor Amit Nandandhar Trivedi sir.
Dr. Siddharth Mishra sir to felicitate Professor Gaurav Raj sir.
There is an announcement to make. A quiz session for residents will be held after lunch, so respective colleges please form a team of 4 and provide your name to Dr. Shakib and Dr. Nitin.
Now I would like to welcome our esteemed chairpersons, Professor Kshitish Srivastava sir, Professor, Department of Neurosurgery, KGMU, Dr. Praveen Sharma sir, Additional Professor, Department of Neurology, KGMU,
Professor Vishali Upadhyay ma'am, Senior Consultant, Department of Radiodiagnosis, Vivekanand
Dr. Neeraj Kumar, sir, Additional Professor, Department of Neurology, KGMU.
And Professor Shailendra Tripathi, sir, Professor, Department of Geriatric Mental Health, KGMU, to please come on the dais and initiate our third session.
So to begin with the next session, I'd like to invite Colonel Dr. N.K. Jain, who will be delivering a session on basics physics of MRI and pulse sequences. And I hope that for all the residents present here, you should all pay attention because that will give you a better understanding of MR on a day-to-day basis.
Talk is basically meant for residents and medical students. So it's a very basic talk. Since morning we are having a very good discussion on advanced MRI techniques. We have discussed about DCE, we have discussed about K-trans, and we have discussed about a very complex talk on steady state MR. But this will be a basic introduction of the principles of NMR, how we use it to generate basic tissue contrast, and how we go about localization. So how many of in this hall are basically residents and medical students? All of you, so this talk is basically directed to you. So outline of this talk is, first we'll discuss basic physics behind the MRI. What is the basis of generation of an MR signal? How do we get onto the so-called tissue contrast? And once we get the tissue contrast, how we go about a spatial localization of this signal in order to get a meaningful image. And finally, we'll discuss briefly about the pulse sequences. So if you have to summarize the entire physics or principle of MRI or image generation in one single word, that is electromagnetism. The basic principle is electromagnetism, that is any charge, a moving charge or a moving electric field will induce a magnetic field and vice versa. Any changing magnetic field will induce a electric charge. So what here in MRI, we are using the same principle to measure the electric charge associated with movement of hydrogen protons. Now will come that why we are specifically using hydrogen protons. So unless until specified for certain special sequences or certain special types of spectroscopy or other application, MRI, unless otherwise specified, mostly deals with imaging of hydrogen in the body. Now hydrogen has got an unpaired proton. This unpaired proton, when it precesses, it acts like a tiny magnet. So this is an electromagnet which in all practical principles will resemble like a tiny bar magnet only. So hydrogen we are using because 80% of all the cells in the body are basically hydrogen atoms. It has got an unpaired protons and it's got a nuclear spin. So that is why the hydrogen is the atom which is predominantly used for MR imaging. Now what happens in a normal state when we use, when there is no external magnetic field, all these hydrogen atoms are randomly oriented. So these spins basically cancel out each other. Whenever an external magnetic field is applied, for example here, if you see there is an external magnetic field V0 applied, you can, and the patient is placed in this direction. So what happens, all the protons which are there in the body, they align themselves in this direction of the external magnetic field. Now, most of the protons will be in a low energy state, so they will align in the direction of the external magnetic field, while there will be certain protons which are in a higher energy state, they will align against the direction of the external magnetic field. Now, both these opposite fields cancel out each other, so ultimately what we have, we'll have a net field which is always in direction of the external magnetic field. So once you place a body which is to be imaged inside an external magnetic field, the body itself starts behaving like a magnet and it generates its own magnetic field. And this magnetic field is in direction of the external magnetic field. And this is known as a net magnetization vector. Now there are two things. One, we have just spoken about the net magnetization vector or protons aligning in a particular direction. But parallelly, there is another thing which is also happening, a phenomena which is known as a precession. Now what exactly is the precession is that these electromagnets or tinily these protons are like a spin. They are wobbling continuously and this wobble is taking along the direction of a net magnetic vector. And the path which takes these protons take is known as a precessional path. Now, till now, we are very clear that we have placed the body inside the magnetic field. There was an external magnetic field. Some protons aligned against it, some along the direction, the opposing one cancelled out. We had a net magnetic field, and this net magnetic field is also precessing along the direction of the external field. Now, at what frequency this precession is taking, this will be based on a very simple equation which is known as a Larmor frequency and basically depends on the strength of the external magnetic field. So this Larmor frequency defines as to the precessional frequency or the frequency at which these protons are rotating, spinning or precessing. This depends upon the strength of the external magnetic field. So moment you increase the field strength, this precessional frequency will increase. And also another factor which is there is a gyromagnetic ratio. Now this gyromagnetic ratio is basically constant for different kind of nuclei or different kind of spins. So protons, we have a different kind of gyromagnetic ratio. Now, we have got this precessional frequency, they are precessing. Now we need to measure these frequency in order to get a meaningful MR signal. So for that we have to divide a coordinate system. So what's happened out here is, this is the direction of our net magnetization vector. We have the protons which have directed in a particular this thing. So this particular thing, the direction of the external magnetic field is conventionally followed as a Z-axis. So Z-axis is the direction of the external magnetic field. But there are two other axes also. So one we can say X-axis, Y-axis. So there are three axes, so we have to get these three coordinates in order to get a meaningful MR signal. So what happens is, this magnetic field which we have created in the body, we want to measure that. But when we compare it to the external magnetic field B0, it is a very minuscule or a very, very tiny, just like getting 2 buckets of water from a vast pond. So it is very difficult to measure this signal unless until we flip the signal into some other plane, where this particular net magnetization vector is what we are planning to measure. So we can get a meaningful measure of that. So for that very purpose, so that we are able to measure these changes in the net magnetization vector, we give a source of external energy now, which is also known as a radio frequency pulse. The role of this radio frequency pulse is to flip the net magnetization vector in any other plane which is against the direction of the B0, where we can actually measure these particular frequency. Now, in order that RF pulse be able to transfer energy to this precessing photons, now we have to understand another very basic principle known as a resonance. So resonance is basically any two systems can transfer energy amongst themselves only if they are precessing or moving at a similar field strength. So once your RF pulse has got a frequency which is similar or which is matching to that of the precessional frequency of the protons, transfer of energy takes place. Once those precessing protons receive energy, they are flipped into another plane. So essentially, RF pulse does two things. So one, as we have discussed previously, it reduces the longitudinal magnetization. So on one hand coordinate, we are saying the longitudinal magnetization is flipped to a transverse plane. But actually this is not what is happening. What is happening is, moment you give the RF energy, many of the low energy protons are now gaining energy and they start aligning against the direction of external magnetic field. So they start cancelling out each other. So net result is that your longitudinal magnetization is reducing. But at the same time, simultaneously, a very important phenomena is also occurring in the transverse plane. See, there are multiple protons, multiple innumerable protons. All of them are processing at a different phases. Like you have a watch, multiple, say 10 watches are there. One is at 10 o'clock, one is at 2 o'clock, one is at 3 o'clock. At a single point of time, all of them have got a different phases. So this RF pulse does another thing in a transverse plane, that it brings all these transverse, phase. It brings the phase in one direction, so it results in a net increase in the transverse magnetization. So now we have understood what this RF pulse has actually done. So after this RF pulse, so I think one of the slides is missing. So once you have RF pulse is basically switched off, what exactly happens is, there is an basic tendency for it to go back again into the low energy state. So in the transverse magnetization will again start gradually going up, and whereas the longitudinal magnetization, will start recovering and go up, whereas the transverse magnetization will again start dephasing. So moment you switch off the RF pulse, there are two things which happens: recovery of the longitudinal magnetization as well as decay of the transverse magnetization. So based on these two phenomena, you can have, by now we'll try to understand two different terminologies. One is the longitudinal relaxation, which we also know as T1. The second is the transverse magnetization, which is also known as the T2. So longitudinal magnetization, as we have discussed, the moment we switch off the RF pulse, the longitudinal magnetization, which was earlier switched on the transverse side, it starts recovering back towards the direction of the external magnetic field. Now what we see is different tissues have got a different precessional frequency, and by definition we define T1 as the time when this 63% of the original longitudinal magnetization is reached. Now here you can see this yellow one depicts the protons which are present as a part of fat, whereas blue you can say is water or CSF. So here your fat is having a faster T1 recovery, so a faster longer longitudinal relaxation as compared to the fat. Whereas at the same time, what was happening in the transverse plane when we switched off the RF pulse, that there was a decay. So since there was a decay, moment as along with the time we go up, this signal is going to drop. This is known as a transverse relaxation. So T2 is defined as a time when the transverse magnetization has decreased to 37% of its original value again. So here the T1, the fat again is decaying very fast, whereas the fluid or the water or CSF takes a longer time to relax again. But in practice, what is actually happening is T2 is never a pure T2, because your external magnetic field is never that homogeneous what you want. So there will always be some amount of inhomogeneities which will be present in the external in this magnetic field. This will lead to a small areas of mini magnets which form, and they will lead to further faster decay of the signal than your T2 signal. So in order to get a meaningful signal again, you have to do now something else, that you have to apply a refocusing pulse or a 180-degree pulse, which we'll discuss subsequently in greater delay, so that in order that you are able to overcome this T2 star decay thing. So moment when you use your this T2, when you apply a 180 pulse, what is happening is the decay, which was happening very rapidly because of this T2 thing again, your protons, the net magnetization vector flips and protons again start rephasing. The moment protons start rephasing, again you get a bright signal. So that is the purpose why you use a 180 degree. So because of, now the first slide was the principle of electromagnetism, there was a significant changes in the signal generation. So because of this changes in the magnetic field will induce an electric current, and this is the electric current which will basically lead to the presence of the formation of the MR signal. So two more terms before we come to the various tissue characteristics. One is TE and TR. TE is basically time to echo. you have applied a initial radio frequency pulse that is 90 degree to flip the longitudinal magnetization into the transverse plane. You also applied a 180 degree refocusing pulse so that again the transverse magnetization comes in phase and your field inhomogeneities are catered to. So after a certain time of this 180 degree, whenever you acquire a signal, so the time interval from the initial 90 degree pulse to your acquisition of signal is TE, time to echo, whereas the time interval between the next RF pulse, means one sequence is completely over and then you switch on to the next 90 degree pulse, is known as TR, time to repeat. So short TE is less than 30 milliseconds and anything more than 80 milliseconds is a large T. Similarly, a TR less than 500 milliseconds is a short TR and a TR greater than 1500 milliseconds is a long TR. So based on this, now let's finally come on to assimilate all this which we have seen till now and try to get the tissue contrast or what is known as a weighting of an image. So what happens is, this is TE. If we acquire TE very fast, so what happens, everything is bright signal, even your fat, muscle, water, everything is going a high signal. And why is that? Because everything is in phase right now. You have just switched off the RF pulse. But as you keep waiting, they start dephasing and signal starts dropping around. But this dropping of signal will be different for different kind of tissues. So this is like at a time of T2, and if you go very late, this is say a third echo. So if you acquire a signal very first, initially, everything will be bright. If you acquire a signal very late, everything will be dark. So there has to be an optimal time where you can get an adequate tissue contrast or differentiation between different kind of tissue. So by now we can understand that TE is basically determining the T2 characteristics of a tissue. Same concept if we apply along what is happening along the longitudinal recovery. So if the signal is recovering towards the longitudinal axis, again, we saw that fat was recovering very fast and the fluid was going slowly. So the T1, there is an optimal time where this tissue contrast is a maximum. So this is determined by TR, that is time to repeat. So TR is determining the T1 characteristic of tissue, T is basically determining the T2 characteristic of tissue. So how do we get a T1 weighted image? When you talk about a T1 weighted image, what we have done is, firstly we have to take a short TR. So you take a short TR, in order to null the effect of T2, you basically get a short TE also. So a short TR and a short TE will give you a T1 weighted image. So these are the parameters which are written here. You got a short TR, you got a short TE. Short TE has removed the T2 effects and a short TR has accentuated the T1 effect. So by applying these parameters, you get what is known as a T1 weighted image. Same thing you apply, what happens in a T2 weighted image. T2 weighted image, it was basically depending on the TE was determining the T2 contrast. So you took a largest sort of TE, and in order to maintain, you have to have a large TR. So a large TR and a large TE will give you a T2 weighted image. So by now we have understood the tissue contrast, we have understood two basic types of sequences, like what is T1 weighting and what is T2 weighting. So till now it's fine. Now to get the final image, what do we require? We need to localize this particular signal, and this signal has to be localized at least in 3 coordinates. So each pixel or a voxel which we are going to image has to have a proton which has got a unique phase information, it has to have a unique frequency information, and it has to got a unique positional because of the slice encoding. So for that we use gradients. So what these gradients do is, these gradients alter the field of the external magnetic field, and these 3 gradients are applied in this 3 direction. So you got a slice selection gradient, you got a phase encoding gradient, and you got a frequency encoding gradients again. So slice selection gradient is basically applied in the direction of the z-axis or in the direction of the external magnetic field. So what it does, that each and every proton in the direction of the z-axis is now processing at a different frequency. So whatever slice you want to activate, you bombard it with the RF pulse of that particular precisional frequency. We again go back to our Larmor equation, which we had understood again. So this bandwidth of your RF pulse is actually going to determine the slice thickness which you are going to generate. Now comes the phase encoding gradient. Now what happens is, on another axis, basically along the y-axis, you can apply a phase encoding gradient. So this phase encoding gradient, when you apply each particular TR, you have to apply a different phase encoding gradient, and this will ensure that all the protons in the y-axis are having different phase information so that you are able to localize them. And actually this is the most time consuming step in MRI. That is, it is a limiting factor is that of a phase encoding gradient. The third step is the frequency encoding gradient. So in the third dimension, that is in the x-axis, you apply a frequency encoding gradient. So what will happen is all of them will move at a different precisional frequency. So, and this frequency encoding gradient will be basically applied in the direction of the readout gradient at the time of the generation of the echo. So finally, whatever the information you get at the time of the readout, they are like complex waves again. So you use mathematical models, will not go into the detail of it, which is known as a Fourier transform. You deconvolute it to smaller sine waves and cos waves, assign them a numerical value, and feed them into what is known as a virtual space, that is known as a K space again. So what happens as data keeps on accumulating, so your rows in this thing are basically your phase encoding gradients are kept on filling in the direction of the rows, whereas your frequency encoding gradients are kept on filling in the direction of the columns. So whether you use the center of the K space, whether you use the peripheral of the K space, the pattern of the filling of the K space will determine lot of contrast and the speed of the MR sequence. Again, we'll not go into detail of it because of the time constraint. So this was broadly, right, how from the principles of magnetic resonance we understood, we went to the external magnetic field, then we went to the RF pulse, then we went to the free induction decay signal, then we went into the tissue weighting contrast. Finally, we have been able to localize this signal in 3 dimensions, giving rise to a unique information of every proton in a pixel or a voxel. And this is, in brief nutshell, how an MR image is formed. Fine? So now, briefly, we'll go into the second part of the talk, which is basically pulse sequences. Part of this has already been covered by the previous speaker in the talk of when we talked about the steady state sequences in the previous talk. So most of the gradient based sequences have been covered. So basically when we talk about the pulse sequences, there are 2 broad groups of sequences. Either they are spin echo or they are gradient echo sequences. All MR sequences are nothing but variation of this. So let's not get confused by complex nomenclatures or complex name and ultimately at the end of the day, there are only 2 sequences, spin echo and gradient echo, fine? You can apply them in 2D mode, you can apply them in 3D mode, as simple as that again. So till now what we have done is spin echo, classic spin echo is what? You had a 90-degree RF pulse. This 90-degree RF pulse flipped the net magnetization vector to the transverse plane. We have already understood why we apply a 180-degree refocusing pulse to bring the dephasing protons back in phase in the transverse plane again. So we already understood what TE and what TR. So this is a classic spin echo sequences which use a 90-degree pulse, which uses a 180-degree pulse, okay? So this is a spin echo diagram again. This we have already seen. So you have one 90-degree pulse which is coming. Then you have a 180-degree refocusing pulse. After a certain time, your echo is acquired. This is a TE. At the same time, simultaneously, let's understand what is happening is you are applying a slice select gradient at the time of giving a 90-degree pulse. Then you are applying a phase encoding gradient. This is before the collection of your echo. And finally, you are applying a frequency encoding gradient at the time of the readout again. So this is in nutshell what basic spin echo diagrams looks like again. So this spin echo can be T1 weighting and T2 weighting as we have discussed. They are less prone to susceptibility artifacts because why? Because we've used a 180-degree refocusing pulse again. So conventional spin echoes are generally not used in clinical practice because it takes lot of time. 180-degree refocusing pulse itself takes a lot of time. So this is example of T1 weighted and this is T2 weighting again. We have already discussed the TRT parameters of this, but these are spin echo sequences again. Now, there are certain variants based upon to be actually useful in clinical practice. We have to do certain minor modification in these sequences. So we go to what is known as a FSE, fast spin echo or a turbo spin echo, haste or a broad group which is known as the inversion recovery sequences. So in fast sequences, let's not get confused. It's nothing too big which is happening. You applied 190-degree pulse, your longitudinal magnetization is flipped into the transverse, then you are applying 180-degree multiple TEs you are acquiring within the same TR. So depending upon the number of TEs you are acquiring in a single TR, that becomes your turbo factor or a FSE factor. And those so many lines of K space will be filled in a single TR. If you want, we can fill the entire K space in the single TR itself again. That would become a form of a ecoplanar imaging, which we see later on. Similarly, you can do certain modification at the level of filling of K space also. Haste is an acronym, trade name used by Siemens. So what it is doing, half Fourier acquisition. You are doing a turbo spin echo, but what you are doing, you are filling only half of the K space. Rest of the half of the case space is just inferred. Something in CT we do interpolation of data, something like that, so that your time it becomes faster. You can use an MRCP or abdominal imaging. Now let's come to the inversion recovery. Inversion recovery is a separate group of spin echo sequences. Now what happens in spin echo, in order to generate a contrast, you try to null a signal from a particular type of the tissue. So basically what happens, moment you switch off the RF pulse, you know that your fat, which is one extreme, and your water, they are recovering at a different frequencies. So what you can actually do is, basically, before starting your regular pulse, you put a 180-degree inverting pulse. So this 180-degree inversion pulse, what happens is, so let's focus on this particular first diagram right now, this one. So what happens is, you applied a 180-degree inversion pulse, your fat is recovering faster. So by the time your fat has come to the transverse plane, you use this particular time, now you start your 90-degree pulse again. So what happens, right now there is no magnetic vector of the fat, that fat will immediately slip down, so you have effectively nulled the signal of the fat. So this uses a short TI time. So this stir sequence, short T1 inversion recovery, is basically used for suppressing a fat saturation again. So you see the advantage here now. So this is a marrow, here you can't see much, this is a subcutaneous fat. In this, after the application of the stir sequence, your subcutaneous fat is suppressed, but look at the clinical information which you are getting. Your marrow fat is suppressed, your bone edema has become so conspicuous out now. The second inversion recovery which we are using is known as a flare sequence again. So what is actually happening in flare is we are waiting for a much longer time after giving your initial inverting frequency. So you apply an inverting pulse and you keep on waiting till the time your water now comes to the transverse plane again. So that requires a very large TI or the inversion time. So moment water comes to the transverse plane, you start your routine spin echo sequences, so your fluid gets suppressed. So this is known as a fluid attenuated inversion recovery sequences. So this suppresses the CSF, very useful in brain imaging for identifying pathology and most of the other body parts also. Now, these are the broad group of the spin echo sequences. Gradient echo, I think I'll cut short because a lot of it has already been covered in the previous talk. But what basically difference between a gradient echo and spin echo was that here in the spin echo, we used an initial 90-degree pulse to flip the longitudinal magnetization into the transverse plane. In gradient, what is happening, you use again an RF pulse, but not necessarily to a 90-degree. You can flip it to a varying degree, 30-degree, 40-degree, 60-degree, depending upon the time and type of tissue contrast you want. So this is known as a flip angle. So this is first difference between gradient echo and spin echo sequences. The second major difference between a GRE sequence and spin echo sequence is earlier we had used a 180-degree refocusing pulse, and which was taking a lot of time and lot of energy deposition also again. So here, instead of that 180-degree refocusing pulse, what we will use is basically we'll use a gradient again. So this particular gradient at the time of gradient, the frequency encoding one, we will use this gradient to rephase the protons again in the transverse plane. So you've done away with two steps, you've done away with 180-degree refocusing pulse, and you do not necessarily flip it to the 90-degree and you get a gradient echo. Ultimately, what are we trying? Why are we using gradient echo? Basically to cut down the time short. Faster imaging, faster imaging, faster imaging. But at what cost? The cost is faster imaging at the time, since you are not using 180-degree refocusing pulse, your inhomogeneities are incompletely suppressed by the gradients which you are using. So there will be more of T2 star effect in gradients again. So all your gradient will have a higher degree of T2 star weighting than a pure T2 weighting again. So this is the pulse diagram of gradient echo which we already does. Just remember here the TE controls T2 star weighting instead of pure T2 weighting. TR controls the T1 weighting, but however there's an additional factor which has come here, which is known as a flip angle here. Flip angle also controls the T1 weighting again, and spin density effects are almost always present again. This pulse sequence diagram will skip, and this part has already been covered, so I will just focus on this chart diagram again. So gradient echo sequences, as Dr. Parihar in his previous talk has already think, what is the problem which is happening? Why did we go on actually to go to that state of steady state? Why did we require them? Because now you started doing the sequences so fast, what is happening is, before your transverse magnetization has disappeared completely, you are again bombarding with a fresh TR, you are again coming with a fresh TR. So always there is a certain degree of residual transverse magnetization, because that is why you went to gradient, because you want a faster imaging. Now this problem of transverse magnetization can be dealt in two separate ways. Either you spoil the transverse magnetization, that is you decompose it by whatever you're using. You use the spoiler gradient, whatever is, you discard it, and then you use the fresh signal, whatever you're getting. In that case, you are nulling the T2 effect and you'll get a fast T1 weighted sequences. So that will be your spoiled gradient echo sequences. Whereas if you decide to use this transverse magnetization, if you decide to use it, keep it, either you can decide to partially refocus it and keep on using in your next generation. So that will become your FID type of or steady state and free precision sequences again. Either you can use a FID signal or you can use an echo signal. Or finally, if you decide that you can phase changes are balanced in all the three directions, as has already been discussed in the previous talk, you will get a balanced sort of sequences. These balanced, this is already been declared, either you can have a cis sequences or you can have a des sequences, very fast sequences, a good T2 imaging, predominantly they are on the T2 imaging reasons we have already seen. Ecoplanar imaging I already told, ecoplanar can be done both as spin echo as well as a gradient echo, just finishing. So spin echo as well as a gradient echo, both can be used to do usually we use a gradient echo. Common example of ecoplanar imaging are the diffusion. So basically within a single TR we are trying to fill up the entire case space. And last one variation of this ecoplanar special sequence is a diffusion, where you apply gradients in opposite direction before the 180-degree pulses. So anything which is static or has got a restricted diffusion, these opposing gradients which you have applied, they cancel out each other and you get a bright signal on a DWI. Whereas the motions which are moving, they do not cancel out and the signal is separated. So it's got a very vast clinical application of DWI. So in order to summarize, this is my last slide. So these are broad sort of T1 weighted images, T2 weighted images and T2 star weighted images. So this T1 weighted you can use a spin echo sequences or you can use a gradient echo like flash is a trade name or a 3D GRE. Whereas on a T2 you can have a spin echo sequences, you can have a steady state sequences, and even your DWI with a B value of 0 is of a T2 weighting. Similarly, your spoiled gradient echo will have a more of T2 star weighting. Thank you. Thank you.
Thank you, Dr. Jain. That was an excellent presentation with wonderful animations. And I think whoever has listened carefully, it was like a mini session on the basics of physics. It was truly good. And for the benefit of residents, I would like to recommend a book to you. If you can read after his lecture, you'll really understand it. It's called MRI Made Easy. And anyone who has access to it should really read it. It'll be really good for all of you.
In fact, a lot of animations has been taken from that book also.
Yeah.
Recommended to residents. It simplifies in understanding.
Yes, it was quite popular around 20-25 years or so, but I still believe there is no better book to understand MR physics than that one. So, really wonderful session. Thank you.
Thank you.
If there is any question from the audience.
Excuse me, Dr. Jain, very nice and very excellent. You have summarized this complex topic. Just I want to know if I wish to make a sequence, which factors are needed? Which factors are needed to make a new sequences? Like if I want to make a sequence, derive a sequence, which factors I have to change?
Depends on spin echo, gradient echoes. The basic factors will be like TR. If you're using a gradient echo, then basically TR, TE, flip angles again. These are little primary tissue characteristics. By altering this, we can get different kind of sequences. Or if you apply a special sort of gradients or pulses, like when you use a diffusion, you can use a different kinds of gradients again. Or if you go into a different kind of imaging, like susceptibility, basically it all depends what you are trying to image. Suppose you want to use a time of flight phenomena again. So you can use an inherent tissue contrast again. So that can be used to get a separate set of sequences. Suppose you want to use the phase information. So you can use the phase information in generating different kind of sequences. You can use a phase venography, you can do a flow studies depending on that again. And similarly, suppose you do a susceptibility weighted image. You can use this again, T2 star effect and other phase information again.
No, that is a good thing. But just I want to know the factors, how we have to change the TR or we have to change the FOV or the flip angle or cos theta.
So primarily for a user or a technician who will be doing, the basic factors would still remain the same. The primary tissue weighting or contrast will still depends upon the TR, TE, your flip angles, but in actual thing, lot of other things come into play, like number of averages you will be taking. your FOV size, your matrix size. So when you actually do, there'll be, things are more complex. This is like in an effort to simplify the basic principles of physics. So moment you try to get a narrower slice, your SNR will drop, you'll have to increase the averages of that thing, your time will increase. So multitude of factors come into play in that way. But still the primary determinants of tissue contrast will be these basics only.
Okay, thank you, sir.
Thank you, Dr. Jain, for an excellent presentation. So our next speaker is Professor S. Senthil Kumaran. He is joining us online and he is going to speak on functional MRI in neurological diseases. Now, Professor Senthil Kumaran is a professor in the Department of Nuclear Magnetic Resonance, AIIMS, New Delhi. His area of interest is nuclear magnetic resonance, functional MRI, Parkinson disease imaging, ataxia neuroimaging, stroke imaging, magnetic resonance spectroscopy, cardiac MRI, and cardiac MRS. He has more than 345 publications with 1275 citations. So, Professor S. Senthil Kumaran.
Thank you very much for the kind invitation and the wonderful introduction. Thank you very much. I hope the slides are visible.
Yes, sir. But some flipping is there. Yeah. No. Yeah, it's okay now.
Thank you very much. Thank you for given wonderful introduction about various sequences, and just before closing he talked about echoplasma imaging. So that is one thing which is fundamental in functional MRI. And I don't know how many people have known. There have been 6 Nobel Prizes in the field of magnetic resonance. And yes, functional MRI also should get its due, so we are hoping that there will be a Nobel Prize for in that. Movement disorder is one area where we have the motor symptoms, non-motor symptoms, and the origin is basically due to a biochemical alteration in the substantia nigra. That's what it is believed to be. But then when it happens to us, we do have people complaining that our memory is not good and there is a degradation and all those things. So there are a couple of things that we have been trying to do over the last 20 years, and the whole research started with us basically when the subject is not able to speak properly, and once there is a pollution, like they started saying like what's her name, and he wanted to say Arthur or something. So after that, once the lips could open, the patient could tell the name very clearly without any ambiguity. So that's where we started our research using functional MRI. And also DBS is having a full lifetime, so it's good for 70 max. And there are a couple of other things which are very close enough, like multiple system atrophy and supranuclear palsy basically. Both, and all the 3 mimic in some of the, and in some cases the symptoms do overlap. So at 8, sorry, I think there is some more on that point. Yeah, hope there is no echo now. Yeah, at AIIMS we are trying to address the movement disorders using metabolic, functional, and structural methods. And we have been trying to see how we can. So as we progress from our own research, now functional MRI, it's a technique for measuring brain activity, and it detects the changes in blood oxygenation and flow that occur in response to neural activity. Like a particular brain area is more active when it consumes more oxygen to meet its increased demand of blood flow, then there is always a supply to that area, and that supply basically overshoots the demand, and the flow to the brain area is maintained for some time, as long as the activity is in progress. So it can be used to produce activation maps showing which parts of the brain are involved in a particular mental process. And it has two things: and task-based fMRI. And in both the conditions, basically, so we have a resting state where the blood flow is there. So using that, but then it does keep change when there is a thought process or some imagination or anything associated to visualization or other things. So if a subject is lying inside the scanner with eyes open, there can be steady stream of thoughts, and there can be change from one topic to another over time, and trying to map the network based upon that is resting state fMRI. And activated, like you give there is a small activation happening whenever there is a thought process. Now, there is something called task-based, so for which I typically use this. So a person is not doing any task, and so during resting state, the hemoglobin is being maintained, and as soon as he starts moving his hand or doing the finger tapping task, then there is an activated condition. So what happens during that? So if there is sensory or cognitive or motor process, there is integration and signaling in ensembles of neurons. There is ATP consumption by neurons and astrocytes, so where because of that increased glucose, increased blood flow, increased oxygen, which leads to displacement of deoxyhemoglobin. The movement of deoxyhemoglobin causes an increase in the coherent spin in the proton nuclei that is being used for imaging, and there is an increase in local MR signal due to that. And this variation in terms of susceptibility is only 0.08. That is, when a subject is at rest and when the subject is doing a task. So motor task and other tasks are much more stronger. The cognitive processes are not so stronger. So this difference of 0.08, how it translates into the signal at a particular given field. So even 1 fMRI is possible, 3 Tesla is definitely possible, and as every one of you know, the signal increases with the strength of the magnetic field, and signal to noise ratio also increases proportionally. So here oxyhemoglobin has less field inhomogeneity, and deoxyhemoglobin has more field inhomogeneity. Now, the percentage bold signal change is a combination of cerebral blood flow, cerebral blood oxygenation, and cerebral blood volume. So I normally say it is an indirect measure when I am introducing the topic. So the rate of change of oxygenation, metabolic, the blood flow and blood volume, basically all the factors combined together gives a change in the signal intensity when you are doing the bold. And here we have also put that there is a measurable physiological and magnetic field dependent constant which is there. So if the person is having changes in the breathing pattern, there is change in the bold signal change. And that signal is being captured through a gradient based sequence or echoplanar imaging sequence. So normally we say it is T2, but since I am going for a gradient echo, I would call it as T2 star, and this is a proportionate of the blood hematocrit. This is the classic example. The picture is from one of C.G. Ogawa's presentation, and as soon as a task is being initiated, there is an initial dip, and that's where the deoxyhemoglobin is there, and oxyhemoglobin is depleted, and immediately there is information back to supply more oxygen, and the supply of oxygen goes to that particular area. If I am doing a task related to primary motor area, say M1, then in M1 area the blood rushes, so and then it overshoots the demand and then settles down. So the time scale I have not put explicitly because it varies for different tasks, but it is typically between 1.5 to 7 seconds for various tasks. And after that, if the task is stopped, there is a post-stimulus undershoot which happens. So it is similar to here and overshoot. So there is an undershoot and then there is a saturation phenomena over time. So C.G. Ogawa in 1990 basically used the blood flow and oxygen metabolism to infer brain activity, and he showed in one of the very first report in rats that with administration of blood carbon dioxide level and the oxygen basically, and then he showed that the difference could be easily mapped. And there are susceptibility weighted sequences also which are there. So this is one of the technique which basically exhibited both bold as well as susceptibility in those days. Those days it was not called as SWA image. In 1992, Dr. Kwan demonstrated first bold contrast in the visual cortex, and if you see that, and those days even to occur 7 slices, you would take a couple of seconds basically, and now as of at present, you can do whole brain data acquisition in sub-seconds basically. There are a couple of scanners which are possible to scan in 530 milliseconds the whole brain, like around 30 slices, 31 slices of say 3 to 4 mm or 5 mm slice thickness, you can do at 530 milliseconds. And so if you keep it at 1000 milliseconds, then you can acquire more number of slices, or you can reduce the number of the slice thickness, and you can acquire the whole brain with higher spatial resolution. So the initial study, as you see, there was activation, and then they tried to map it out, and they showed the activation in the visual cortex. Why is it useful? It is non-invasive, which is true for the MRI itself. You have excellent spatial and good temporal resolution. When I say good temporal, basically, like you cannot compare with EEG where it is in the orders of milliseconds, but we are able to match that now. As I said, 530 milliseconds for 30 slices. So if you are going to concentrate on a couple of slices, you can still go for much lesser. So around 100 milliseconds is still possible if you are going to cover around 5 to 7 slices. And spatial resolution is, if you are going to acquire a 64 by 64 matrix, that's what the time that I had given. So if you want to increase from 64 by 64 matrix to say 128 by 128 or 256 by 256, yes, there is a compromise on the temporal resolution. And it is easy for the experimenter to use, and repetitive investigations are possible. And as part of International Society for Magnetic Resonance in Medicine, are you able to repeat the same measurements what you have done 1 year back, and can you repeat it now, is some of the challenges that they normally pose. Yes, it is possible if you had used some set of parameters, and it is very useful in functional MRI as well. It is a popular tool for imaging normal brain function, and it provides new insight to investigation memory, language, pain, learning, emotion, etc. And it is used in clinical as well as commercial settings. So when I say for functional MRI, what do you need? The MR scanner is available, and along with the MR scanner, you just need a couple of accessories if you want to do different types. A visual cue. Either you give a cue using a binocular setup, or you give the cue through auditory stimulus, or it can be the back projection system, or it can be a monitor which is available very easily over the last 8 to 10 years. We have LCD monitor which are placed. So 24-inch to now 42-inch monitors are available. So you just need a back and the subject is able to see the cues that are being presented. And if you want a response grid or a button response system, so whatever is there you can use. And the task has to be programmed in a timely way. We used to have use a commercial software, but there are many software, PsychoPy, and there are presentation softwares which are available for use freely without any commercial thing, and it can be used to time the presentation if you are looking at a task-based fMRI, and if you are looking at resting state fMRI, then there is no need of any such thing. So, of course, the practical concerns when you are using the MRI, there is a claustrophobia. The noise induced in gradient coil by the rapidly switching gradient is there, so which necessitates that you are, if you are trying to give an auditory stimulus, you have to have a good headphone and the mic system which have to be there. And of course, I know that one vendor tries to sell it for 42,000 with active noise cancellation, and with passive noise cancellation, the noise suppression is only around 30 decibels. The gradient switching might induce nerve tingling, so you have to look for PNS. Of course, the other things which are related to MRI, the same concerns holds good for functional MRI also. Now, with respect to the field, you see 3 Tesla, the percentage change in the motor cortex is much stronger. So, the more the field, it is better for the percentage signal change of bold. And again here, this is for a motor task where you can see around 6.5 to 7% over here. But if you are looking for some cognitive processes, it will be around 3 to 5%. And so at 3 Tesla, it will be around 6 to 9%, basically, somewhere around that. So what are the concerns in fMRI? Or in other words, what are the steps of fMRI experiment? Yes, the very first and foremost, ethical clearance. After that, you have to design the experiments. Like if you are going to use motor task, speech task, or you are going to give language, memory, emotion task, or you are going to give some phonemes like SIMS, like verbal 1 back, verbal 2 back, whatever is the task. So it has to be designed. And after that, there should be parameter standardization. There should be couple of studies and controls for proving the reproducibility. And of course, in patient, because you have to know whether the patients are able to comprehend and respond depending upon your research question. And of course, pre and post data analysis. So as I said, the task paradigms inherited from other established techniques can be used, or it can be block design or event related design. So when we say block design, it is series of task, no task. So your subject is doing a motor task like a finger tapping for 30 seconds and not doing anything for the next 30 seconds. So it is alternating block design basically. Or it can be event related. There is no work and then suddenly the subject does a task and then again there is no activity. But then we have to make sure that the overlap is taken care of, because as I said, it is an indirect measure. If any task is given within 18 seconds of the next, there is a partial overlap between the signals among that. So this is one of the earliest experiment that we did in 1997 with a sensory experiment and using flash actually, and you can see how the variation is there. And so how 7 cycles of rest and listening and how the variation is. So basically the data is processed in such a way that you have the signal related to the task, the signal related to the rest. You average, you add all these signals during the task and you subtract them from the added or average of the baseline task. That's how the time series is analyzed. We had done some studies on bilingual processing, so using both auditory study as well as visual studies. And before going for any study, you have to know, at least have prior idea about the areas that you are looking for, the task that you are looking for. And so this is very much essential, because when you plan a task, you need to know what are the time frame that you are looking at. And so you have to optimize the task accordingly, and retrospectively you have to look at the parameters which are like TR, TE, the number of dynamics, number of measurements. Whole brain data is acquired multiple times, say 200 times, 400 times, 800 times. So, and from that we are getting the data. As I showed here, this is data is acquired over 600 seconds. So you have 1, 2, 3, 4, 5, 6 cycles over here, and the initial cycle and the last cycle we are not considering, and the rest is 1, 2, 3, 4, 5, 6, 7. So this 7. So the data, the whole brain data is acquired for the entire duration of the time point which is presented over here, and the data is analyzed. And then, of course, you have to have a little bit of information on the flow of the data. And so just gave some examples from the literature. And you have to have the role of some of the areas, especially if you are trying to look at subcortical areas, it is advisable that you do a bit of homework, go through the literature. So this is one of the work that we had started. We basically recorded the spectrogram in the Parkinson's disease, the people with Parkinson's. And after that, we also did bold, basically. We asked the subjects, we had given consonants like velars, palatals, bilabials, nasals, like that. And we did, of course, the experiments repeated for proving the reproducibility. And after that, we also tried to correlate with the spectrogram, and we also recorded the dynamic movement. This is a single slice experiment done. Every 40 milliseconds we had acquired the data, and we could estimate what is the acoustic cavity which is present during that time, and the movement of tongue, aura, and all those things we could map over here. So we did, and we found that voice onset time directly correlate with the motor area when the dentals, bilabials, and nasal speech evoking tasks were present. Retroflexes were affected in patients, and the pitch was reduced in patients, as you know, in Parkinson's, that is very much affected. And we could use this to differentiate MSA, PSP, and the Parkinson's. That was one of the strong outcome that we had. And of course, the dynamic study that we tried, how the whole thing is different in MSA, PSP, and PD. So you see that the PSP subject does not have any problem and almost comparable to the control. And the motor area controls velum palatine to produce nasality. So that may be the reason why the whole thing was correlated. So we also attempted memory. As I said, there was a common perception among the patients that the memory is affected. So we did functional MRI study along with DTA, and we also did the machine learning features. This was performed somewhere in 2015, and we could show that the memory was intact, that is one, and the volumetric showed that substantia nigra and thalamic area together could be used to classify the PD from healthy controls. We also looked at color discrimination because this was one of the area that has not been attempted, and we found, of course, domain-specific cognitive impairment is somewhat normally relevant. So we did that, and we could prove that. And we also found some of the cortical measure also being altered. So along with the color, we found that the correlation between color perception and task-based functional connectivity was present in these 4 networks. And we also tried to look at the volumetrics in Parkinson's with mild cognitive impairment and Parkinson's without any cognitive impairment, basically, or cognitively normal subjects, as we call that. So there are a couple of areas which are affected. So when I say HC more than PDMCA, that means these areas are affected in PDMCA in comparison with HC, and between cognitively normal and cognitively impaired Parkinson's subjects, these areas were affected. Basically, inferior parietal, the temporal, occipital gyrus, and angular gyrus were affected. So, and we could prove with multiple studies along with our ophthalmic colleagues. So we could say that there was an impairment in the color perception. There is intratemporal connectivity which has been altered, and temporal to occipital and frontal attention network was affected. And when we compare PD normal and PD with impairment, we could also show that temporal and parietal atrophy was present. And we also tried to look at olfaction. This was a pre-COVID era that we attempted, and the work was started somewhere in 2017, and we could show that how the smell evokes cortical activity in the subjects in healthy as well as in Parkinson's. And coffee was one of the favorite smell for them. And of course, we tried, we had a lot of sample, smells, the perfumes, and from that, basically we started sniff kit, and sniff kit and India-based the olfaction kits were acquired, and we normalized. After that, we started using India-based because some of the kits from sniff kit could not be used for the PD patients. And the connectivity again, the areas which are affected, like in left thalamic area, in the left thalamus and the right thalamus, and similarly right thalamic, right hippocampal, and right occipital, which are connected with the left thalamus, they were a little different. And then we also tried to look at the ERP results with smell, and that also showed that there were some alterations. So we could show that the rates of disease progression in Parkinsonian disorders will be able to show some things, because we could show functional connectivity as well as the EEG signal varying. Now, as part of intervention, yes, we attempted TMS as one of the things, and we gave that in M1 area, primary motor, and supplementary motor area, and we found that the sensory motor area did not evoke any effect post TMS. So real TMS in motor area had a little focus activity, and the SMA also had a little better. So this study was followed up, and we could show that M1 in SMA TMS was very useful. Now the question is, how long does the intervention should be continued? So we are trying to look at that aspect. And of course, other than Parkinson's, yes, the functional MRI has been used for surgical planning of patients with epilepsy. So language area is something very typical, but then language, speech, any area that you want to look at, it can be done, carried out. And of course, we have done that in stroke also to look at how is the activation and whether the mononuclear stem cell administration, does it help? Because those days getting the approval for stem cell, the autologous mesenchymal cells were difficult. So we started the study with mononuclear cells, and we found that even that was effective. Only thing is, it did not have long-term improvement. So we had to again go for other cells, which have time benefits to the patients. So we also did a lot of studies in stroke. Now coming to clinical applications, yes, surgical planning is something where it is very useful, and of late we are using it for TMS and this navigation for TMS, and to give the focal area where the TMS can be planned. So that is one thing. Functional assessment in management, increasing the efficiency, basically to look at the effects of therapy, looking at functional changes, effect of drugs, the linguistic performance, cognitive processing, all those things. And the whole thing would not have been possible without the help of multitude of faculties coming together, and the main strength is the students, people who are there. Thank you very much.
Thank you, Professor Senthil, for such an excellent presentation and an overview of functional MRI. So as a neurosurgeon, we know how important is functional MRI in our surgical planning. I still remember our old days, 10, 15 years back, whenever in most of our scientific conferences, we used to discuss about how to
I'm sorry, I'm not able to hear you.
But nowadays, safety is something which we considered first. Because 15 years back, whenever we operate a patient, we simply pray that my patient should remain fine in the post-op period. But we most of the time see unexpected results. We were not sure of our results because no such things like functional MRI or DTI were available at those times. But nowadays, with functional MRI, with DTI, and we are very much comfortable in planning our surgery. We know, because of the help of functional MRI, that we know that whenever we are going to operate this patient, we can plan it beforehand. We can plan how to choose a trajectory, how to do a surgery so as to find a patient very good in the post-op period. Thank you, Professor Senthil, for such an excellent presentation. Any questions from, yeah.
Good afternoon, sir. Sir, I have one question. Sir, task-based MRI, actually we are giving a task followed by a baseline, an activation period followed by a baseline. But in the case of event-related MRI or resting state fMRI, this baseline is not there because the task is continuously run. So how this signal is being interpreted?
Yeah, in the event-related, you actually give events different time points. So whenever the events are not there, that is considered as the baseline. So, but then as I said, there is an overlap. So if you give events, a couple of events together, say for 6 to 8 seconds, and then there is no, it is varying basically. You give a gap of 18 seconds and then give the next event. And after that, you can give a gap of 30 seconds or 40 seconds to give the next event. So the presentation of event timing is in your control. So whenever the events are presented, with respect to the control, the baseline is how you get the signal difference bit of the. Only for resting state, we are not giving any task. So that we use the intrinsic network analysis to elicit the activation.
Can I have one more question, sir? Sir, you said about olfactory fMRI. So how you are giving the task, how the patient is giving that smell? So.
Yeah. We had an olfactometer which was procured from a company in Europe, but there are simpler ways to give. One or two, I can suggest that you have the manifold line inside the MR examination room.
Okay.
So you can use that to flush basically, but then you need to have a small controller inside which has to be MR compatible. So if that is, we have gotten that with help from IIT, and we used it in addition, because many a time that olfactometer that we imported had a delay of 14 seconds, but that 14 seconds was continuous. So we could always do that, but we also wanted to check whether it had any effect on the olfaction, basically the stimulus that is presented to the subject. So we had this module and we used it, so the oxygen flush through that, and then the oxygen flush without the perfume. So there were two tubes. So it was alternating between the two, and we could verify that the bold signal is due to that particular smell.
Thank you, sir.
Thank you so much, sir. This is Durgesh. Dwivedi, sir, thank you so much for your time, sir. Also, I know sir just had another talk before this talk. He's in a conference. He's basically organizing a workshop in Delhi. So thank you so much for your time, sir. I know we are running late. Just a small question, sir. Any like one thing is like volumetric analysis. When you said what you are doing for that volumetric analysis. And also, just to say again, thank you very much, because we are fortunate. We can count them on finger, like who is doing fMRI in entire India. Very less number of people. So just wanted to know about the volumetric thing, if you can comment. Thank you, sir.
Thanks, Dr. Durgesh. It's always a pleasure. The volumetric is basically from the T1 whole brain MRI data. So it is a 3D T1 on which we are using and our 3D T2. Or we can use the combination of both. And the volumetric tools, basically there are many open software which are available, or the vendor-based software also. So one of the open software I can give is statistical parametric mapping. It has a CAT toolbox. So the CAT toolbox can estimate the volumetric analysis. Like you can have multiple parameters that can be estimated using that. And FSL also gives good parameters. The MRTrix. There are so many software which are available nowadays for estimating the volumetric parameters.
Thank you, sir. This is Dr. Nitin. I am from KGMC. There are two small questions, sir. For a condition like Parkinsonism, we have a star-studded DICE in which chairpersons are from geriatric mental health and neurology both. They don't need us to diagnose Parkinsonism radiologically, they diagnose it clinically. Is there any proven role of fMRI in diagnosing Parkinsonism as of now, established role? And is there any role of fMRI in deciding pharmacotherapy for different subsets of Parkinsonism?
Yes, MRI per se or fMRI per se did not have a role in detecting PD. But then, as I had put a couple of slides on various aspects, like we could show that memory is not at all affected in Parkinson's. So like that, there are many clinical outcomes or research outcomes that are going to benefit the clinical community. That is one. The second is, to your question, how and like MSA, PhD and PD, the difference is one of the challenge that the neurologists always wanted us to work on. So that is something that we could. And we, like functional MRI, basically the speech-based, we could differentiate the three. And also MR spectroscopy is another thing which we combine. And our separation of the three disorders was very good, excellent. Now, coming to your question of what role, basically the effect of intervention, whether it is TMS or DBS or TDCS or whatever pharmacotherapy intervention, you can always look at the effect of all those things using fMRI. Now, the second question is, like when we were able to look at olfaction, we also found that olfaction and the dynamic MRI that I had shown, these two were one of the initial characteristics that could immediately pick up PD from other dystonic disorders, basically. The delay. And we also say that it is a motor disorder primarily. So the cognitive, whatever cognitive feedback, everything that we are having, it may be related to the motor. And so some of the non-motor symptoms are actually triggered by the motor. That is good to know.
Thank you, sir. Thank you so much.
Thank you, Dr. Dikshit. He asked about that we don't take help to diagnose people with MSA or PSP or PD. Actually, the way Dr. Kshitij was talking about that, he was just praying for the patients when he was operating 15 years ago. So it could be a possibility that at this point in time you are not taking your help, but it's definitely
the way we have seen the promising result in representing different types of Parkinsonism by Dr. Sartha Kumaran, and hopefully in years to come, maybe 5 or 10 years down the line, we will start taking more help in representing these conditions. So thank you, Dr. Kumaran, for such a nice presentation.
Thank you.
Now it's time to invite our next speaker. The Philips Healthcare is a leader in manufacturing scanners worldwide. So our next speaker is from Philips Healthcare, Mr. Rohit Mishra. He is going to deliver a lecture on MR spectroscopy in neurological disorder. Mr. Rohit Mishra.
Thank you. Am I audible? Yeah. Thank you for giving me opportunity to present in this forum. My topic is today is for MR spectroscopy. And before starting the topic, I know audience is going through a lot of different discussions, and I think it's time to say good morning for everyone. Can we say good morning? Okay, it's a good afternoon basically, so you have to come out of your that comfort zone now. It's a good afternoon part. So we have to start the session now. Can you switch the screen? Thanks. So we'll start with the basic concept of spectroscopy. We know for spectroscopy we are using chemical shift method, and what is a chemical shift is like your water and the fat will process at different frequencies. So frequency separation is almost 3.6 ppm on a level like on 220 hertz or 1.5 Tesla. It's differ for 3 Tesla on absolute basis. If you see different precessional frequencies will cause a different chemical shift artifact. You are using this kind of chemical shift principle in phase and out phase imaging in liver to differentiate the fat in the nephrological areas. Then you are using this method also to use a fat separation. The technique name is spatial, spare. These all the naming conventions we are using across the vendors to use as a fat separation method. And last but not least, we are using this method for spectroscopy part. So before talk about the spectroscopy, let me jump into the imaging part. So in imaging, we acquire and reconstruct the signal, right, from the protons in the water, as discussed in our previous sessions as well. Whereas in spectroscopy, we are actually acquiring the signal protons in the molecules other than the water. So basically, we are trying to map the brain metabolites in the anatomical area, and then we are projecting those metabolites in a spectrum kind of format in the imaging. So we won't get any kind of image out of it, but you will get some kind of graph where you can interpret which metabolite is available in the brain in what amount of concentration. We use gradient to selectively excite the volume of tissue, and the time signal, the free induction decay or the T or echo time, we will acquire it to get this data. So if you see the MR image part, each voxel will represent either fat or water spectrum. So like that kind of different water and fat spectrum there in the particular FOV you are going to image it. So when we apply our gradient, we can localize these signals in the image section, and you can able to interpret those fat and water spectrum in image like this, and then we'll go and do the Fourier transformation for that acquisition, and you are usually getting these kind of images. That is what the MR image looks like. Now in the spectroscopy, this all the data which we are acquiring in time domain. Then we are mapping it on a scale, on a ppm scale, where you can see such kind of graph in the upper top corner. We used to acquire this MR spectrum data in single voxel and the multi-voxel. Single voxel can be acquired with the steam press method, which I am going to discuss in my next slide. Then chemical shift imaging, the whole volume or slice of the brain, you're going to acquire it and then map those signals in a similar format. These kind of map you can generate with those CSI format, and you can map it on your choline, creatinine and NA area based on the brain imaging or anatomical data. So this is the basically method where we are acquiring a combined time signal, T2 decay signals, and then we are separating out with the method of Fourier transformations, and we are mapping on a frequency spectrum. Like my individual time signal 1, 2, 3, and this is basically how the spectrum or the CSI data will looks like on the images. Reading the spectrum, you can see the small differences in the frequencies, like all the spectrum have different frequency. You can see in the below the ppm scale is there. Some vendor used to push this ppm scale as a hertz scale, and some vendor will use it ppm scale. You can see the signal intensity on your y-axis, where you can able to interpret it on some arbitrary unit. It's why it is no any unit there, because it is very difficult from vendor to vendor. All machine have different homogeneity level, different kind of RF pulse sequence they are using it to get this kind of data. So there's some arbitrary unit we'll use to mention what is the signal percentage is coming off. So some will show in numbers like thousand of number, some will simply show in a absolute number. So better we stick with our ratio options. That is why your clinician used to ask what is the ratio in this particular disease, and then accordingly they will define the diagnosis. You can see the zero frequency from your right hand side. The smaller frequencies will come on from your right to left. So that is how we are going to interpret it. Now the position of peak in the spectrum is like resonance frequency of the proton you are measuring out. As I told, x-axis is always in hertz or the parts per million, and ppm values are independent. That's why the using ppm values on your x-axis will always give you like vendor neutral kind of reading. So that is not create a confusion when you go from one vendor to another vendor. Vertical scan, as I told, it's an arbitrary unit, or the numbers it will show, and the kind of signal intensity of that particular metabolite is going to show you. And finally, the intensity of the MR signal is proportional to the number of protons available in that metabolite. So like, let's say in one metabolite which we measured in the previous slice, it is only HO. So there is only one water proton. So that's the number of signal it is showing. Similarly, the number 2 will have two water protons, so it will show the different signal peak there. So this absolute concentration is always depends on your spectroscopy, how and what are the kind of factor you're using, like your TR, T, then your RF homogeneity, and the kind of coil you're using. So if you use a multi-channel coil, then that data also will create a more on homogeneity issues. And then that is the reason in most of the time we used to prefer for proper spectroscopy a single TR coil, transmit receive coil, channel coil actually. It is easier to use relative concentration, so that's the reason we are going into ratio option instead of absolute values to detect any diagnosis or pathology, and to recommend also in the previous section. Now the signal of the metabolite are very small compared to the water, so we need to suppress the signal as well. If water signal is there, your rest of the metabolite you cannot able to see only. So that's the reason in the acquisition process of the spectroscopy, you need to suppress water signal. If you see the key comparison between the MR imaging and spectroscopy, there you are setting the TE timing to control your T2 decay and get the T2 weighted imaging, whereas in if you compare with spectroscopy, this T2 decay or the T2 weighting actually will help you to define which particular metabolite you want to map it. It is not exactly to weight the image kind of thing. TR here we are setting to control to get the T1 relaxation on the images. So basically you are defining your T1 weighting and MR imaging, whereas spectroscopy it will control or minimize your saturations, or optimize your relaxation effects in the data. NSA, we are controlling NSA to get the motion related artifact removed from the data and to control the SNR. Here it is only working to control the SNR method. The major difference between these two, if you see, we are using applied nuclei in spectroscopy, only the water proton. Whereas, if you see the spectroscopy, we are using for proton spectroscopy, which is very basic and fundamental one. Then we are using phosphorus, carbon, and different nuclei also. Compared to the presentation of information, there you are used to happen to see like cross-sectional images and with the different weighting like T2 weighting, T1 weighting and all. Here you are getting one frequency spectrum. Based on your metabolite, you can able to differentiate in the different pathology. The application area for this MR imaging, we are using for anatomy and pathology, whereas here we are using for the metabolism in the particular anatomy and the physiology part of it. Shimming is very important. There we are optimizing the shimming especially for the fat separations method and all, because generally T2 and those things are acquired well in a good format only. Whereas if you see the shimming, here we have to do shimming very precisely to get the correct metabolite out of the volume. Let's talk about the brain metabolite. So in our system, this is kind of script you can able to view. You have to select the spectrum, like these kind of metabolites are there. Let me highlight it. And based on your field strength, you have to filter it out. And once you filter it out, you can see what available metabolite is applicable on your system. Once it is done, you have to select your peaks. Then all the brain metabolites going to have the 0 to 4.7 ppm. These ppm scale also we can increase and decrease it based on the requirement, or if you're working for some research project and all. Then the peak area will indicate the number of protons in that particular metabolite is high or low. Your T will define actually the appearance of the spectrum. So we'll talk about which spectrum is going to affect with which kind of T method. So if these are the metabolites which is going to be visible at all echo time. So like you can note it down like this is choline, then total creatine, your Na, your lactate, and these are the ppm scales basically, where exactly is going to mark it on your x-axis. So we know the signal intensity increase with the field strength, but lactate will have a different impact here. How? So if you use your short T less than 40 millisecond, you can say double peak of the lactate on the shorter T. When we are going for medium T, this particular double lactate will get inverted on the medium T, and might be the reason is like increasing your susceptibility will increase this chemical shift displacement, and finally this J coupling and the J modulation will phase out the effect, and finally you will get the inversion of the lactate peak. So sometime your radiologists and doctors may ask you, like, I want to differentiate this lactate peak. So that time as a technician you have to use or go for short T and the medium T to differentiate it better. Whereas if you go for the longer T, which is on our system is around 288 milliseconds, this peak can be again reversed back into your double peak in like how it's used to show in the shorter peak. These are the metabolites which actually going to visible on the shorter T acquisition. So your aminoacetol, glutamate, glutamine, lipids, these are going to use on shorter T like less than 40 milliseconds. If you where to choose short, medium or longer T, this is always question between the doctors and the technologists. So when you want to see more metabolites, you can go with the shorter T. Or the baseline, the correction, the standard, all the metabolites you want to see, like I have discussed in the previous slide, you can go with a medium T. And if you want a baseline flatter, like you want only the major peaks to be shown in the spectroscopy, you can use a longer T. SNR will increase from shorter to the longer T, so you have to take consideration of that also. If lactate peak is hidden by the lipid peaks, so with the inversion pulse, so basically using the medium T or the shorter T, you can able to utilize this method to actually detect the lactate peak. These are the summary of peaks you are getting and what particular time of echo you are going to utilize it. That's also mentioned here. You can also refer to this particular paper where in RSNA 2014 they have very much clearly talked about this metabolites. Now talking about the volume selection, which is a very major part of it, and we are more reliably dependent because once your acquisition is correct, your post-processing doesn't need to do a lot of things. So that's the part we need to go for the volume acquisition. So to get the correct information, we are using several volume selection methods. We are going to use press, steam for the shorter TE, S laser. This is a newer method available to remove the, there's a displacement artifact which I am going to discuss again in the coming slides. This S laser is a semi-quantitative method which actually add one adiabatic pulse and remove the displacement in the single voxel spectroscopy. Various technique for the spatial localization available, like I talk about the multivoxel spectroscopy is the chemical shift imaging part. And then choice of volume selection always depends what kind of study you're going to do, what kind of spatial resolution you wanted to get the data. As MR is always talked about, your spatial definition always comes with the cost of time and the SNR of the spectra. So we'll first talk about the volume selection method. First is the press. So press is a basically point resolved spectroscopy and is based on the Spinnaker method. You can select the volume of interest in one measurement, use your 90-degree excitation pulse followed by 180-degree to 180-degree refocusing pulse with the parallel acquisition of your gradient into that pulse sequences. It has a chemical shift displacement already notified in the acquisition, and then displacement is there in all three orientation. So when you're going to localize any spectroscopy in your anatomical area with this method, that displacement you can easily not able to basically see in the acquisition, but there is displacement generally mentioned on this technique. When you go for press method, this is a typical kind of sequence where you are doing your first RF pulse and then your two 180-degree pulse with the same line of gradient applied pulse actually. Then there's a second method is the steam. So steam is your stimulated echo acquisition method. Again, you can select the volume of interest in one measurement only, but major difference here will come is you are using 390-degree of excitation pulse. So your acquisition time will get reduced, plus your TID will be reduced in this case because you are using post 90-degree only the acquisition you are going to get it. You are using a stimulated echo for this spectroscopy. So here with this method we can achieve more shorter T with this method. So we are more prone to acquire this kind of shorter T acquisition with steam method. It has a chemical shift displacement already as we discussed in the press method, but compared to that because the advantage is shorter T we are able to acquire it, we are using this method for most of the sequences. If you see the pulse sequence diagram, again you will give same your 90-degree pulse in all orthogonal plane and you are acquiring the data which is a stimulated echo. If you compare your press and steam method, the press actually eliminate your steam process eliminates your half the signal, therefore press can have up to twice the signal of the steam sequences, resulting in the better SNR from the press. Steam can have a shorter T, like we can achieve up to 7 milliseconds with the steam method, and if you're going for a T for the press which cannot as short as possible, but we have to keep your millisecond around 22 milliseconds, what we able to acquire on our system with the TR coil, which is basically a single channel transmit and receive coil. Therefore, steam will show more T2 metabolites compared to the press method, and we used to prefer this method over the press in our system. Also, press is your less motion sensitive, whereas steam does not, but over the kind of quality or the metabolite, we can able to acquire the both of the situation. Like here is the example given for the short single voxel press method 35 millisecond and the steam method. You can see the peak quality actually compared to a press and the steam. The peaks are very much higher and sharper compared to this one. And even if you see the shorter T, which I talk about like more on the homogeneity part, and the peak quality is much better on your steam method compared to press one. That talk about I was giving like there's a displacement of the voxel. So let's say as a technologist, you plan this area, okay, which was highlighted in the yellow color or green color here. And if you see, there's a displacement actually is measured or can be shown in the next diagram here only, which actually comes with the press or steam method. So we actually started doing with our new version of the software called Release 5.6. It's a semi-localization, so we are adding additional adiabatic pulse in that sequence of timeline, where this kind of technique got actually reduced this displacement shifting from 30% to 7%. So now you have more good quality of metabolites or the peaks in the spectrum compared to the standard method with almost same kind of timing. So your speed is also there with the acquisition. You are not spending any other time for this method actually. This is the method where we are using these two adiabatic pulse in the standard acquisition method, and these adiabatic pulse actually help us to get rid of those displacement. Selection method, if you go for the spin echo option in our system, you can see all three options: press, steam, and then you can use a CSI method as well. Everything within the slice selected will generate a signal, so you have to take care of this. All the signal generated must be included in the FOV, otherwise you will get this fold over artifact into this also. Then the rest lab can be used to suppress the signal which you don't want it. Like let's say your particular volume is covering lot of fat in that area. So one way of doing this, you can go for the higher T2 weighted signal or higher T2 T kind of sequences where fat will get automatically null. Or second way is getting this done is you can use your rest lab in those fat areas so that those signals will not contribute in your spectrum. So this is the typical method what we are doing for the spin echo pulse sequences. And when we are comparing with the spin echo versus the press sequences, or you can talk about like single voxel versus multi-voxel sequences. So there is no in-plane chemical shift within the slice because you are acquiring all. This is the one key advantage you are getting. Then there is no fold over correction required because you are acquiring entire slice in the brain. Now rest lab can be used to get your signal more better and reduce the fat peaks, and spectra are less clean because it works like a point spread function. You are acquiring complete volume in the brain, so that is how it's going to give you a signal, not a particular location you are localizing in the spectrum. With press, you will get only signal from the VOI, so at disadvantage like if you have mets in the patient brain and multiple disease spread across the brain area. So you have to acquire multiple data to get it verified and it will take your time. Chemical shift can be occur because it's in 3D direction localization is there. There is no sensitivity for the fold over because you are acquiring a very small area in the brain. So there is no fold over correction, you can able to use it. You will get the stronger T2 effect and it is less fat contamination because now you have a choice where you want to place your voxel, the spectrum in the images. Shimming is also very important in this because the more the good homogeneity you can achieve in that particular acquisition, the more the good quality of spectra you can get it. So you know the shimming we are able to acquire the good optimizing good homogeneity. So this is the kind of method. If you have the bad homogeneity, this kind of spectrum you will get it. But if I improve the signal in the spectrum or the homogeneity in the spectrum, my spectrum signal will go in a very peak or the good kind of peak will come. And that's how it will improve or better the more you would do the shimming. This is an example of good shimming versus the poor shimming. You can see the height of the peaks and you can see the spectrum. The good C is showing proper V kind of structures, whereas the bad shimming will show you doublet kind of structure in the peaks, which actually define and it's help you to observe your data like whether the homogeneity is good or not. So B1 homogeneities will affect in this kind of cases, and to get rid of this we are using two methods. One is iterative shimming or the first order shimming. Second is pencil beam shimming, which is a second order shimming. So we are using both method to or selected our volume of acquisition or whether you want to apply on a particular user defined area. At the last of the acquisition, we will give you kind of one notification what is the full width half maximum interpretation value is there. So you can before the acquisition only you can able to get the idea whether your acquisition going to be correct or not. So like this kind of information is come, full width half maximum for this particular acquisition is 5 hertz, or so we prefer to keep it below 13 hertz actually on our acquisition. This is the method it will come. You can see the PB auto, pencil beam shimming auto. It means automatically it will define the slice under volume. Second, we'll get the PB volume where the user have to define the volume and correct it. Again, iterative is the first order where system will do the iteratively, it will acquire the B0 images and it will do the correction again with the user mode and the volume mode. It adapts in XYZ direction, the iterative shimming. It only perform your linear, so first correction only, and it only takes some of the minute during the acquisition. Pencil beam is the second order shimming I told you, and it will done in 9 direction. So the accuracy will improve more, and generally we used to prefer this kind of technique on 3 Tesla. It requires a minimal volume for our system is 25, 25, 25 in the acquisition part, and then we require time approximately 40 seconds for the second order correction. I'm going to close the slide, talk about 1 minute. The newer method we are implemented already. So there's a 2 package now came with this option. One is, as I talk about the laser and the vapor, which will actually improve your faster MR spectroscopy, you can able to achieve it. More robust water suppression is there. With the laser method, you can able to increase the localization accuracy. And with these methods, now on 3 Tesla platform, you can able to acquire your GABA peak as well, which is very much important for the psychiatric disease and the epileptic patient. I'm sorry for the time, and yeah, I'm closing the presentation here. If any questions, just let me know.
Thank you, Mr. Mishra, for a nice presentation. Now, any questions from the audience?
LC model and GMRUI, like any comments on post-processing of these things?
Sir, post-processing free model from Philips, it is not there.
It's not, it's paid.
It's not
okay,
there,
yeah.
but there's a workshop planned in the coming session. We want to show you the spectroscopy.
Oh, today evening?
Yeah, today evening.
Wonderful.
So in that workshop session, we also show you the spectroscopy, how it works in the workstation. So all the manual work, we have removed it. Reason because a lot of feedbacks was there from the customer. It's a very difficult task to achieve with all the technologies. So we have removed all the manual method. Now you have option for the baseline correction, first order, second order correction as an default application, but even the application do it everything by itself only. So that during the workshop session we'll show you how it works.
All right, thank you.
Thank you so much.
If there is no questions, then we are going to close this session. This was a wonderful session, and it is for all the radiologists and clinicians. This is the foundation of basically imaging. And if you learn what are the basic principles related to physics of MRI and various sequences, this will be a great learning. And it has been nicely presented by all 3 speakers. Thank you.
We extend our sincere appreciation to each of you for the incredibly insightful talks. Let us go on to invite our chairpersons to once again felicitate the speakers.
I would like to invite Colonel Dr. Narendra Kumar Jain, sir, to please come on the dais.
I request Mr. Rohit Mishra to please proceed to the dais. Now for felicitation of our chairpersons, next we would like to invite now for felicitation of our chairpersons, next we would like to invite Professor Anit Parihar sir to felicitate Professor Chitir Srivastava sir. Professor Manu sir.
Thank you, sir. It's now time to cater the call for lunch. I would request you all to kindly proceed to the hall for lunch. We'll reconvene after lunch for more enlightening session. But until then, enjoy your meal and let's meet at 1:45. We would also like to remind you about the quiz session that is about to happen very soon. So respective colleges,
Bas, sir,
please
thoda
form your
lunch
team
kar
of
liye,
4 and provide your name to Dr. Shakib and Dr. Nitin.
Just one more thing to announce. We will start a session at 1:35 sharp, because other session chairs has to go. Another thing is, I heard like BHU residents has to go back. So there is a prize distribution also. So you can, they have to leave at 3. So we'll announce the results pretty early and then quiz and then you can go. Take. Yeah. We'll see how it'll go. Yeah.
हेलो हेलो हेलो
एलईडी चल जाएगी ना क्योंकि चार्ज करा रहे हैं
हेलो हेलो
ऑफ कहाँ से
म्यूट को
स्क्रीन के नीचे हाँ वही
हेलो हेलो
लंच चल रहा लंच हाँ निपटा लेंगे भैया कि पहले यार देख लें हाँ जैसे बात करके मैं बताऊँ तुरंत ठीक ये हजरत में रही कहाँ जानते रही में सब्जी मंडी है बीच वाली चौरसिया मार्केट में भी देखा है हम घर से करते मेरे पास VHS था MD9 था सोनी का हैंडी था इसमें यही लेटेस्ट लेने थे तो लिया नहीं कैमरा भी हमने है क्यों काम हिसाब से है पैसा पड़ा 15 लाख 1.5 लाख का कैमरा लिया 60-70-80 हज़ार का काम किया प्रोफेशनल फिर 2 साल बाद लॉन्चिंग हो रही नई कैमरे की मेहनत तो ब्लॉक होता जाता है हम लेंगे तो स्टिल भी लगा देते काम चलाओ चाहिए कोई छोटा मोटा फंक्शन फंसता है लेकिन भेज देते हैं कर जाएगा 3000 था 3500 था कुछ में
Hello and welcome back. Hope everyone enjoyed your lunch. Without further delay, let's dive into the heart of our conference. So fasten your seat belts as we are about to start session 4 themed on cardiac and perfusion MRI.
I request the chairpersons of the session, Professor Manoj Kumar sir, Professor, Department of Radiodiagnosis, KGMU, Professor Monica Bhandari ma'am, Professor, Department of Cardiology, KGMU, and Professor Neeraj Sinha sir, Professor and Dean, Department of Biological and Synthetic Chemistry, SGPGI, Lucknow, to grace the dais and introduce the speakers.
I would now invite the first speaker for this session, Dr. Siddharth Mishra. He is an assistant professor in Department of Radiodiagnosis and Interventional Radiology, KGMU. He did his MD Radiodiagnosis and PDCC Fellowship in Vascular and Interventional Radiology from SGPGI, Lucknow. He is an experience of more than 7 years in the field of vascular and interventional radiology. He is a fellow vascular and interventional radiology from SGPGI. He has interest in peripheral vascular interventions, peripheral angioplasty, embolization and intervention in CKD patients, and central vein recanalization and fistuloplasty. To Dr. Siddharth Mishra.
Thank you, madam. So I will be talking on cardiac MRI techniques, and as the name suggests, this presentation will be more technical. So the outline for the talk is first we will see how patient is prepared, then the scan protocols from basic to advanced, and finally the real-time scanning of cardiac MR. So moving on to the patient preparation. So at least 2 hours of fasting is preferable. If stress cardiac MR is planned, then make sure the smoking and caffeine are avoided for 24 to 48 hours, and ask for the history of asthma, because adenosine is contraindicated in patients with asthma. And any history of contrast reaction should be sought, and EGFR calculation should be done, and patient should have good renal function, at least EGFR of more than 30 ml per minute. So heart rate is not a problem for most of the scanners, but heart rate of less than 50 beats per minute is a problem, because then the breath hold times will increase drastically and the scanning time will become longer. Also, the claustrophobic patients, they have difficulty spending the time because the scan times are longer, about 40 to 45 minutes. And the technician should, or the resident should give breathing instructions to the patient. The typical breathing instruction is breathe in, breathe out, and then hold your breath. सांस लीजिए, सांस छोड़ दीजिए, और अब सांस रोक लीजिए. So the breath hold sequences are done in and expiratory phase. Measuring the height, weight, and GFR of the patient are of utmost importance, because in cardiac MR, the index volumes are calculated on the basis of body surface area, and body surface area, it is derived from height and weight. Also, the specific absorption rate that the MRI scanner gives, it is also based on the weight of the patient. Again, GFR is calculated, which is important for the adverse reactions on and the kidney functions. So again, the instructions to the patient: explain properly what is the time spent in the scan. So most often the time that the typical cardiac MR desires is about 40 to 45 minutes. And breathing instruction I have earlier told you, and patient should remain immobile for the duration of the scan. The information that we should have prior to the MR scanner are any ECG or echo reports and angiography reports, or if the patient is of a congenital heart disease. So in such patients, if there is any history of any previous surgery. So patient chest should be shaved because it is preferable that it is shaved because then attaching the ECG leads will create a problem. And ECG leads, preferably we should use MR compatible leads, graphite ECG leads, and the metallic ECG leads should not be used. This is the typical position of ECG lead placement in Philips and GE scanner, and the ECG leads should not be entangled with each other. This is the positioning of electrodes in the Siemens scanner, and it is the electrodes are typically L-shaped, placed L-shaped around the heart. And here the patient is keeping his arms by the side of the body. So arm should be kept by the side of the body, and soft music will play a role such that it will make the patient immobile for some longer duration of time. So scan protocols, we have to tailor our scan protocol according to the indication. So the major indications are to assess the function of the heart, the cardiomyopathy, and the viability. So the bare minimum scan is, which we have to do in every cardiac MR patient, is to assess the function. So other major indications are cardiomyopathy and viability. So when we are assessing the function of the heart, this is the typical protocol which gives the functional assessment. So the 3-plane localizer is the first sequence, then the axial black blood sequence in the axial plane of the chest, then white blood coronal static images which are in the orthogonal plane of the chest, then 2-chamber, 3-chamber, 4-chamber, and short axis and aortic valve cine images. Aortic valve images are taken in 3-chamber view or the LVOT view. So these are cine stacks, means these are movie-like images. And short axis cine stacks I have highlighted because these are the workhorse for the functional assessment of the heart. So all the volume calculation, the ejection fraction, the left ventricular mass, this is calculated on short axis cine stack images. The phase contrast images are used for calculating the Q flows, the Q flow of the aorta and the main pulmonary artery. So this is the bare minimum which we have to do in all cardiac MR scans. Then after that, if the patient indication is for cardiomyopathy, then apart from function, which is the bare minimum, we have to do some more sequences, like we have to do stir to look for myocardial edema in 2-chamber, 3-chamber, 4-chamber, and 3 short axis imaging plane slices. Then if we have to assess the RV volumes, so typically our 2-chamber views are for left atrium and left ventricle. But if we want to assess the right ventricular volumes, like in arrhythmogenic right ventricular cardiomyopathy, ARVC, so we have to add another sequence which is axial cine stack and the RVOT views, which gives the volumes of right ventricle. So to see the scarring and fibrosis within the myocardium, delayed enhancement imaging is done, and T1 mapping and T2 mapping is also done. So T1 mapping provides the extracellular volumes, and T2 mapping provides the early myocardial fibrosis and provides the information about myocardial edema. So another indication is viability and ischemia. Again, function, the sequences which are required for functional analysis should be done, and then the stir images are obtained in 2-chamber, 3-chamber, 4-chamber, and in 3 short axis planes, and 3 short axis planes are basically at the basal cavity, at the mid cavity, and at the apical cavity. Then the perfusion scans should be done ideally in stress perfusion mode by adenosine stress perfusion, and this perfusion is the first pass perfusion within the myocardium, and it shows the myocardial perfusion defects in cases of ischemia. Then again, the delayed gadolinium enhancement images, they provide the distinction between the dead and the viable myocardium. The dead myocardium or the non-viable myocardium on delayed gadolinium enhancement images, it appears as bright. Again, congenital heart diseases, again function is to be done, and then axial cine stack from arch to apex is done again for right ventricular assessment. Contrast angio is done for aortic dimensions and for MAPCAS. the post-contrast 3D T1 vibe or Dixon sequence is done for extracardiac structures, and when we are unable to get the planes in the typical cardiac axis like short axis planes and 2-chamber, 4-chamber view, so in such patients we have to plan a true coronal and sagittal cine stack images, because we are unable to plan the planes in the normal cardiac axis. So other scenarios, so mass, thrombus or pericardial pathology. This is one condition in cardiac MR in which we use typical T1, T2 and post-contrast T1 sequences. So until now we have seen the black blood images, the white blood images, but typical T1, T2 images are used when we have to characterize a mass or a thrombus. Otherwise, the normal T1, T2 sequences are less often used in cardiac MR. In constrictive pericarditis, the short axis dynamic fast free breathing cine images are used, because this is the sequence to evaluate for septal bounce, which is found in constrictive pericarditis. If we are dealing with iron deposition like in thalassemia patients, so to assess the iron deposition, we have to have an image apart from functional analysis and other sequences. We have to have a T2 star sequence in the mid cavity level in short axis plane, and actual T2 star image of the liver for iron quantification. For hypertrophic obstructive cardiomyopathy, we have to have a 3-chamber cine and LVOT view with higher number of phases reaching up to 40. So in hypertrophic obstructive cardiomyopathy, this sequence shows us the typical systolic anterior motion of anterior mitral leaflet, which is the characteristic finding of hypertrophic obstructive cardiomyopathy. The AV valve is assessed by having 3 thin slices across the aortic valve, and then for I told it earlier, for ARVC patients, for calculating the RV volumes, because it is RV volumes, this is in the major criteria for the diagnosis of ARVC. So for calculation of RV volumes, we have to take axial cine stack from arch to apex. This is white blood image. So now we will move on to the live real-time scanning of cardiac MR. And the objective is to show the basic steps in cardiac MRI, how we will do the cardiac MR and how we will plan the basic imaging planes of cardiac MR. So I think the video is not running in the PPT format, so I will switch over to the video directly. So this will take around 20 minutes from now. So I think it is visible here. So user interface may vary with different vendors, but the imaging planes for cardiac assessment, they are almost same. So first we have to select the patient, enter the patient details, and the important thing is we have to enter the height and weight of the patient, because it is required for index volume assessment after we have done the functional analysis, and weight is also required for specific absorption rate. After this is done, so first and most important thing is to get good ECG and respiratory gating. So to get the ECG gating, we have to start the calibration. So what calibration does is, calibration provides us with a tall and sharp R waves, and these R waves, they trigger our ECG gated scans. So calibration is done for ECG gating. So first sequences that we plan is the survey images in true axial, coronal and the sagittal plane of the thorax and upper abdomen. So these are the survey images. And on the survey images, we will plan the first sequence, which is axial black blood image. Axial means it is in the orthogonal axial plane of the chest. So axial black blood images cover the entire chest. The yellow box which we are seeing is the shimming box, and shimming box is required because the heart is eccentrically placed in the thorax. So there are a certain magnetic field inhomogeneities within the area of the scan. So what shimming does is it makes the magnetic field homogeneous, and so the artifacts and phase wrapping is minimized. So black blood image is planned. Then next sequence that we have to plan is oblique sagittal images. Oblique sagittal images should not be confused with the true short axis images, because here it is written as SA, but this is not in the true short axis plane of the heart. So the proper term is oblique sagittal images. So we are planning the oblique sagittal images by drawing the plane perpendicular to the left ventricle. So this plane is perpendicular to the septum and the lateral wall, and also it should pass perpendicular to the aortic annulus. So this will give us the oblique short axis view, perpendicular to the left ventricle, passing perpendicular to the lateral wall and the septum, and perpendicular to the aortic annulus. So this is the black blood image which we have planned earlier. It has come now. So we will move this actual black blood image to the image planning window so that we can plan other sequences. Now on this actual black blood image, we will plan the two-chamber view. So two-chamber view is planned by keeping the plane passing through the left ventricular apex and bisecting the mitral wall. So this is the actual black blood image. We will keep this plane along the left ventricular apex, and which will bisect the mitral valve. So this will give us the two-chamber view or vertical long axis view, VLA view. And on the coronal survey images, the plane should be perpendicular to the diaphragm. And now we've got the oblique sagittal images, and we have put it into the planning plane. And for two-chamber view, the plane should be parallel to the interventricular septum. So now we have planned the vertical long axis view. So it is known as two-chamber view because it will provide us with the left atrium and the left ventricle. So it is known as two-chamber view. Two-chamber view of the right ventricle can also be planned in the similar fashion if we want the information about the right ventricle. After this, we have to plan the four-chamber view. So four-chamber view, again, it is planned on two-chamber view, which has come now. So the plane, again, it passes through the mitral valve and the left ventricular apex. And on the oblique sagittal images, the plane should pass through the junction of anterior and the inferior right ventricular wall, and it should bisect the septum. And we have to keep in mind that the plane should not cut through the aortic root when we are planning the four-chamber view. So four-chamber view means in this image we will see the right atrium, right ventricle, and the left atrium, left ventricle. Now we are planning the three-chamber view on this four-chamber view. Again, we will keep the plane bisecting the mitral valve and going through the left ventricular apex, and in the oblique sagittal plane we will keep the plane which cuts through the aortic annulus into the ascending aorta. So this will give us the three-chamber view. Three-chamber view means we will see in three-chamber view the left atrium, left ventricle, and the left ventricular outflow tract along with the aortic valve and ascending aorta. So this is the three-chamber view, the left atrium, left ventricle, and the ascending aorta. This is the LVOT view. So this view is very important in cases of hypertrophic obstructive cardiomyopathy to see the systolic anterior motion of the anterior mitral leaflet. Now we are planning the true short axis view. So true short axis view is planned on 4-chamber view and 2-chamber view. The plane should bisect the left ventricle. The plane should bisect the left ventricle in the 4-chamber view and in the 2-chamber view. So it will go perpendicular to the septum and the lateral wall, and here it will go perpendicular to the anterior wall and the inferior wall in the 2-chamber view. So in 2-chamber view, this is the anterior wall of the left atrium, left ventricle, and this is the inferior wall. Whereas in the 4-chamber view, this is the septum and this is the lateral wall or the free wall of the left ventricle. So meanwhile, we are also doing the shim align to reduce the artifacts. Then we will plan what is known as LVOT view. So for planning the LVOT view, we require only 3-chamber view. So the plane is passed through the ascending aorta and the aortic annulus. So this is the planning for LVOT view. So this is the short axis image in the mid-ventricular cavity that we have planned in true short axis plane. Now these are the non-contrast sequences. Now we will move on to the post-contrast sequences. So the first post-contrast sequence which is done in this patient is dynamic perfusion imaging. This perfusion imaging is done under adenosine stress. And the plane are again the short axis plane in which perfusion is done. Only 3 slices are planned because we have to have the acquisition on all these 3 slices in single RR interval so that the myocardial perfusion is best assessed. So only 3 slices are planned in short axis plane for myocardial perfusion. So first the dummy run is planned, and when the dummy run shows no evidence of any artifacts, then we will plan for adenosine infusion. After adenosine infusion, if there is a response, then we will inject the contrast. So this is the typical short axis plane in which the perfusion imaging is done, and this is the mid cavity level. After getting the so perfusion scan is run after injecting the contrast. The contrast first comes into the right-sided chambers, then into the left ventricle, and then it slowly perfuses the myocardium. We are getting the perfusion defects in the myocardium. So perfusion defects are seen in the septum and the inferolateral wall of the myocardium. As well as if you see in these images, there is thinning of the anterior wall, the apex, and the inferior wall in some segments. So this is the stress perfusion MRI using adenosine, and it is showing the perfusion defects suggestive of ischemia in the septum and the inferolateral wall. Now we have injected the contrast, and to obtain the delayed enhancement images, we have around 10 minutes to do the delayed enhancement images. So these 10 minutes are utilized for acquiring the short axis cine images. So short axis cine images are again planned from the base of the heart to the apex. without interslice gap. And these images are cine images. So this cine image is in the mid cavity level because we are seeing the papillary muscles. And these short axis cine images are the, I have told earlier that these are the workhorse images on which we do the functional analysis. These images provide the left ventricular volumes, the stroke volumes, the ejection fraction, and these also provide the regional and global wall motion abnormality analysis. So I will be concluding in 2 or 3 minutes because the video is about to end in next 8 minutes, I think. So I will end in 2 to 3 minutes. So I will move on to quickly when these short axis cine stack images are planned. So meanwhile, when we are waiting for the dynamic delayed contrast enhanced images, so we do other sequences like QE flows for aorta and main pulmonary artery. And now I will quickly move on to the delayed enhancement images. So for delayed enhancement images, again, they are taken in short axis plane, in the 2-chamber view and in the 4-chamber view. So these are planned after 10 minutes of contrast injection. So these are the images which are showing the bright myocardium. So in delayed contrast enhancement images, the bright is dead. So bright myocardium shows this myocardium is not viable due to acute MI, due to chronic myocardial infarction, which is patient was suffering from chronic MI. And these same segments are showing the thinning on 2-chamber and 4-chamber view. So I think I will end this talk. So thank you.
Thank you, Dr. Siddharth, for this elaborate presentation on cardiac MRI. Cardiac MRI is a very important tool for the assessment of the left ventricular volume and functional assessment. And regarding congenital heart disease, it is also very important because sometimes echo is not sufficient to diagnose various complex congenital heart diseases and the evaluation of MAPCAs, because in echo we are not able to correctly identify how many MAPCAs are there, and it is very important for the planning of the surgery in tetralogy of Fallot, because these MAPCAs have to be dealt with before taking the patient for the surgery. And before knowing the information about these MAPCAs, we can plan the surgery. And regarding the assessment of the cardiomyopathies, again it is very important because for example, hypertrophic obstructive cardiomyopathy, in many instances it is because of autosomal dominant defect, genetic, but sometimes it is not. So it may be because of some storage disorder, and it helps in planning the management in such situations. If it is because of amyloidosis, then we can plan the treatment accordingly, or some other disease like Fabry disease. So the plan of treatment is completely different if it is because of these storage disorders, and the other one, the autosomal dominant defect, the treatment is different. So and also again in coronary artery disease, it is very important, especially it helps in identifying, suppose what type of the scar or late gadolinium enhancement is there. It is subendocardial, mid-myocardial, so, or it is acute MI or tachysubocardiomyopathy, for example. I think it is subendocardial defect in tachysubocardiomyopathy. So in the assessment of, in these disorders, it is quite very helpful. Thank you. Any questions from the audience?
Thank you, sir, for a lucid presentation. I'd just like to add that cardiac MRI is not popular these days because it's taking long time for the evaluation. It's 45 minutes, but this is an ideal situation. In a clinical scenario, we do not require to do all these sequences because functional analysis newer generation echo is doing pretty well, and cardiologists are doing this, and they know what they are looking for, and they do not require the accurate assessment of the volumes and all those things. So if we avoid this functional part, then the cardiac MRI time will reduce very much. It can be, it's a very helpful for the cardiomyopathies. So if we tailor-made these sequences, then our time will reduce and effort will also reduce, because if you see, the maximum planning is required for functional analysis because the accuracy matters in that case. However, literature-wise, cardiac MRI functional analysis is better than echo. Second thing, this is a simple technique. It appears difficult, but it can be done in all the available MRI machines. It's a 1.5 Tesla machines, and with minimum effort, it can be done. In North India, we are not doing much, but in South India, it's very popular technique. And if you tailor-made all these things, then the cost will also reduce in cardiac MRI. Thank you. So it depends upon the questions. Like if you want only the delayed gadolinium enhancement, then the time will reduce. Now there are different time increase if you're doing a T1 mapping, T2 mapping also. So depending upon the, like most of the things echo can diagnose. But suppose there is, you want to evaluate a one mass. Now whether it is a fibroma, whether it is a fibroblastoma. So depending on these, the sequences are planned, and the time can be decreased. It's not the time.
For instance, suppose it is a coronary artery disease. Some patients nowadays, MINOCA, that is myocardial infarction and non-obstructive coronary artery disease. So whether it is because of tachycardiomyopathy, or if it is because of myocardial microvascular obstruction, or it is less than 50% stenosis, in that situation it is helpful.
Yeah.
We can do CMR, myocardial reserves also now.
Yes.
And FFR is invasive again. So it is a non-invasive tool. We can combine these things and get the diagnosis. So in that situation it is important. It is not important in each and every functional assessment.
Yes.
For ejection fraction, wall motion abnormality, echo is enough for.
And like a CT scan, it can also be used for a triple rollout also. For acute MI also, if you are doing just a stir sequence only, it's a very quick sequence. We can identify lot of the myocarditis and all those things can be diagnosed. So cardiac MRI per se doesn't require that much time. Depends upon the clinical situation, we can tailor-made.
So I want to announce one thing. If any technician from our MRI is sitting here, please make sure that the functional assessment is done in all cardiac MR scans, because we are giving nothing to the patients. The functional assessment is not done, and this bogus report is not required at all. So either stop doing the cardiac MRs, or you do with which is required and which is done.
Next speaker for this session is Professor M. Mahesh. Is it online talk? Okay. Huh? So then this is not the one. No. Mahesh PS is different than M. Mahesh. I think he is not Hopkins University. Okay. So I have the wrong sheet. So I'm sorry. So the next speaker is Mr. Mahesh PS for SCT IMST Trivandrum and Sri Chitra Institute of Medical Sciences, and he is going to talk about perfusion weighted MRI. And Mahesh holds the position of Senior Imaging Technician in MRI and Radiology Radiation Safety Officer at the Sri Chitra Tribunal Institute for Medical Sciences and Technology under the Department of Science and Technology, Government of India. It is located in Kerala. He has extensive experience, including the clinical role as a radiographer and MRI lead since 2009, and expertise in neuroimaging, cardiac imaging, body imaging, and vascular imaging. And he is actively engaged in research projects in the fields of synthetic MRI, intravoxel incoherent imaging, enhanced arterial spin labeling, myocardial T1 mapping and resting state functional MRI. So with this, Mahesh.
Thank you, sir, for the nice introduction. Very good afternoon to all. So today my topic is MR perfusion techniques. And at the onset, the definition of perfusion MRI refers to the delivery of blood flow to tissue or organ. I would like to cover the topic in such a way to include the introduction of perfusion options like dynamic susceptibility contrast, dynamic contrast enhanced perfusion, arterial spin labeling technique, some data processing steps, and the practical setup. So today morning we have a basic discussion about perfusion technique by Dr. Durga Uday Kumar. She talked about the basics of perfusion techniques. So why we need a perfusion, or what is the indication? What are the indications for perfusion? A lack of functional information with conventional MRI. The conventional MRI appearance in enhancing malignant brain tumors may be similar and may not indicate a specific diagnosis as such. Contrast enhancement is usually directly related to the progressively increased grade of tumor. Because these are some of the reasons why we depend on perfusion. And perfusion MRI helps in characterization and grading. And the options available for perfusions are mainly exogenous tracer methods with the use of a contrast medium, mainly under two categories: dynamic susceptibility contrast enhanced perfusion, otherwise we call T2 star perfusion, and dynamic contrast enhanced perfusion, we call it as T1 perfusion or permeability perfusion. And of course, we have endogenous tracer method also, like arterial spin leveling and intravoxel incoherent motion. So I'm able to speak all these things, the basic things. So before going deep to the perfusion techniques, let me say something about the blood-brain barrier and neoangiogenesis. So you may know what is blood-brain barrier. Blood-brain barrier is a highly selective permeable membrane that separates the circulating blood from the brain and extracellular fluid in the central nervous system. So normally, in normal conditions, this blood-brain barrier, you have a mouse, the blood-brain barrier may not allow these vascular components to the extravascular extracellular space in normal condition. But whenever a pathogenesis or a tumor develops, the blood-brain barrier will break and the vascular components will extravasate to the extravascular extracellular space. This is the extravascular extracellular space. This is the extravascular extracellular space, and this is the blood vascular component. Normally, it won't cross the blood-brain barrier. So once a pathogenesis is infected or pathogenesis is affected, a tumor develops, the blood-brain barrier gets activated, and it will be extravasated to the extravascular space. So actually, DSC perfusion or T2 star perfusion is to find out the neoangiogenesis. Neoangiogenesis is the formation of new blood vessels. So tumors may be highly vascular or maybe low vascular. Depending on the tumor, it may be a vascularity will be high, vascularity will be less. So neoangiogenesis is the study of the vascular behavior of tumor, whereas T1 perfusion or DCE perfusion is meant for the blood-brain barrier leakage or permeability. So once the contrast injected into the vascular system, if it is extravasated, then that will be get enhanced. If it is not, the blood-brain barrier is intact, that means no enhancement will be there. So these are the perfusion parameters: CBV, cerebral blood volume; CBF, MTT, and TTP are the perfusion parameters of T2 star, and K times, otherwise we call permeability constant; VE, VP, and KEP are the perfusion constants of T1 perfusion. Actually, analysis of T2 star perfusion is based on the assumption that contrast agent remains in the vascular lumen itself. That is, there is no blood-brain barrier breakage. So T2 star perfusion has been calculated in such a way that on the assumption that the blood-brain barrier is intact, but it is not true always. So coming to the effect of gadolinium contrast agents, as when contrast is injected, what are the changes occurring? The susceptibility induced distortion of magnetic field due to intravascular compartmentalization of gadolinium, which may cause signal loss in a T2 star weighted image and a signal gain in T1 weighted image. Normally, the sequences used for perfusion, T2 star perfusion is spin echo EPA and gradient echo EPA sequence. Two sequences, both sequences we can use for T2 star perfusion. but the standardized protocol is gradient sequence. And the physiological process is when contrast is injected, field distortions are caused due to the, in the space of decreased T2 and the attenuated signal. So these field distortions are responsible for the signal drop. And about the contrast selection, so we have different types of contrast media and classified into macrocyclic contrast media and linear contrast media. In the bracket, you can see the relaxivity of that particular contrast medium. So in some articles, it is suggested that if you are using a lower relaxivity contrast medium, or if you are doing the perfusion in a lower strength MRI, a gradient DSC MRI is recommended. But if you are using a higher relaxivity contrast medium, or a higher strength MRI like 3 Tesla or 7 Tesla, then a Spinnaco DSC MRI is standardized. So nowadays, the European Society of Radiology has banned the use of linear contrast media. So in most of the centers, macrocyclic contrast media are being used. So coming to the general steps of DSC perfusion, so susceptibility effects due to the gadolinium contrast will occur, which will directly give the time signal curve. The time signal curve will generate a tissue concentration time curve, and thereby we get a cerebral blood volume directly from the image itself. But we are not getting any other parameters. We can qualitatively analyze the perfusion by CBV directly from like this method. From this, we are generating the arterial input function using a theory called the indicator dilution theory. And we are generating a tissue response function. These are some of the sophisticated mathematical algorithms happening inside the software. And we are generating a tissue response function. This tissue response function will generate cerebral blood flow and mean transit time. So initially, qualitatively, we are getting only the cerebral blood volume. And later, with the help of arterial input function and a deconvolution technique, the MTT and cerebral blood flow are being generated. So these are the steps. Deconvolution of arterial input function derived from tissue concentration is needed to determine the MTT. So actually, deconvolution is a mathematical process that removes the arterial input function from tissue concentration. And arterial input function is something called input profile of contrast agent. Then what do you mean by relative and regional CBV? See, many times you must have seen that it is mentioned as RCBV or RCBF. What is meant by relative? So actually, absolute quantification is not possible in a T2 star perfusion. So what we are doing is a semi-quantitative semi-quantification. Why absolute quantification not possible? Because certain uncertainties are there due to the hematocrit of the patient. It may be different. It is not a constant in all patient. Patient by patient, the hematocrit will change due to brain proton density constants, then relaxivity of contrast agents, then recirculation of gadolinium because of the permeability, the blood-brain barrier breakage, relaxivity, the recirculation will be there. So certainly there are correction factors are there. Because of these reasons, absolute quantification of T2 star perfusion is not possible at all. So that is why we are using the term relative CBV. So relative CBV is referred to a value that is normalized to a normal tissue in the contralateral white matter. So you have a regional CBV also. So once you quantify it, you semi-quantified using the arterial input function and all, you call it as a regional CBV. So relative CBV and regional CBV is somewhat different. So when you're qualitatively analyzing the perfusion, we'll call it as a relative CBV or CBF. Then coming to the practical setup, what are things we have to take care? We should plan in such a way that the same number of slices should be there as that of the routine images. That's a must. Phase encoding direction should be anterior to posterior. Normally in routine axial images, the phase encoding direction will be from right to left, but in perfusion it is from anterior to posterior in order to reduce the time, because we don't need a good spatial resolution in perfusion images. So we are keeping the phase encoding anterior to posterior. 50 or high measurements, then wait for 5 to 7 seconds for the baseline and bolus injection. And finally, we check for qualitative and semi-quantitative analysis. These are the practical steps included what we do for DSC perfusion. And coming to the injection protocol, a 18 to 20 gauge needle is recommended. A right antecubital injection is preferable to avoid left jugular vein reflex. So it is always better to put a right antecubital IV line. The contrast dose should be between 0.1 to 0.3 millimole per kilogram, and preferably should be given by a pressure injector itself. The injection should be commenced after 5 to 30 milliseconds, and flow rate should be 3 to 5 ml per second. If the flow rate is below 3 ml per second, then you won't get a good perfusion. And saline flush should be at least 20 ml with the same flow rate as that of the contrast media. No, these are the parameters what you are getting after the T2 star perfusion, globus bolus sport, otherwise we call it as signal intensity curve, percentage of baseline, we'll see one by one. So this is a globus bolus sport. In some vendors they are using the term signal intensity curve, in Siemens they are using global bolus sport. Here you can assess whether you get a good perfusion curve or not. If 30% dip in curve is there, then it means that you are getting a good curve. If 30% dip in is not seen, then it is a bad curve. The perfusion values may not be accurate as such. Then CBV is a cerebral blood volume. It is defined as the amount of blood per 100 grams of brain tissue. This is called cerebral blood volume. So CBV represents the neoangiogenesis. That is, it will give the detail about newly formed, the newly sprouted blood vessels. So the normal value of CBV is about 4 ml per 100 gram of tissue. For white matter, it is 2 milliliter per 100 gram of tissue. And then comes the CBF. It's a volume of blood flowing through 100 gram brain tissue in 1 minute. And its unit is milliliter per 100 gram per minute. So the normal value in gray matter is 75 ml per 100 gram per minute. And in white matter, it is 25 ml per 100 gram per minute. And for ischemia, it will be less than 20 ml per 100 gram per minute. And there's something called percentage baseline at peak. So normally the radiologists look for CBV and CBF. So these parameters are there. In certain articles it is mentioned that relevance of these parameters. But normally, generally, they look for the CBV and CBF. Percentage baseline at peak means it's the amount of signal loss at peak time. Then something called arrival time, that is the total time or the interval between intravenous contrast injection and its first detection of contrast between tissue, that's called arrival time. Then time to peak, it's defined as the time from initial contrast injection to peak signal intensity. Then mean transit time, that is the total time the entire bolus of injected contrast to pass through the particular tissue, that's called mean transit time. And what are the clinical applications of DSC perfusion? The common clinical application for DSC perfusion are glioma grading, then the dedifferentiation of tumors, biological activity to differentiate between demyelination and lymphoma. So these are some of the important clinical applications of DSC perfusion. So in 2015, the American Society of Functional Neuroradiology Society recommends they standardized DSC perfusion. Before that, no standardization of DSC protocol was there, but they recommends this recommendation, in that they mentioned that the slice thickness should be 3 to 5 millimeter. Then the injection rate should be at least 4 ml per second. And another important thing is for the correction of this recirculation and all, they suggest the flip angle should be maintained at a 30 degree if you are not giving or not giving a preload contrast. So they recommend to give a preload contrast before T2 star perfusion, and the flip angle should maintain at 60 degree. If you are keeping if you are not keeping in 60 degree, you can keep it 30 degree without giving a preload contrast. That is to maintain it is a correction factor for recirculation of contrast media. So it is mentioned here, a single dose of 0.1 millimole per kilogram is given 5 to 10 minutes prior to dynamic imaging. Then there are certain disadvantages with DSC MRI also. There is it is unreliable for calculating the absolute quantification and permeability. Contrast recirculation is there, so we may not get an absolute quantification as a contrast leakage and tissue enhancement issues are there. Susceptibility artifact. And how you know whether you got a good CBV maps or CBF maps? You can check the most you can check the CBV values in the ventricles, or if you are getting increased CBV in ventricles, that means your bolus administration is wrong, that you have given a wrong contrast dose or a wrong flow rate. Thereby you can check whether your perfusion values are correct or not. Then next is about dynamic contrast enhanced imaging or T1 perfusion. So the morning session we have heard about the dynamic contrast basics about dynamic contrast enhanced perfusion. So I said before that whenever a blood-brain barrier leakage is there, the contrast is extravasated to the extravascular, extracellular space. So to calculate this permeability or how much leakage is there, we are doing T1 perfusion. And what are the other indications? There is something called pseudo-progression. You might heard about that. I mean, the technologists, if any are sitting there, you might heard about the pseudo-progression. It is a condition in which after radiotherapy or chemotherapy, if you do the scan within 6 months or 9 months, due to the fibrosis of blood vessels, the tumor will get enhanced. It will mimic a tumor recurrence. or it will mimic a tumor recurrence, and the radiologist may he may mistakenly say it as a tumor recurrence, but it may not be a tumor recurrence. It will be a pseudo response. It is happened due to the fibrosis of blood vessels or fibrosis of this newly formed blood vessels. So if you do a T1 perfusion or dynamic contrast enhanced perfusion, you will be able to know whether it is a pseudo progression or a true progression. So if the permeability is more, then it will be a pseudo progression itself. Or if the permeability or the K-trans value is less, then it is a pseudo progression. Similarly, pseudo response also there. That means the tumor will shrink. The tumor size will get shrinked after radiation or chemotherapy. Then also you can do a T1 perfusion and can finalize whether it is a pseudo response or a true response. So the practical setup, the ideal contrast dose is 0.1 millimole per body weight, and preferably using pressure injector. And flow rate should be 2 to 4 ml per second. Please remember the flow rate for DSC perfusion is minimum it should be 3 ml per second, but for DSCE perfusion it can be 2 ml per second. And a saline flush, a minimum of 10 ml should be given at the same flow rate. So the general steps include, it's a steady state T1 weighted sequence. In the other hand, for T2 star perfusion, we use a spin echo or gradient echo APS sequence, but here it is a steady state T1 weighted sequence like SPGR or something like that. Then we do a perfusion baseline T1 mapping, T1 imaging. That is before contrast injection, we are acquiring some images. Then during the administration of gadolinium-based contrast agents also, we are acquiring the images. And after the administration, we are getting that images. Then these signal intensity are converted to the gadolinium concentration, and we determine the vascular input function. And perform the modeling technique called pharmacokinetic modeling. You might have heard about this modeling in the morning session. So I said before, this is the vasculature and this is the extravascular extracellular space. And what is permeability? See the transfer contrast, how much leakage is from this intravascular space to extravascular extracellular space is called a K-trans or permeability constant. So this is the value where you, which will give the direct relation of the leakage. So there are different interpretations depending on blood flow and permeability. So there is no perfect value like CBV or CBF, as I said before, because it depends on the permeability. Because if high permeability is there, then K-trans reflects the flow, and if the low permeability is there, then the K-trans reflects the permeability. So K-trans means simply the transfer constant of contrast medium or the vascular component from intravascular space to extravascular extracellular space. Then something called VP. VP is the plasma volume. This is the volume of the vasculature. That is the plasma volume. Then VE is the ratio of contrast agent quantity leaked into the extracellular space to that of plasma. Simply we can say VE is the volume of extracellular extravascular space, because all these ratio are of minimal difference. And KEP constant is the rate of contrast which is moved back to the plasma from extracellular space. So K-trans is the permeability from vasculature to the extravascular space, and KEP is the transfer constant from extracellular space to the vasculature. And you have two techniques for the calculation process. One is called initial area under the time intensity curve, that is called IAUC, and another technique is called pharmacokinetic model. So in some articles it is mentioned that IAUC technique is used for this outside CNS, means for breast imaging, breast perfusion, and for prostate perfusion, and all the IAUC technique analysis is being used. For CNS tumors and for CNS perfusion technique, normally pharmacokinetic modeling is used. Pharmacokinetic model means two compartment model, that is one is blood plasma and one is extravascular extracellular space. And in pharmacokinetic model also certain steps are there called genetic tissue model, conventional Tofts model, modified Tofts model, which is these all things explained today morning, and Putlock model, of which the modified Tofts model is what it's following by in CNS tumors as such. Then clinical applications include brain neoplasm, metastatic lesions, radiation necrosis, pseudoprogression and pseudoresponse, and cerebral vascular disease. And something about arterial spin labeling also. Yeah, arterial spin labeling is a technique whereby you are not giving any contrast media for the perfusion results. Simply the blood itself is acting as an intrinsic tracer for getting the perfusion result. But the only thing is it is an absolute quantified value what we are getting, but the value what we are getting is only for CBF. So mostly it is related to for this CBF calculation, to find the high CBF values in epilepsy cases or in dementia, Parkinsonism, where any high flow is there. Like that. So technical route, basically two images have been taken, 2 steps of images have been taken, and one is called a labeled images, where you are applying an inversion, an adiabatic, flow-induced adiabatic RF. Flow-induced adiabatic RF means specially tuned RF pulses, in which only the flowing vessels alone will be affected. None of the other spins will be affected. That is called flow-induced adiabatic pulse. So these flow-induced adiabatic pulses are applied to invert the spins, so that it will spin to 180 degree inverted, and after a particular time, the brain is being acquired. So this time delay between the inversion pulse and acquisition is called a post-labeled delay, and you will get a control image, a labeled image, and finally you take a control image also. That means without a adiabatic pulse, you simply acquire the images and you get a control image. This control image is subtracted from the labeled image to get the final CBF or the cerebral blood flow. So the cerebral blood flow, once you get the raw images, it is get fused with a 3D volumetric images, and it can be correlated with other anatomical images to find whether any increased CBV is there or not. So I'm concluding. So these are the this conclusion. Whether a need of perfusion is not overstated. DSC still remains the gold standard, and encouraging results with the DC is there. ASL has an advantage of an absolute quantified value as such, and IVIM is still in research stage. Thank you.
Thank you, Mahesh. Very nice, very illustrative overview you have given. Any question from a house?
In routine protocol, we are not giving any preload, but the flip angle, their correction they are recommending, if you are not giving the preload contrast, it is advisable to keep the flip angle to 30 degree. Normally, the in protocol, if you check, the flip angle will be 90 degree. If you are giving the preload, then the flip angle should be 60. If you are not giving the preload, then they are standardized in such a way that the flip angle should be kept at 30 degree. You remember that our flip angle is 30 degree. Yeah.
In a T2 star perfusion, when the second pass goes, your baseline, above the baseline.
Yeah.
So in order to saturate that extracellular space, you might think of giving a preload in those kind of where you have a strong clinical suspicion that.
No other question, then Mahesh, thank you very much.
Thank you, sir.
For your nice lecture. Then we end this session.
Thank you, sir. The diversity of the perspectives and expertise you collectively brought to the discussion made the session truly enjoyable.
I now request our chairperson to felicitate our speaker. Thereby, I call upon Dr. Siddharth Mishra, sir, to kindly come on the dais. Mr. Mahesh, sir, I request you to please come on the dais.
Now for the felicitation of our chairpersons, next we would like to invite Professor Anit Parihar sir to felicitate Professor Manoj Kumar sir, Dr. Priyanka Yadav ma'am, Dr. Major Nitin Arun Dikshit sir. Looking forward to another round of precious clinical and academic exchanges, I would like to begin the next session on MRI methods and applications.
With a big round of applause, I would like to welcome our chairperson for this session, Professor Sandeep Tiwari sir, Professor and Head, Department of Trauma Surgery, KGMU, Dr. Priyanka Yadav ma'am, Assistant Professor, Department of Radiodiagnosis, KGMU, and Dr. Ashish Gupta sir, Additional Professor, Department of Biological and Synthetic Chemistry, SGPGI, Lucknow, to kindly come on the dais.
At the outset, I would like to thank organizers for giving me this opportunity to chair this session. And it is an important session on MRI methods and application. Our first speaker is Dr. Arjuman Jahan, who is Assistant Professor and Head, MNN Medical College, Prayagraj. Areas of interest are women's imaging, fetal imaging, and neuroradiology. Gold medal in radiodiagnosis in KGMU, published several original papers and case reports, and presented papers and posters in many conferences. So over to Dr. Arjuman Jahan.
Good afternoon, everyone. Before I start, I just want to thank Anit sir and Durgesh sir and other members of organizing committee for inviting me here on the dais, because it is the place from where I learned basics of radiology. Now to begin with the breast MRI, knowledge about the spectrum of tumor characteristics and patient outcome has made diagnosis of breast cancer more complex. Management has been tailored in all facets of breast cancer care. Pathologic positivity of surgical margins have been redefined. Genomic profiling is helping selecting receptor positive cancers just to maximize the techniques of treatment also. Duration of radiotherapy is being minimized by use of hypofractionated partial breast irradiation. Prospective trials are in place to evaluate whether active surveillance for low-grade DCIs may be viable alternative to surgery. And considering all this background, we the radiologists need to optimize breast cancer detection. And thus, for the advancements, now there is abridged MRI techniques have come into existence. These things I will be discussing in further slides. So why and when the MRI is needed? MRI has a predilection to capture higher grade and more invasive disease rather than more indolent disease. MRI breast is not a replacement for mammography or ultrasound imaging. It is only a supplemental tool for further evaluation. If possible, breast MRI should be performed after menstruation in second week of the cycle, This is because background parenchymal enhancement is relatively low in the 7 to 14 days of the cycle. I will be discussing it in further slides. So what is structural versus functional imaging? This slide is basically the differentiation between mammography and MRI. Mammography is structural imaging. It is limited by breast tissue density. We all know it depicts calcification and speculated mass very well. And digital breast tomosynthesis, which now is in very much use, it adds little in extremely dense breast. DBT also accentuates architectural distortion, and sensitivity for non-speculated rapidly growing tumor subtypes is relatively low in mammography. So what adds the MRI? MRI is functional imaging. It is not limited by breast density. Multiparametric MRI is based on use of contrast enhancement. It has superior soft tissue resolution and is enhanced by physiologic characterization of properties such as cellularity when we use the sequences like diffusion weighted imaging. So this slide shows the differentiation. This is a case of 48 years old female who has extremely dense breast. The lesion was somewhere here, but it was missed on mammography, which later on when the MRI was done on post-contrast subtracted image, we can see there was the presence of lesion here in this section of the breast. This slide is just showing the difference between screen film mammography. This is for the same patient who was undergoing screening, and earlier when first screen mammography was done, we could see how the resolution was. Then it was done digital mammography, and then came digital breast tomosynthesis. When in all these series we can see that density of the breast was very high, so mammography marks the presence of the lesion. So what are the indications of breast MRI? The most common indication in clinical practice is for screening and evaluation of breast cancer. Annual screening MRI of the breast is recommended in high-risk women such as those with a lifetime risk of 20% or greater, BRCA mutation carriers, untested first-degree relative of BRCA carrier, and history of chest irradiation between ages 10 and 30 years. In patients with already diagnosed breast cancer, MRI imaging is done for preoperative assessment of the extent of cancer, screening of contralateral breast cancer staging for treatment planning, monitoring tumor response to neoadjuvant therapy, and preoperative assessment for multifocal and multicentric disease. What are other indications? Those women who have dense breast, to differentiate between scar and recurrence, axillary nodal metastasis, and to assess the stability of silicone breast implants, and patients with nipple discharge. What are the contraindications? The contraindications for basic MRI are the contraindications of breast MRI as well. So contraindications to gadolinium-based contrast media, either due to allergy, pregnancy, or compromised renal function, inability to lie prone, marked kyphosis or kyphoscoliosis, marked obesity, extremely large breasts, implantable devices that are not MRI compatible, and severe claustrophobia. So coming to techniques, what are the principles of breast MRI? The use of MRI for breast cancer detection is based on the concept of tumor angiogenesis or neovascularity. Tumor-associated blood vessels have increased permeability, which leads to prompt uptake and release of gadolinium within the first 1 to 2 minutes after administration, leading to a pattern of rapid enhancement and washout on MRI. This dynamic rapid enhancement pattern helps to distinguish breast cancers from benign lesions. Coming to techniques, for breast MRI, the patient is placed in the prone position with the breast in the cups of the coil with judicious padding to minimize patient motion and transmitted vibration. Prone patient positioning minimizes the effects of respiratory motion on images and helps to move the breast away from the chest wall and resulting artifacts from cardiac and respiratory movement. So this is the breast coil, and this is the patient positioning while we conduct MRI breast. So what is the MRI field strength? The current recommendations require that the breast MRI be performed at 1.5 Tesla or higher. The higher field strength enables the acquisition of high resolution imaging with adequate signal to noise ratio and enables the use of fat suppression. Imaging at 3 Tesla provides an opportunity for even greater improvement in SNR, increased image resolution, and faster imaging. Breast MRI has evolved from primarily contrast-enhanced techniques to a multi-parametric technique in which T2 weighted and diffusion weighted imaging are routinely performed to ultra-fast and abbreviated MRI. Still, the basis for any MRI protocol is a dynamic T1 weighted contrast enhanced sequence. So MRI breast, earlier we used to do conventional full protocol dynamic CMRI. Now abridged MRI has come into existence. So what is the difference between the sequences which we acquire in abbreviated MRI and which we were acquiring in standard MRI sequences? So the concept was only to reduce the duration. So in abbreviated MRI, we have axial T2 weighted with fat saturation, axial pre-contrast T1 weighted with fat saturation, axial post-contrast T1 weighted image with fat saturation, post-contrast subtraction. So total acquisition time is around 8 minutes. And here sagittal and coronal images are not taken. And standard MRI sequence is a lengthy protocol and the total acquisition time is around 30 minutes. But still we are using both the both the techniques just to optimize the reporting. So this is an example. Now what we are doing in ultra fast MRI, we are seeing the initial enhancement kinetics. So the tumor basically enhances very fast. So this is the fast, medium or slow uptake of contrast material. I will be discussing this enhancement kinetic curves in further slides. So coming to our recent advance which has taken place in breast MRI, that is abbreviated MRI, it refers to a shortening of standard breast MRI protocol. By retaining only one post-contrast sequence, examination is streamlined. Ultra-fast MRI is a distinct imaging sequence to capture rapid initial contrast inflow at high temporal resolution, which is usually less than 6 to 7 seconds within first 2 minutes after contrast administration. Ultra-fast MRI techniques are not currently standardized and various approaches are used such as parallel imaging, wave sharing and compressed sensing. In clinical practice, twist is a technique which is used on a 3 Tesla imaging unit for ultra-fast imaging which has temporal resolution of less than 5 seconds. So what are the newer terminology which are used for ultra-fast MRI? Those are time to enhancement, maximum slope, initial enhancement rate and arterial venous interval. Time to, because the tumor enhances very early when the contrast is given, so time to enhancement is just the time which the lesion takes to enhance. The slope, the maximum slope and very steeper slope is concerned with the malignant lesions, and initial enhancement rate also says that how avidly the malignant lesion enhances. And arterial venous interval, now with the development in MRI techniques, we can visualize both artery and veins with maximal intensity projection images. So shorter arterial venous interval is also concerned with malignant lesion. So the malignant lesion have shorter time to enhancement, they have a steeper maximum slope, they have a higher initial enhancement rate, and they are associated with shorter arterial venous interval. What are advantages of abridged MRI? I will be discussing in the following sections like lesion conspicuity, functional depiction and discriminating power. So coming to one by one, studies have shown abbreviated MRI to be highly negative predictive with NPV of around 99.8% and sensitivity of 90.9% based on maximal intensity projection images alone. It preferentially increases the conspicuity of malignant lesions by imaging during the early post-contrast period. Tumor enhancement peaks usually by 120 seconds and background parenchymal enhancement peaks around 300 seconds. These timings can vary from machine to machine, and what the sequences we are using helps in detecting lesions in challenging locations such as retroareolar region, medial posterior region and axillary region. Functional depiction, new angiogenesis of abnormal leaky vessels and increased venous drainage, particularly in large high-grade breast cancers, lead to initial brisk contrast material uptake and rapid washout and MRI. Earlier we used to only see the washout kinetics, but now we are, with the help of ultra-fast MRI, we are seeing the early contrast kinetics. In addition to peritumoral vascularity, indicating metabolic and metastatic potential, whole breast vascularity is also altered by the presence of cancer, which can be well evaluated by MIP images. I'll be showing it in further slide. Vessel caliber is also an indicator of treatment response. Differentiation between artery and veins is now possible with high temporal resolution of ultra-fast imaging. Lesions with time to enhancement less than 10 seconds are likely malignant. Lesions with TT more than 15 seconds are likely benign. and lesions with TTE 10 to 15 seconds are equivocal. But many a time there is confusion and we had to correlate with pathological options. Lesions with early brisk contrast material wash-in, steep maximum slope greater than 13 to 29% per second, and bright enhancement with high initial enhancement rate greater than 183 are more likely to be malignant. But there are disadvantages of abridged MRI as well. So when there is greater temporal resolution, this comes at a cost of decreased spatial resolution as well. It is still possible that even limited spatial resolution may not actually impact detection in the setting of screening. There is some loss of sensitivity also, and it is attributed to the lack of later post-contrast sequence to capture slower enhancing cancers, such as low-grade in situ cancers, certain lobular cancers. Low to intermediate grade DCIs may not be visible on early post-contrast images even up to 100 seconds or more. Lobular cancers may enhance more slowly and less avidly. So this creates a condition of doubt in ultra-fast imaging. There are some benign confounders also, benign vascular or inflammatory lesions that demonstrate rapid initial early enhancement can mimic malignancy, such as papillary lesions, capillary hemangiomas, and intramammary lymph nodes. So coming to caveats, abbreviated MRI may not be appropriate for baseline screening in women with BRCA gene mutation. BRCA-associated cancers are more likely to have a typical morphology. Invasive cancers are more likely to appear circumscribed, mimicking fibroadenomas, and frequently manifest as non-mass enhancement. May miss late enhancing malignant diseases such as low-grade DCIs or invasive lobular carcinoma, which have tendency to show late enhancement. And abbreviated approaches are geared toward identification of aggressive disease in screening setting, but are not optimized for full depiction of disease. So what is the future of abridged MRI? Non-enhanced abbreviated approaches using techniques such as diffusion-weighted images are also being investigated, especially because deposition of gadolinium has been described in recent literatures. So this slide shows that though ultra-fast MRI is being used in some setups, but still it needs to be combined with delayed imaging so that we could evaluate the lesions in whole of the terms. So I'll show two cases, and I want to thank some of my colleagues working in private setup from where I could get these cases. This was a case of 35 years old female who presented with lump in right breast. This is the T1 weighted sequence, this is T2, this is T2 weighted fat suppressed sequence, this is diffusion weighted image, and this is ADC map. Now here we can see the lesion was also showing diffusion restriction, and the lesion was speculated, and the strands we can also see there was skin involvement. And now the purpose of the showing this case is just I'll show the use of last slide I said that MIP images can show the presence of arteries and venous enhancement and the patterns which is altered by the presence of cancer. Here we can say in right breast, the lesion is showing increased vascularity, but rest of the breast is also showing some abnormal vessels, which can really be compared from the normal breast where the vessels are decreased. So by the use of MIP image also, we can predict the type of the disease in the breast. And this is the graph which was taken in ultra-fast imaging, where we can see the lesion is showing rapid rise with decreased time to enhancement, and the lesion came out to be DCIS on pathological reports. This is the ultra-fast post-contrast sequence which was taken in early phases. And this is a case of 48 years old male who presented with a mass in right breast, and now here we can say the sequences are same. This is T1, this is T2, T2 weighted fat sub, and this is diffusion weighted, and this is ADC map. Here we can say there was no significant diffusion restriction. And now on MIP image, we can see the pattern of vessels, and this was the early post-contrast sequence in ultra-fast series. And now here comes the graph. Now we can see the graph which I showed earlier, it showed rapid enhancement, But the graph line which is seen in this image is in between slow and rapid rise. It is showing medium increase in contrast enhancement. So I have kept both the cases together so we can compare the contrast kinetics. Now you can see this line and this line. So this is showing relatively a rapid increase. And this was the case of that male patient which is showing this medium rise in the slope with persistent enhancement in delayed phases. And this is to summarize both the initial and delayed phases, how we are interpreting. So this was all about breast MRI. Thank you so much.
Thank you, Dr. Rajaman, for such nice and illustrative presentation, that too well before time. So I congratulate you, you have finished before time.
Thank you, sir.
And if there are any questions from the audience? So no questions, I think, from the Dr. Nitin.
So much.
Dr. Nitin. Stay, Dr. Arjuman. Dr. Nitin is having some
These
questions.
days we are talking about, my question is MRI still just a problem solving tool, but people in US are talking about screening MR memos. Do you see a validity in doing screening MR memos and all, or is it still a problem solving tool?
Sir, what I feel after reading so much and seeing the clinical implications, in our setup, I think it will not be better to just say that it is a screening tool. We cannot only rely upon MR mammography. We had to correlate, sir.
Arjuman, this is a great talk. This is Durgesh. So just to follow up with Nitin, I have a question. So nowadays, everyone is doing like abbreviated MR. That too again in screening, because in US, screening mammography is standard. So they pick the cancer at much early stage as compared to India, where, you know, patient present, because delay is very big problem in India, you know. So what do you suggest, like in future setup, like whether we should follow up in our setup, like abbreviated MR protocol to go, and what should be the minimum protocol timing and all, if you have any thoughts on that?
What I think after seeing like the patient, because the most big problem in our setup is we don't have like ultra fast sequence. Very few centers, still my college is also not having, and in KGMC also we are working on delayed MRI protocol only. So sir, I think it will take a bit time because availability is most important. If there will be availability of first MRI machine and sequences only, then we can standardize the protocol.
Thank you.
Okay. Thank you so much.
Next. Hello. The next speaker is Dr. Gaurang Pandey, and he's a consultant in the radiologist at the Pitambar Diagnostic and Wilson Medicity Hospital. He has completed his MD in radiology from KGMU, and he got several awards, just like a Best PG Student Award, first prize in case presentation at IRIA Lucknow chapter, as well as he is a Best PG student in the Padma Shri Dr. S.S. Sarkar oration.
So hi, good afternoon everyone. It's great back to the department. So I've just designed this primarily for the residents. That's what I was told, because our lives becomes artifacts once we ask questions on these in the seminar hall. So yes, going ahead with it, we'll go with 3 basic concepts and then we'll run directly into artifacts. I'll be a little quick. So we know that when we switch on the B0, the magnetic field, the net magnetic moment of the entire body gets aligned along the z-axis. Then we apply the RF pulse, which propels the NMV into the XY plane. This XY plane NMV recovers back to the Z plane. This is called T1 recovery. Also, all of them become coherent or in phase. And when the RF pulse is switched off, they start dephasing, and that is called the T2 decay, right? This is what we mean by in phase and out phase. I'm sorry, in phase and out of phase, right? So here you can see these clocks are in phase, right? So that's the basic concept. The same diagram explained again. Now, the pulse timing parameters TR and T. So basically TR and T, for us to understand, would be this. A TR is the time to repetition. A small binoculars we use to look at T1, whereas a T is a long telescope we look at T2. If neither of the combinations match, what we are left with is the proton density image. Okay, so just remember this. Spatial encoding. Now, so we have applied the B0 magnetic field, but for example, I have to reach to the left adrenal gland of my body. I need to do something to localize the signal till that point, and that is what is referred to as a spatial encoding. So upon the magnetic field, we will superimpose gradient coils in the X, Y, and the Z planes and do something with them to reach my left adrenal. Let's see what happens here. So these are the additional coins that we will superimpose in the planes described. Okay, so here is the bore, okay, and inside this, we have graded the magnetic field. So at one point it is strong, the other point it is weak, right? So now from this particular grading, we can select the slice we are interested in, and that is why it's called the slice selection gradient. So here is the slice where my left adrenal lies, right? Now, what I can do in this is, over this slice, I can change the frequency in the XY plane, okay? So everything becomes different, and this particular stalk will have the same frequency throughout. And now what I will do is, I will change the phase in this very respective same frequency column, and I will reach to the left adrenal. The same has been shown here, right? So just an example study. So this is the Z-axis, okay? If I have to take axial scans, I will apply the slice selection gradient in the Z-axis, like this, cut the body, we'll get this, right? Now what is the longitudinal axis of this image? Abdomen is longitudinally like this, right? So the frequency encoding will be done like this, phase encoding will be done in the Y plane. What about the head? For the brain, this becomes the long axis, so the frequency encoding is done in Y and phase encoding in the X, right? This is what a basic sequence will look like. So we will select the slice, we will do the phase encoding and then the frequency. Now just remember, I want you guys to remember this. There is a little delay in the phase encoding step and attainment of the echo. Just remember this for a later discussion. Now, all this data that we have collected, we have to store it somewhere, right? And that storage device is the K-space. Now, where do we store our data? We store in a rack of shelves. So just understand one chest of drawers. This is a very classical example. So example is that one chest of drawers having multiple drawers inside it, right? This is for one slice. Each of the drawers individually is the phase encoding, okay? And when we pull out that drawer and we keep the objects inside, that is the frequency encoding. So we should be clear about this. For example, okay, the same thing has been described here. So we will use this example in our analogy head, right? So we select a slice, then we select this very particular drawer through the phase encoding, open the drawer and put the data inside, that is the frequency encoding, basics. Now, in the center part of the drawer, we'll put the larger objects, and in the peripheral part, we'll keep the smaller objects. Why so? Because in the center, we get a higher signal, in the periphery, we get a good resolution, and when we superimpose, we get a good image. Clear about it? Okay. Now, there are two methods of filling the drawer. Either you fill the entire drawer once, move to the next set of drawers, and so on and so forth, or you select drawer number 1 of the first rack, fill it, select the drawer number 1 of the second rack, fill it, drawer number 1 of the third rack, fill it, and come back again. And this composes the TR of the 2D volumetric acquisition technique. The same thing depicted in the diagram. The third concept that we should know before going ahead is a scan time. Now, scan time depends upon TR, phase matrix, and NSA. What is TR? Obviously, the time to repetition from filling the first drawer and getting back to the same set of drawers is the TR. Phase matrix is the number of drawers. If the drawers are too many, you obviously will take more time. And what is NSA? Now, for us to understand, NSA is simply that the signal that we are getting contains more information. The number of signals don't change, they contain more information. For example here, if the socks are the objects we are keeping, simply increasing the NSA means that the socks have become larger, they contain more color, that's it, right? So basics. Okay, now let's come to artifacts. Now what happens in artifacts, simply artifact is something we don't expect to see, right? Something that is not a part of the normal tissue within the imaging matrix. There are two techniques to learn artifacts. One, there is a set of mnemonics and a chart, which is too long to understand. Second, if you're good at using Instagram, then there are many filters which correspond to the various artifacts we use. And also, if you have seen a lot of Shah Rukh Khan movies last year, the category is complete. So the first category is motion. If there's a lot of motion, as was in this dance, that's the first category. Second, when there was a problem in the system and the measurement. And third, there were external forces responsible. So these are the three categories of artifacts that we understand in MR, okay? Trying to make it simple for you people. Let's start with motion. We will not be covering the flow related because that's totally different set of things. So phase mismapping. So now we'll begin with the Instagram filters, okay? This is the guy in motion and the filter that we use is this, right? This is simply phase mismapping, what looks on an MR image like this. Now no one will get confused, hopefully. Why is it happening? It is happening because, so how do we define it? It is the replication of the moving anatomy along the phase encoding gradient. If the motion is periodic like that of the chest wall, it is called ghosting. If it is the eyes, it's called smearing, okay? The separation between these lines is given by the same formula, which was the formula for the scan time. So our basic purpose is we need to stretch out these lines away from the scan, okay? So how do we do this? Now, let's understand the cause. So here you see that we remember that this chest wall, the anatomy was at one position along the phase encoding gradient. When the TR came back to the first drawer, this chest wall had actually moved to another place, and that is why this artifact results. Also, now you recall that diagram where there was a delay between the phase encoding and the acquisition, right? Frequency was happening simultaneously, but the phase encoding was taking a little time, and that delay is another reason for this artifact to occur. So what are the remedies? A smart remedy would be to swap the phase and the frequency encoding. Like for in this example, we had to study the aorta, so we just simply swapped it out, right? Second would be putting a pre-saturation pulse. Like for a cervical spine imaging, we can put a pre-saturation pulse to negate deglutition, okay? Third is the respiratory compensation. Now, for any compensation techniques, there are two methods, trigger and gate. Trigger means that one event will trigger the sequence to start, and gate means that we are applying a gate, let the movement happen on its own, and a gate is applied where there is least motion. So these are the two things, and how do we do these two things? By three methods. Bellows. Bellows are these tubings which are applied across the chest wall. We get this respiratory movement, and towards the end of the expiration, when the movement is least, that is when we attain the sequences. Second, navigator pre-pulse, same technique, but now seeing it on the screen. And third is very important, respiratory ordered phase encoding or rope. Now here, the technique becomes independent of respiration. Let the respiration happen. When it is at its peak during inspiration, we will store the data in the outer side of the case space. And when it is shallow, we will take the data and place it in the center. So we'll get a good signal, a good resolution, and superimpose both the techniques. Three methods, right? Obviously, we have to answer these as well in the exams: voluntary breath hold, counseling the patient, sedations, etc. Or you can use faster sequences. So that completes the first motion. Second would be aliasing or the wraparound. Now let's example if a SRK was like this. If there was too big an anatomy to cover and there was a small FOV that you were using, so what happens is another histogram filter called hog. The right part of the image goes on the left and vice versa. This is simply called wrapping or aliasing. What is the logic behind it? The logic behind it is that if there is a big anatomy and the FOV is small, and this is the bore. So it is just not the FOV, but also the anatomy outside the FOV which will be experiencing the effect of the magnetic field. And therefore, this will happen both in the phase as well as the frequency encoding gradient. Now, what is the frequency wrap? Frequency wrap means, let's say, for example, I'll take an example for this. Receiver bandwidth of 64 kilohertz, which means 32, 0 plus 32, right? Something which we are interested in is this zone, but something located at 35 kilohertz, according to this formula, would be interpreted as minus 29. So this 35 plus will actually come at minus 29 position. This is called frequency wrap. What is phase wrap? Phase wrap simply here, you can see that this is the FOV, but the phase of this part and the phase of this part, they are same, right? And therefore, this part of the anatomy will get replicated here, and this part will get replicated here. This is called the phase wrap. So how do we avoid this? You simply enlarge the FOV or use phase oversampling. Now, if you see this diagram, the second one, in the phase oversampling, none of the phases are actually getting repeated. The number of draws will have increased, obviously, so you will have to increase the scan time, but this is one technique. Second would be apply pre-saturation pulses on the anatomy outside, or third, phase frequency swapping. Again, the same concept. Chemical shift. What is happening here? One part is bright lit up, the other is dark. Same thing when happens in the body, a complex name of chemical shift has been given. See here, this margin is dark, okay? And this part is as if a torch is being born from this side. Now, this happens along the frequency encoding gradient when there is a fat fluid interface. Let's take a second to understand this. See, fat is a large molecule. So the hydrogen nuclei in the center have got a large electron cloud, and the magnetic field we are trying to impose on this is guarded, okay? This is not the case with water. So water is precessing faster, fat is precessing slower, and at 1.5 Tesla, this difference is actually 220 Hertz. So now if we have a receiver, again another example, so if we have a receiver bandwidth of 16, which means minus 16, 0 plus 16, so 32,000 Hertz. And if we have a frequency matrix of 256, if we divide, each pixel will have 125 Hertz difference. And according to us, the difference of was 220 hertz, right? Fat was processing 220 hertz slower. So if you divide this by 125, 1.76. That means water and fat will go in different pixels. The signal will drop. Okay? So what technique can we use to avoid this? If you simply increase the receiver bandwidth, both the water and the fat will come in the same voxel. So here you see the same technique is used. Also using fat saturation techniques, imaging at a lower field strength and reducing FOV. These are the next methods. Out of phase signal cancellation, a classical India ink stain, right? This is the India ink picture, and that is what is called as out of phase signal cancellation. So a dark sketch pen is used to draw the entire anatomy, and this is how it happens. Now the difference is that this happens when the water and the fat come to lie together within the same voxel. Now understand, if water is processing faster, right, 220 hertz faster than fat, so there will be times when fat and water will be in phase, but there would be times when fat and water will be out of phase. Every 4.4 milliseconds at 1.5 Tesla, water and fat come in phase, whereas every time half of this at 2.2, 6.6, 11, they are out of phase. And that is what is called, the difference of this is called the out of phase signal cancellation. The remedies would be two. Either you just make a T correspond to 4.4 and you get the signals, or you use a spin echo sequence. What happens in a spin echo? The moment they try to get out of phase, they are slapped back by 180 degree, and again they'll be slapped back, and this dephasing actually doesn't occur at all. So Dixon was a smart guy who did a very basic maths. He said if in phase is water plus fat, out phase is water minus fat. So if you take the sum average of this, by basic mathematics we see we get a water only image. Similarly, by a difference average, we get a fat only image. And this is what it looks on Dixon imaging. All the four sequences, now we know why it happens. Magnetic susceptibility. So how magnetic you are, how strongly can you attract the magnetic field, that's the basics of magnetic susceptibility. So some tissues will magnetize more, okay, paramagnetic, some will repel diamagnetic. Again, when they will attract more magnetic field, they will process faster, and so on and so forth. And again, there will be dephasing at the interfaces, okay? So this is the concept that we use in GRE imaging for imaging of hemorrhage, hemosiderin deposition, quantifying liver and myocardial iron overload, etc. Now, what are the remedies for this? Obviously, remove all metals, use of the spin echo sequences, increase the receiver bandwidth as much as possible, decrease the T, because more the T, more the dephasing you are allowing, or use of parallel imaging sequences. Truncation of the Gibbs artifact. Simply truncate it. The word it tells you cut short. So if there is an interface of high and low signal, okay, there is undersampling of data, because the tissue is still producing a high signal, but you have stopped the sequence. And then you see a linear line, like for example, a syringe-like appearance inside the spinal cord. So wherever there's a high and a low interface junction, this is what you see. Remedies would be increase the phase encoding step. Avoid techniques that partially fill the K space, because the problem is already happening because we are just allowing partial filling, right? Or the use of filters, that's the third method. Cross excitation, what do we see here? One part is bright, the next sequence is dark, another bright, another dark. Cross excitation. The basic reason for this is that the RF pulse is not exactly square, okay? It's curved, like this. So when it is curved, let's say for these are the two hydrogen nuclei. If it is curved, the RF pulse here will be able to transmit some information here. Both will be flipped like this, okay? This will start recovering, but the RF pulse now will be applied here, and this hasn't recovered. So this will be dark, bright, dark, right? So this is the basic concept of cross excitation. Now, the remedy would be two. Either you increase the interslice gap, okay, make it 30% of the slice thickness, or the technique of concatenation or interleaving, where you excite slices 1357 and 2468, so on and so forth. More fringes. Now here, basically, when there's a field inhomogeneity or there's a fluctuant supply, you get these classical patterns of tweed clothes, corduroys, canvas, etc. Or if there's too big a patient, okay, if there's too big a patient and coronal imaging is being done, again the same phasing, dephasing will happen at the corners, aliasing will be superimposed and more fringes would result. So this is simply another aliasing artifact, okay? Getting with the last four of them. I'll try to be very quick. Shading. Now shading basically means that there is an uneven contrast. As you see, this part is appearing dark, this is light. Why is it happening? The most important reason is abnormal loading of the coil. So if you have for shoulder you have to screen and you keep something to screen the thighs, right? So there is a difference in the anatomical size in the coil that you are using. This is what will result. Or the magnetic field inhomogeneity, and also if the excitation pulses are not exactly at 90 and 180 degrees. So how do we correct it? Load the coil properly and do shimming effects, okay, to reduce the magnetic field inhomogeneities. Parallel imaging. Now, just for a moment, let's try to understand what parallel imaging is. If you go back to the example of drawers, we were pulling one drawer, keeping the object, moving to the next, and so forth. Now what we do is we appoint 3 children and ask them to open 3 drawers simultaneously. All 3 will be open, objects will be put, drawers will be closed, next 3 in line. Okay? So basically we have appointed 3 coils which will be performing 3 times the function within the same TR. Our process has become 3 times faster, and that is called acceleration factor. Okay? So filling multiple lines of K space per TR by assigning each line to an individual coil and coupling them together in an array. What happens is that here, this central granularity results. Okay, this is an artifact which happens, another minor form of aliasing you can call it, and the remedy for this would be to reduce the acceleration factor or to increase the FOV, basically the acceleration factor. The zipper artifact. Now here you see the dense broken line, right? This is the dense broken line across the image. This is because of the external magnetic field. You are asked this question in exams, which artifact would result out of the external magnetic field. So it is this one, okay? So if you are playing mobile or radio outside, the door is open, you have landed a flight inside the Bohr magnet or whatever. So either of the reasons can result in this, and this break of line will happen. So you have to close the room and locate any breaches in the other shielding. Last, magic angle, because most of us know 55 degrees, but why is it 55, that we need to know. So if I take a dipole moment, okay, basic dipole moment means north-south magnet. At the north and the south of it, there will be maximum positive polarity, as shown in this diagram, maximum positive polarity, okay? Just tangential to these points, there will be maximum negative polarity. So if we draw petals around this, we used to do it in class 10th, you see at this point, there is a single point here, somewhere here, that there is no magnetic field at all, right? This is given by this equation mathematically, but by the figure we can see this is somewhere at 55 degrees, okay? So now what happens in tendons, the collagen molecule is there. Collagen has a lot of hydrogen nuclei, water tightly bound to each other, okay? So na mera bhala ho na dusre ka is the policy these guys work upon. So what will happen is that they are so tightly bound, the dipole-dipole interaction is very strong. This dipole does not allow the other one to have a longer T2. All of them are dark. They have a very short T2 time. But when that particular tendon is projected at 55 degrees to the main field, this effect wanes off. The T2 time increases because the dipole-dipole interaction has weakened, and therefore you get these brighter signals, okay? So most commonly seen in the patellar tendon, the supraspinatus tendon, ACL, etc. So quickly spotters, just I want to see if I have been able to convey something to you guys. You people can just answer. Which artifact would this be? Yes, yes. Aliasing, correct. Next one. Some pattern appearing, some carpet-like pattern, herringbone. Okay, herringbone, corduroys, the patterns that we were studying, right? Next. Okay, so this is a lipoma basically. Okay, this is fat. So what do we see here? One line is dark and the other opposite side is bright. So this was the chemical shift artifact. Last, you see these lines, these are the artifacts we are talking about. So which artifact was the one occurring at the interface of bright and dark? Zero movie, Gibbs truncation artifact, right? So this one was, okay. So that completes pretty much it. So the image credit goes to these. The basic concept was from the Catherine's Westerbrook's book, MRI in Practice, and the other sources. And obviously we have to thank the guy for the images. Thank you, everyone.
Thank you, Gaurang. Such a nice. Thank you, Gaurang. This is very, very nice presentation. In fact, so much things I have learned at this stage from you.
Thank you so much.
Any question from audience?
Thank you, Gaurang. It's such a complex topic, such a wide topic, and when I was designing it, I was thinking about you. None other than you could have, completed this topic in short time. I have only one question. You haven't covered shimming. When you do the MRS, you need to have because magnetic field homogeneity is not across the bore is not the same. Right. So you have various other artifacts even in the images also. Yes. So could you comment on that also?
So basically the T2 star inhomogeneity is the result of this artifact that sir is telling, and we have to do shimming. And there are two methods, an active and a passive shimming. Active shimming is done by the magnets that are installed within the bore, and at the very start of it there will be isocentering. And the passive shimming is done by the external coils that we would be using. And these are the two methods. So a homogeneous field strength will be applied over and above which we will be applying the gradient coils.
Wonderful.
Yes,
So this is very important topic for residents, for technologists, everyone whosoever is watching these images, because you should know and how to correct it also. So you should know what kind of artifacts you are dealing, and also you should know. Thank you so much.
Thank you so much, sir.
Thank you, Gaurang. Thank you, Gaurang. You made such a complex topic so simple in a masterly manner. Once again, I will request all of you to give a huge round of applause. And one question, why you have chosen only Shah Rukh Khan in your images?
Sir, it was just his movies that were actually providing the right categories, the last 3 movies, that's why I had to choose them.
Thank you.
Thank you, sir. Thank you so much.
Thank you, speakers, for your insightful delve into these relevant topics. Now, I would like to request all the respected chairperson to come forward and felicitate our esteemed speakers. I invite Dr. Anjuman Jahaman to join us on dais. I also invite Dr. Gaurang Pandey sir to join us on the stage.
हेलो हाँ बोलो आओ आओ
Now, for the felicitation of our chairpersons, I would like to call upon Dr. Rohit Gurnani sir. To felicitate Professor Sandeep Tiwari sir. Dr. Amit Chaube to felicitate Dr. Priyanka Yadav ma'am. Dr. Siddharth Mishra sir to felicitate Dr. Ashish Gupta sir. So now it's the time for most awaited quiz session. I request all the team members to kindly be seated in front row as quiz is about to begin. Our quiz masters are Dr. Nitin Arun Dikshit sir and Dr. Pranjali Joshi ma'am. Our scorers are Dr. Siddharth Mishra sir, Dr. Arjuman ma'am, Dr. Gaurang Pandey sir, and third umpire are Professor Manoj Kumar sir and Mr. Uday Pratap sir.
I would request the teams to take the front row on the sofa. I'd request the dignitaries to kindly step back. शीट मंगाते ना अभी सौरभ एक फाइल दो B team, the command team, and the BHU team to take the front row. Team B is from BHU. Team B is reinforced by 2 residents from KGMC. I request the teams to leave a sofa vacant in the D का है? And team D is from RML Institute.
और दे दो और
I would request the teams to introduce themselves. Team A is from the command hospital.
Team A from Command Hospital.
Individually.
I'm Dr. Pratibha, Senior Resident.
I'm Dr. Pranjal.
I'm Dr. Srihari.
I'm Dr. Amandeep.
I'm Dr. Mathun from IMS BHU, second year junior resident.
I'm Dr. Vignesh from IMS BH.
Dr. Rishita from KGMU.
Dr. Ananya from KGMU.
Dr. Saroj from KGMU.
Dr. Shevya from KGMU.
Dr. Nitin from KGMU.
Dr. Shakib from KGMU.
Dr. Niket from RML IMS.
Dr. Shivam from RML IMS.
Dr. Komal from RML IMS.
Dr. Shubham from RML IMS.
The team which hits the buzzer first will get to answer. And there will be negative marking in the buzzer round. There will be 10 marks for each right question and there will be 5 negative marks for a wrong answer. Now, we start off with round 1 with team A. This is the question for team A. this is the clinical history and findings. These are the images. This is the first image. This is a NCCT image. This is the MRI image. And this is the NGO. Do you want to see the images again? This is the CT image, this is the MR image, diffusion, and this is the NGO. Now we move on to the questions to team A. What is TOF MRA?
Time of flight MRA. Angiography.
What exactly is TOF MRA? You are telling me the full form only.
Sir, that in TOF MRA without use of contrast, we are able to image the blood vessels, and we are based on we are saturating the moving RBCs in the neck region and then imaging the excited RBCs in the cerebral vessels.
Is it a gradient based sequence or a spin echo sequence?
Spin echo sequence.
It is a gradient based sequence, but we'll give the 10 marks to. What is the treatment? 5 marks should be allowed.
Mechanical thrombectomy of interventional radiology.
Mechanical thrombectomy, what is the time period like?
Within 6 hours, sir, for anterior circulation.
The guideline has been changed now within.
Till 12 hours, up to 12 hours.
Up to 12 hours.
Sir.
Okay. And what about IV thrombolysis?
Within first 4.5 hours, sir.
And for posterior circulation?
24 hours.
Good. We can give them 10 marks full. We move on to the second question. This is for team BHU. 5, 10. These are the MR images. What is the diagnosis? And what is the diagnosis? First question is to team BHU is, what is the diagnosis?
Intraparenchymal bleed on right thalamus.
Yeah? Intraparenchymal bleed, आगे? And?
Bilateral thalamic intraparenchymal bleed.
And? Is there something missing in the down, in the last image?
Look at the venogram again.
The question passes to team C.
Sir, there are bilateral thalamic hemorrhages as a result of venous occlusion. So it's a case of venous thrombosis leading to hemorrhagic infarcts.
Good. And the second question? These days there are multiple methods of doing MRV without contrast. You need to tell just 2 of them. And Dr. Durgesh is sitting just behind you.
Sir,
Kindly you can stand up and answer the...
Sir, TOF MR...
There is a videography going on.
Sir, TOF MRV and...
And?
ASL. Sir, we can also use phase contrast.
Good. So, प्रॉब्लम क्या है तो 5 नंबर दे दो भाई. Question for team KGMU. History. 35-year-old female having on and off tingling numbness in hands. Moving on to the MR images. Shall we move on to questions if you have seen the image? What is the diagnostic criteria for this condition? And the second question is, which is the lethal acute variant? And team D is eyeing for a pass question from KGMU. Team RML is eyeing for a pass question. They know the answer, I think. They are smiling also.
Sir, McDonald's criteria.
Good. And which one is the lethal acute variant? 5 marks for McDonald. Correct answer.
Sir, Marburg variant of MS.
Great. Great, Shakib. And now question for team RML. History. A very common occurrence these days, 42-year-old male with history of alcohol addiction. The patient presents to ER with altered consciousness, nystagmus, and these are the MRI images. There is a triad with this condition. Can you just, Aniket, can you just describe the findings?
Sir, there are flare hyperintensity noted in the periaqueductal grade.
Great.
And sir, these point to the diagnosis of Wernicke's encephalopathy.
Good. Great shot. And treatment of Wernicke's? The initial treatment required for Wernicke's encephalopathy? Great. And we again move on to second question of the first round to team command. This is the history. A 48-year-old female with tingling, pins and needle sensation and numbness felt in both hands and feet. Difficulty in walking also. Shall we move on to the image? The answering person can kindly stand up and tell the answer, please, so that we can record.
There is hyperintensity in the posterior, T2 hyperintensity in the posterior part of cord, with the history likely subacute combined.
I'll come to the questions. What is the diagnosis? Yeah. The clock is ticking.
Acute combined degeneration of cord,
What is the cause normally in Indian vegetarian population?
B12 deficiency,
Great.
methylcholine deficiency.
And the sign, the second part of the question, you get 5 for this.
Trident sign, sir.
No, Trident is a sign of osmotic demyelination seen in ponds normally.
We would like to pass it.
Team BHU, SACD sign.
Pass.
The question passes to team KGMU. And, yeah, great. And any other name? The other name is rabbit ear sign, in rabbit ear sign. We give 5 marks to command and 5 to KGMC. हाँ देना सही है नोटेड एक्सेल में है हाँ एक्सेल में ही पूछ रहे हैं. Next question for team BHU, amalgamated by KGMU. History: 33-year-old male presents with severe acid peptic disease and melena. To the ER. No history of alcohol intake. I have made your work easy. Can you describe the findings? Any one of you?
Like axial image showing there is a hematoma in duodenum. There is a bleed.
There are 2 images for you. I am an intervention radiologist, but I have not made the quiz. So you need not be biased that it might be an aneurysm or a hemorrhage only. I'll move on to the question to make things easier for you. Diagnosis, and there's a triad associated with this condition.
So, Boerhaave syndrome.
Boerhaave. Esophagus is not visualized in the provided images, I think.
Acute bleed from the posterior wall of due to gastroduodenal.
The question passes to, do you want more time to discuss? No. The question passes to team KGMU again.
Girls disease.
The question passes to team RML. They are eyeing for this bonus marks.
It is likely a gastrinoma associated with Zollinger-Ellison syndrome, and the triad includes hypergastrinoma. Apart from that, peptic ulcer disease with diarrhea and increased gastric acid secretion.
Great. We move on to, and this question is not from RML, so there is no bias from my side. Moving on to the question for team KGMU. 55-year-old female with positional headache. And we move on to a few MRI images. Can anybody describe it from team KGMU? It's a very easy and a common case which was not picked up in earlier times, but it is becoming a very common diagnosis. A hint from my side, my bias towards KGMU is obvious. But Shakib, can you stand and answer?
Sir, we are able to see crowding in posterior fossa with tonsillar herniation on the sagittal.
Yeah.
And
yeah, it's bulky. Something is bulky.
And the midbrain is noted.
And The first image and the second image. Is there anything striking in the second image? Too much of anything?
The subarachnoid spaces are proper.
Yeah. Subarachnoid or subdural or what? Great. These are, on the first images we can see the subdural hygromas. And we can give, we can't give anything to you on this. And
Questions?
this, the second image is?
Sir, that of encephalocele. No,
Hey,
just a second.
Just hold on.
Just a second. Sir,
which investigation is this?
We are seeing a CT cysternography.
Yeah.
And it is usually advised for to check for CSF rhinorrhea.
What is the symptomatology of this patient? What would have been the characteristic symptomatology? Yeah.
The patient usually presents with recurrent rhinorrhea and is unable to sniff it back.
Okay. We can give 5 marks to Shakib and team KGMU. Moving on to the next case. The next question is for team RML. A 45-year-old alcoholic admitted for altered mental status and gait disturbance. After uneventful and improving for 2 days, the patient of one case improved over 2 days of hospitalization. Then again the patient developed altered consciousness despite giving a thiamine, Aniket. And the patient presented with spastic quadriparesis and pseudobulbar palsy. Shall I move on to the image? It's a very full toss type of a question. And team A is eyeing at this. They are ready to answer.
We can see hyperintensity in the pons, and sir, given the history of spastic quadriparesis, sir, it's most likely osmotic demyelination.
And let me ask the questions first. What is the diagnosis? And what is the characteristic sign associated with? Great. This is the trident sign which team A was talking about slightly earlier. They have, you should give credit to team command for reminding you of trident sign. And at the end of our first round, I would ask our scorers to kindly.
So team D, Ramanor Loya Hospital is leading with 30 points, and team BHU is yet to open account with 0. So second and third are team KGMU and the team command.
They're sharing the same points, command and, no, command is second, KGMU is second. KGMU is, so leading is RML, then catching up behind is KGMU, and the third is command, and team BHU amalgamated by KGMU is yet to open its account. I'm sure they'll catch up in the next round. There are too many questions and there is negative marking coming up. And and you should fasten your seat belt. The next round is very exciting. And every team is provided with a buzzer. We are slightly primitive in this buzzer round. So you need to raise your hand also. आपको बैठा लें इधर हाँ, and Dr. Arjuman Jahan and Dr. Gaurang Pandey will spot who, one of the members will have to raise hand. You decide among yourself who will raise hand and who will press the buzzer. Hand raising only. So we are off the buzzers which we purchased with great difficulty. So hand raising is the norm of the day. both. Then we go with both. Buzzer, and you decide among one of the person should raise hand and the other should press the buzzer. So, Dr. Pranjali will start off with this round.
So this is a very interesting round. We've tried to make it as interesting as possible for you. So this round is based on images. So the first image that we're going to show you is of a celebrity. If you identify the celebrity, if you feel, you will be able to answer the question related to the celebrity. Only then press the buzzer or raise your hand.
And then if no one presses the buzzer, we'll move on to the second image. You can press the buzzer on the second or third image also if you feel like.
Yes, this round has negative marking as well, so be very careful.
Plus 10 and for every right answer and minus 5 for every wrong answer.
So we are starting with the first question. So this is the first celebrity.
Anyone, any takers?
I expect the girls to know this one.
Nick Jonas.
Let us ask the questions. Let us ask the questions. So the question is related to this person. Somewhat related. The clinical history is of a 20-year-old male in which there is a previous chest infection, and now the patient is presenting with abnormal movements of the left upper limb. This is the imaging of this patient.
This guy suffers with this condition. Nick Jonas.
So the celebrity suffers with this condition. So you need to correlate the image with the celebrity.
Everyone has seen the image. Can we move?
Can we move on to the questions? I hope you've understood the image.
Nick Jonas, the image. Shakib, can you describe the image for me?
Sir, in the CT non-contrast image, we are able to see hyperdensity involving the right caudate and putamen with corresponding T2 flare hyperintensities on the MRI.
Great. But no marks for this. We move on to the question. Name of father-in-law of this chap. And this question is dear to me. You can.
Sir, Mr. Chopra. Sir, Mr. Chopra.
Hey, Mr. Chopra, nahi chalega. This won't do, this won't do. This won't do. Full name, full name, full name. Full name. हाँ, डॉक्टर चोपड़ा भी नहीं चलेगा भाई. मुझे निक जोनस का नाम याद है ना उसके. He is Priyanka Chopra's father. Come on. He's Priyanka Chopra's father. Yeah. And no one will Google it, है ना? Teams especially. No, the questions are not passed in this round, so you can take it easy. And Shakib, there are two questions. If you don't know the first one, you can go for the second one. Otherwise, there is -5.
Sir, diagnosis, diabetic strypathy.
Diabetic strypathy, yeah, great. You get 0 for this now, because name of father-in-law is still missing.
5 marks, sir.
No, there is no negative for this. There is no negative for this. Then I am not deducting you 5 marks. I am a harsh quiz master, you see. He is an alumnus of my college, and he's retired as a lieutenant colonel. He's a surgeon by profession. He has done MBBS and MS from AFMC. He's an IE batcher, as we call it alphabetically. His name is Lieutenant Colonel Ashok Chopra. Sorry, there are no pass in this round. We move on to the second question. The second question is more interesting than the first. 0 marks for the... And RML is moving on like hot cake. Shall we move on to the second image? Or you want to tell something about this female? She is, yeah? Oh, great. Name of the character? Hey, let's move on to the question first. Presented with severe headache into 6 hours. Can you describe this image? This is a DSA image of our cath lab, not hers. Because she didn't give us permission to take her DSA image. There is something in this image which you should be able to pick up, since your cath lab is, your DSA is also almost as active as ours. Otherwise, other teams can pitch in if they want to, but after these guys say no to it. But there will be no marks for it. It's Is this something which should not be there?
So there is an outpouching from the tip of the basilar artery.
Where is the basilar artery? You're right. There's an outpouching, but not exactly from the basilar artery. But like a harsh quizmaster, I'll not deduct your marks for this, because Team KGMU will fire me if I give you marks on this, because you are right. There is an outpouching, which is not. This is I can give you a small hint. This is an anterior circulation run. This is not a posterior circulation run. That I had to give it to you. This is an anterior circulation run. So the artery you are seeing is not basilar.
So outpouching from origin of PCOM.
I'll give it to you, yeah. It is sort of a ICA bifurcation aneurysm sitting on the PCOM, yeah. Which was a fetal PCOM, by the way. And now the question, name of the show and the character, diagnosis and management. There's no marks for that diagnosis you make.
So show is Game of Thrones, and character is Daenerys Targaryen.
Great, Aniket. Diagnosis, you're right on diagnosis, aneurysm and management.
So endovascular coiling.
Yeah, and we did a stent-assisted coiling for this case. Okay. Now we move on to the next question. And team? Team A, team commanders, press the buzzer. Name of the actor?
Irfan Khan.
Again, it is not his CT, so no copyright infringement on me. And it's not our departmental CT also, so there is no bias in the quiz.
Sir, are you going to ask the question or should I?
Yeah. Last movie and diagnosis.
Last movie.
Diagnosis you must be knowing. Diagnosis is also in this image, if you can see this. Last movie of this great actor. One of the greatest actors I have seen in Bollywood.
Last movie.
Unlike Gaurang's favorite. So the clock is ticking.
So last movie is Hindi medium.
I'll give it to you. Yeah, not Hindi medium exactly.
Hindi.
But for the medium thing, I'll give it to you.
Angrezi medium.
रुक जाओ अभी नहीं. Diagnosis?
Neuroendocrine tumor with hepatic mets.
Yeah, we must give it to them. Whole 10 marks. नहीं skip नहीं करेंगे. चलने दो. नहीं, we can have a toss also if you want. But this image might give them -5 also. Just be cool on it. This might just be the condition in movie and condition in real life.
Sir, condition in movie, progeria, and condition in real life, myasthenia gravis.
Due to crunch of time, we are moving slightly faster because everyone wants to go to their home. It's a Sunday evening, and people have other plans after this conference. Durgesh sir is giving us a party after. And we move on to case 5, and team A has.
Yuvraj Singh.
Team A has taken the bait, I'll say, on this. And you can have a, this is also not Yuvraj CT. He suffered from hemoptysis, by the way. And he was showing to Baba Ramdev when he met a doctor. And the doctor advised him a CCT chest. And these are the images. Now we move on to the question. Name of the wife?
Hazel Keach.
Hazel Keach. Great. And other names of the wife? Are you aware? Lab tests and results for the radiological diagnosis. I suppose you know the, yeah. What are the lab tests we should do to corroborate the radiological diagnosis? I have shown you. Yeah. It's a tough one.
Sir, about the previous CT.
Yeah. What his condition only? He suffered from this condition.
Germ cell tumor.
Yeah, great.
CEA is a doubt.
What all lab tests we do, you are on a 0 now. You have negated your negative marks, that's it. What all lab tests we do for a GCT? Like, this is not a radiological question, but as radiologists, people sitting in this room are the cream of the doctors, and they should be able to guide the clinician or the referring guy as to what to do next. So this is the message of this question. I stress upon this time and again to my residents, and that is what I am stressing on in this quiz, that we are not just photographers or image viewers, we are the best. Anyone else? Any other team? Team KGMC, yeah.
Sir, beta HCG and alpha fetoprotein.
And?
Alpha fetoprotein.
Beta HCG, alpha protein, alpha fetoprotein, and one more?
AFP.
LDH. Great. We had a case, I think. Shaiva, you were the resident? Yeah. 0, yeah. There's some problem with the connection. RML, it goes. Nahi bhaiya, Gaurang is a Georgian, hardcore Georgian. He's a hardcore through and through Georgian. So the question goes to RML, and I am not seeing it. I am seeing the screen. And I have no soft corner for RML. Disclosures. Rohit is smiling on me. What does this image show? The great actor of our times.
Salman Khan and
And
Black
the
Bucks.
Black Buck, yeah. And now I have made the question easy for you. These are again the DSA question going to RML luckily after Emilia.
Yes, sir. This is a basilar tip aneurysm.
So Salman Khan has a basilar tip aneurysm. But, and this is a medical disclosure for which he can sue me. First movie and common symptomatology. And the question it will not pass, but yeah, you can show your general knowledge at the rate KGMU.
सर बीवी हो तो ऐसे रेखा के साथ हुआ था
Great. And this goes to her. What is your name, ma'am?
सर डॉक्टर कोमल
So co-curricular is also important in life. Common symptomatology?
Severe throbbing headache.
Severe throbbing headache, yeah. And sometimes you can have visual symptoms or TIAs, posterior circulation symptoms basically. 10 marks to... raise the hands please, only raise the hands, no buzzer. Next, yeah. Only hands, no buzzer. Kindly take off the buzzers from them. I'm sorry that we have squeezed the buzzer for buzzers. They're not working well in the real life. And team KGMU, who's this guy?
Sir, Mr. Stephen Hawking.
Great. But this is not the question. And I have made life easy for you. Can you describe the case? Yeah.
Yes, sir. So what we are seeing are T2 flare hyperintensities, which are in fact following along the bilateral corticospinal tracts.
Great. And the diagnosis?
Amyotrophic lateral sclerosis.
Great. Motor neuron disease, as we call it. These are few of images from the literature. Name of the person? Great. Diagnosis and sign, yeah. But you won't get it only on the diagnosis. You'll get to 0 only if you don't tell the sign. I can give you 2.5 marks for this. Because I can't be biased towards my own team. Sign is there in this image. That is why I had showed this. You can again have a look. It looks like something. And the clock is ticking. We are moving on to the last question now.
Owl eye signs.
Sorry?
Owl eye signs.
Sorry. Anyone else? Motor van? This is... I'll just show it for you. This is the hyperintensity involving there's arrow on this also. There's a hyperintensity involving the corticospinal tracts and the corpus callosum. This makes a garland. We call it a garland sign for this. I'm sorry if you have not read it, it is a rare sign for ALS. 2.5 marks for KGMU. They have answered 2.52. And now we move on to the last question. No, this won't do. You can also get a -5. The last question is the toughest of the quiz. So don't raise your hands without seeing the first picture. And RML has raised the hand. Name of this actor or child actor, if I'm not wrong?
Sir, character or the original name of the?
You can tell any of them.
Sir,
We'll move on to the question
Sir,
after this.
Dustin from Stranger Things.
Disease condition. Have a look at all the images. It is a very, very easy. It is a sitter basically. Great. So, 10 marks. 10. Anyone name of the character he plays? Name of the actor. Name of the actor. I just can't pronounce it clearly.
Gaten Matarazzo.
And we come to the end of the quiz with this. Art ho gaya na? Thanks to all of you for waiting for so long, and thanks for tolerating me as the quiz master. But the scorer sitting here is more harsh than me. I'll hand over the mic to Dr. Siddharth Mishra for the scores.
So the first runner-ups are Command Hospital. This is second runner-up. Second runner-up is Command Hospital. First runner-up is KGMU. And the winner is Team RML.
I don't want to take anything away from the winners, but it was more of their extracurricular performance which have fetched them the first place.
Which is actually more important than curricular.
All the teams have performed excellently. I'll like to thank you for this, and I would like to thank all of you for participation, especially Team BHU. They need to catch a train, and they are waiting for this. And now we'll move on to the quiz. The winners of all posters and quiz announcements. Prize distribution. I'll hand over the mic to Dr. Durgesh Dwivedi for that. Thanks to the scorers, my co-quiz master, and thanks to the organizer for giving us this wonderful opportunity to organize this quiz.
So we are gonna show you the results and all the winners' name, and the prize distribution will be done. इसके भी winners and after this then we'll go ahead with the hands-on session. लेकिन मुझे लगता है तुम आरएमएल ज्यादा गए हो इसलिए अनिस सर को बुला लो और पूछ लो सर से किस चीज को बोलना है।
Good evening, everyone. Thank you so much for this zeal and the participation throughout these events. So we had in total 3 quiz sessions, poster presentations, model making presentations, among others. So we are here with the results, which is been awaited since the start. The first quiz that we had was yesterday. So what we'll be doing is we'll be going on with the paramedical quiz, the paramedical competitions, prize distribution first, moving on with the residence one. So in order to felicitate the winners, I would like to call upon Professor Anit Parihar sir, Head of Department of Radiodiagnosis. Please give a huge round of applause. I would like to call upon Professor Manoj Kumar sir. Please give a huge round of applause. I would also like to call upon Dr. Durgesh Kumar Dwivedi sir on the stage. I would like to call upon Mr. Vivek, Mr. Sanjay and Mr. Vinu. So we have with us the results of the competition. Moving on with the poster presentation for the paramedical students. On the 3rd position we have Sana. On the 3rd position we have Sana Khan and Aarti from Kailash Institute and Monica from KGMU. So there's a tie. Sana Khan and Aarti from Kailash Institute and Monica from KGMU. Please come up on the stage. And please give a huge round of applause. So we do not have the participants from Kailash right now. This is Monica from KGMU. On the 2nd position we have Soumya and Akash from KGMU. Please come upon the stage quickly. And on the 1st position we have Divyansh and Ansh from KGMU and Archana from KGMU. Please give a huge round of applause. We have among us our chief guest, Dr. Shailesh Kumar Singh sir. Please give a huge round of applause. We request sir you to please join along with the
Next, we have the winners for the quiz competition. The first category was for CT scan students. That was yesterday, day 1. On the 3rd position is Divyansh Kumar from KGMU. 2nd position goes to Ansh Pratap Singh from KGMU. And the 1st position is Anu Verma from Saraswati Medical College.
Next, the quiz for CT scan students on day 2. The yes. Results for second day quiz for CT scan students. Third position goes to Saloni Tyagi from SGPGIMS. Second position goes to Sachin Sahu from KGMU. And on the first position is Rupa Bisht from Tirthankar Mahavir University. Next, we have the winners for the MRI Paramedical Students Quiz Competition on day 1. The third position goes to Gyan Chand from KGMU. On second position is Shraddha Singh from KGMU. And first position goes to Satyam Verma from UCMS.
Please give a huge round of applause.
He's my junior. So Satyam is actually not here. He's my junior from UCMS. So can I collect?
First position, Satyam Yadav, UCMS.
Next, the results for quiz competition of MRI students on day 2. Third position goes to Sanjana from KGMU. Second position again goes to Shraddha Singh from KGMU. And first position is Gyan Chand from KGMU. Now the winner of the model presentation in paramedical students is Shubham from KGMU. छोड़ दो
Poster presentation, PhD scholar, winner is Shweta Dubey. Please give a huge round of applause. So now we move on to the residents, and to felicitate the winners, I would like to call upon Major Dr. Nitin Dikshit sir, Dr. Siddharth Mishra sir, all the quiz masters for the resident quiz, Mr. Gaurang Pandey sir, and Arjuman Nam.
तुम अनाउंस कर लो क्योंकि ये मेरे ख्याल से फर्स्ट है.
Pranjali ma'am, please join us on the stage.
So the winners for the poster presentation are, third position goes to Dr. Shakib Zaidi from KGMU. Second prize goes to Dr. Vignesh from BHU. Please give a huge round of applause, everyone.
भैया हेलो
And the first position goes to Dr. Pranjali Joshi from RML IMS. And now I would request the winners of the winner team of the quiz competition to please come on stage. The RML team. Okay, the first runner-ups are the team KGMU. Please come on stage. And now the winner team, Team RML, please come on stage.
So now we would like to call upon the team of Philips Healthcare to please come up on the stage, and we would like to thank you with a token of appreciation for the hands-on sessions and the overall organization of this. Please give a huge round of applause.
Now let's take a moment to appreciate the hard work of our organizers who made this wonderful event possible. I would request Dr. Shailesh Singh sir to please felicitate our organizing team. First,
I would like to invite our organizing chairpersons, Professor Anit Parihar sir and Professor Manoj Kumar sir. Professor Anit Parihar sir and Professor Manoj Kumar sir, it is under their guidance and supervision that this event became a reality. Please give a huge round of applause.
Now I would like to invite our organizing secretary and program chair, Dr. Durgesh Kumar Dwivedi sir, who has been instrumental for planning and execution of this workshop and symposium.
I would now like to call upon our joint organizing secretaries on the stage, beginning with Dr. Siddharth Mishra sir. Please give a huge round of applause. Major Dr. Nitin Arun Dikshit sir. It is as a result of their endless efforts that has made this workshop and symposium a great success. Please give a huge round of applause. Dr. Sukriti Kumar ma'am, Dr. Anil Rawat sir and Dr. Priyanka Yadav ma'am are now not with us here in this auditorium. However, we would like to thank them for their endless efforts. I would also like to call upon ISRT office bearer, Mr. Mohanlal Bhagwat. ISRT office bearer, Mr. Mohanlal Bhagwat. for his contribution to the successful conduction of this event. Please give a huge round of applause.
We would like to felicitate our Joint Organizing Secretary and Treasurer, Mr. Binod Singh and Mr. Vivek Kumar Rai, and Mr. Manoj Srivastav.
बस हो गया तुम्हारा कुछ बचा नहीं है ना शैलेश से कॉल दिलवा दो हाँ दिलाओ
And finally, I would request Professor Anit Parihar sir to please present a memento to Dr. Shailesh Singh sir as a token of gratitude. Please give a huge round of applause. Professor Anit Parihar sir, Professor Manoj Kumar sir, and Dr. Durgesh Dwivedi sir presenting a memento. Please give a huge round of applause. Thank you so much for your efforts.
There is a small announcement to make. There is a cash prize also for quiz. For resident quiz, there is 1100 rupees. All for the paramedical quiz, there is 1100 per head prize. For the first winners. Model and poster only. Model and poster only. All paramedicals, model and poster. First winner. 1100. अच्छा तो 1000 पर हेड ही तो आया और उसका स्कॉलर का भी होगा ना फर्स्ट टीम हाँ पोस्टर फर्स्ट प्राइज पैरामेडिकल पोस्टर रेजिडेंट का दे दो कितना इसमें Any resident from RML? I would request Dr. Bhanupriya to kindly the first prize for poster. Dr. Pranjali from RML. And the winner team quiz prize also goes to RML. Dr. Bhanupriya to collect the same for the participants. Thank you all for, and now I hand over the mic to Dr. Durgesh Dwivedi.
For what? Closing?
Closing.
I forgot my laptop. Laptop चाहिए क्या? Hands on के बाद कर दें क्या? Hands on कर 2 मिनट दो मुझे लैपटॉप लेते हैं ना मेरा बैग लेते हैं ना वहाँ से एक मेरा बैग और किनारे में दे देना यही था क्या लेते हो लैपटॉप वहीं से खत्म कर देना. नहीं बैग लेते आओ. HDMI किधर है शाकिब? HDMI किधर है? हाँ बस इसको हटा लो. अच्छा छोड़ो छोड़ो छोड़ो. कैसा खोल दिया तुम. So, thank you so much, ladies and gentlemen, esteemed colleagues, honored guests, and fantastic delegates. I am really thankful to everyone, each and everyone who has spent their time with us. All the delegates, all the speakers, all the moderators. Actually, it took a lot of time for us, to formulate this, and it took a lot of energy also. And so I'm highly thankful to, first of all, our head of department, Professor Anit Parihar sir. So give a big round of applause for him. So because he told me to initiate, and then I took it as a challenge, and then we did it. So give a huge round of applause for our team also. And the team consists everyone, because last moment I added all the residents. So please, give them a big applause, for their hard work. I could not sleep, they could not sleep because of me. So thanks everyone, So this is the time to thank everyone. And so basically, I want to, at this time, I want to thank, first of all, our ISRT President Mohanlal ji, and for their time, for his time. And then Vinod Singh and Vivek also, they did a lot of, arrangement. Then if I would start, of course, this is the time to thank our chief guest yesterday, Professor Akhilesh Gupta ji, Honorable VC Madam, administration, entire administration team, they helped us a lot. Then, of course, all the speakers from here, from abroad, you could see all the speakers were there, it was midnight there, So they all, otherwise they could have sent us a recorded lecture. It's very easy nowadays. They send a recorded lecture, you just play it up. But people were there just because of their commitment, because of their passion, and because of their collaboration also. So I'm highly thankful to Professor Yogesh Rathi, Professor Mahesh, Professor Durga, Professor Senthil sir, all those online speakers. And then on-site speakers also, Dr. Gaurang is here with us. Thank you so much. Give him a big round of applause. Dr. Bhanu Priya and Dr. Arjuman Jahan, please, keep clapping because these were the, source behind us. And then, of course, Dr. Nitin Dikshit. He did a wonderful quiz, he is a master of quiz. And so I'm highly thankful to you. Dr. Siddharth Mishra wonderfully explained all the cardiac MRI principle. So please, and of course, Professor Manoj sir. So he is always, our source behind us, and he is always instrumental. And he's also like earlier he was in charge of so many paramedical courses. So thank you, sir. Thank you for your time, and thank you for chairing so many sessions. So again, this is the time to thank all the faculties involved. Some are here, some are not here, some of them, and the delegates from coming all around the India. So please, just clap for yourself also. I know it was not easy for you. Of course, the organizers, so all the team behind this workshop. I want to thank, and I want to take a couple of names like Dr. Nitin. Please, Dr. Nitin Bharti, he did a wonderful job. Dr. Shakib, Ananya, and then Ishita, that girl Ratnashil, Shakib, so all kind of, the source behind us. And then Saurabh, Vikas, Prabhav, Shavya. So they all did wonderful job. Thank you so much. The sponsor, lastly, I would like to thank also like the sponsor, our Philips team. Without your support, so please, thank you so much for your support. Without your support, it was not be possible. And of course, the media persons. So with that, I also like to thank our yesterday popular lecture by Professor Akhilesh Gupta. He explained everything in a very lucid manner, the role of research in India and how the NRF is going to transform the research in India. All the speakers, some of them are here, some of them have already left the place. And I just wanted to play a small clip by Professor Vikas Kulani. So actually I was also invited the Accessible MRI workshop, they are in Delhi. He is the chair of radiology in Michigan. So I just want to play his recording. Let me see if...
Second Eye Center workshop on accessible MRI. I want to wish everyone over there
it's not working.
The best in the
all right, I'll play at the end then. I have something, and I hope you all have enjoyed this. This was designed by Shakib, so please, thank you so much. I hope you enjoyed our selfie point. We hope you enjoy our time together. And this was the entire team effort. It was not done by one alone person. It's always a team effort. So thank you all the team also. And with that, I would like to thank you everyone. I just play the message by him, and then I'll just close this word of thanks session.
This is Vikas Kulani from the University of Michigan.
Why there is no sound in it?
For the Second Eye Center workshop on accessible MRI. I want to wish everyone over there all the best in Hi, this is Vikas Kulani from the University of Michigan. I'm visiting New Delhi for the Second Eye Center workshop on accessible MRI. I want to wish everyone over there all the best in the workshop exploring new frontiers in MRI and CT. Dr.
I'm
Dwivedi,
sorry,
I wish you
there
all
is
the
some
best
issue with
and
the
all
video.
the delegates. I hope you learn from each other and have a great time. Take care.
Just I'm playing with this one.
University of Michigan. I'm visiting New Delhi for the Second Eye Center workshop on accessible MRI. I want to wish everyone over there all the best in the workshop exploring new frontiers in MRI and CT. Dr. Dwivedi, I wish you all the best, and all the delegates. I hope you learn from each other and have a great time. Take care.
Thank you so much. Thank you. Thank you. So with that, we end the session. We'll begin with the hands-on session, and then we'll close this with a high tea. Thank you.
Thank you so much, sir. We'll be proceeding with the hands-on, and like yesterday, it will be conducted in front of you on these systems, and we'll be handing over the mic to the Philips healthcare team for the conduction of this workshop.
Based on their interest, will start. Only detail required.
Good evening, everyone. So today we'll be looking at our new AI-enabled workstation on MR. So we request you can occupy the workstation so that we can do a hands-on session. Yeah, you can come forward, yeah. Yeah, we could request the residents, the students, they can come and join so we can have a hands-on session on cardiac post-processing with AI-enabled tool. Please come forward.
A kind request to the technologist and the residents, please come forward. At least 8 people can sit now. Please have a seat. This one, no? Madam, please have a seat. कोई ना सिर्फ ये वॉलपेपर
The password you can add in, everyone. Philips PCAPS @123. Philips PCAPS, Philips @123.
If it doesn't work, ask them to call us. Yesterday one person logged out the account. Again we have to create the account.
If you are having some difficulty in logging in, please let us know. We'll help you. We'll reach you out. Philips PCAPS @123.
Once you have entered the password, just click on the ISP application If you have entered the username and password, click on the Philips ISP application. Okay, launching, fine. So once you have opened the application, click on the local folder and click on the ISRT 24. So once the application,
No, don't load it in CT, just a minute. Click on the patient directory. Patient directory.
if you have opened the application, click on the ISRT,
Click on the local.
ISRT folder.
Local, yeah. You will have ISRT 24. So I think everyone entered the folder ISRT. So we'll start with first with the neuroperfusion. So you can choose the second case.
Open with multimodality.
Yeah, everyone can open with multimodal. You can follow the monitor.
Please follow the monitor. Should click on the multimodality viewer. Right? Correct, huh? Multimodality.
Review application. Next. Yeah, the arrow.
You have to click on the multimodality viewer. Okay, multimodality viewer. Okay.
Hanging protocol not required, no? We just go with the processing.
So once we have opened the patient, we have to click on the display protocol manager. You have to click here on this button. In this you can get the option called display protocol manager. Madan, if you click on this display protocol manager, this is generally a hanging protocol. So a lot of time it happens here, like we are wasting our time to search for the T2, T1 flare sequences because patient may have been moved during the scan. So what we can do is, based on our case studies or kind of review pattern, we can create our own display protocol. So once you click there, you can see there two display protocol. One is MRI breast, one is MRI brain C. So you select on the MRI brain C, and below that one check mark button is there. Just below that, below. Click there. Now what happens is, this system has been learned that okay, we have to use 2x3 protocol and load my T2 axial on the first window, then the T1, flare, diffusion, ADC and the SWI. So basically it will automatically searching all the sequences for you and aligning based on your review pattern. So every doctors or the resident can create their own hanging protocol, what kind of reading they are looking for. This you can also utilize, let's say you're reviewing case of MRI spine. So MRI spine, we know the major sequence is T2 SAG, then T2 axial and T1 SAG. So those all sequences you can create this kind of layout and save for your review protocol. Now what we are going to do is, in this case, we are processing the neuroperfusion datasets. So let me scroll these images. You can see some lesion on the left side, correct? We have done the perfusion study for this patient. So what you can do is scroll the series down, search for the sequence name FEEPI.
EPI. You can find the sequence at the bottom. Yeah. Hold.
Once you click that sequence, automatically the empty window will get filled with the particular sequence, and you need to do a right click.
Right click on the sequence, right click on the image.
Right click on the sequence and click on launch application. So now in application window you will get lot of application there. So since it is a IntelliSpace portal demo version, so all the application which is available in this module is you can see it in the categories. Now you
So
want
you
to
can-
do neuroperfusion means it will come that MRI window. Here you can see MRI, yeah, MR windows there. There's a one, first is recently used, second is CT, third is MR. Okay, in this now you click on MR neuroperfusion, which is also written as T2 star perfusion.
So here neuroperfusion will give you a quick workflow. So you can just finish the processing in like 2 minutes, like only few clicks. So we have made it more easier and removed more of complication and confusion during the processing. So here automatically you can see there is already maps generated for CBV, CBF. So once you process and give the accurate values or the ROIs, you will get even the accurate result.
So once you get into that window, you can able to see rest of your sequences. So there is a two step. One is MR neuroperfusion, second is MR diffusion perfusion mismatch. So these two windows can be utilized further for your processing. So you need to select the correct sequence. Sequence name is FEEPI. Do a right click on FEEPI sequence. Click on launch application. Now this window opens.
Yeah, who all has
These
already
are the
opened.
MR applications.
So
Click
now
on
you can
neuroperfusion.
see on your left hand side, you can see the image where you have the finding as well as the normal plane. So the green line indicates for measuring the midline shift, and you have the selected maps on your left hand side. You can see you have selected CBF, CBV, and time to peak. All the maps has been automatically selected. You can even remove the particular map, or you can even add the maps. So in case if you want to add only CBV maps to be generated, you can do that also. And you have another option called contralateral ROI also, so we'll go with that. Before that, we have to measure the arterial input function peaks. So
we'll go with the process wise. So let's say this application control is showing you, first is analysis, second is verify and adjust data quality, third is define mask, and fourth is select maps, fifth is ROI. So basically, let's say as an application you have given a training for neuroperfusion, and after a week or maybe a month you got a neuroperfusion case in your center. So even if you forgot how to process the data sets, all our application will come with the guided workflow. This is kind of, these are the steps you have to do it to conclude for the neuroperfusion. So first let me go for the analysis. Here I have all the options available. Previously we have gamma variant available before the model free and the manual arterial input function correction. So all these algorithm are there. Nowadays standard for the neuroperfusion arterial input function is well established technique and the algorithm. So you click on the manual AIF option. The moment you click, one window will open. In this window you can see your neuroperfusion data set, and there is 7 by 7 kind of voxels are there. What this voxel is representing is, you can see the small box here in the red color. You need to scroll on your slice where you can see the MCA, right or MCA or left MCA. There's nothing defined you have to put or right or left. So you just have to go on the slice where you can see middle cerebral artery. Yeah, you can see, refer on the screen also. This particular slice you have to come. Yeah. Now you put on the right hand side of the MCA territory. Moment you put it, you can able to see a 7 by 7 voxel data sets where it is showing how and what kind of contrast kinetic you use during the study. Now I can able to see a good V-shaped structures, and this we require minimum 3 to 5 for the processing. So what you can do is, out of this all voxels, small pixels actually, you can select each 3 to 5 good V-shaped kind of maps here. Okay, so it is not like you have to click on anywhere. You see the proper V-shaped kind of map there, which is creating a proper sharp V kind of structure. Once you click, you have selected 3 to 5. You now click on the apply button. So the moment you click on apply, your main data set will come out here. Okay, like in this case, again I can say the injection was not given by the hand injection. How I can say this? Because when you do a T2 star perfusion, this particular graph, which will showing in the blue color, there's a dip right? This dip should not come out again. This dip should be straight. If contrast given with the injector or the correctly hand also if wanted to be given, but in hand also there should be consistent flow of the injection. What happened here is technician given the contrast and after some time it paused and then again he given the saline push during the study. That's why you can see the doublet kind of peak in the inversion peak is there, right? This is not the correct one. So if your study is correct, you can see the correct V-shape kind of data here. Now here you can see again this data set is some kind of dip is there. This we call as the second bolus pass, which will happen if there is a blood-brain barrier is there during the tumor interaction. So this is also noticeable effect. What you can do is to measure your perfusion maps. Now select, you can verify and adjust the data. Here let's say this IntelliSpace portal or AVW supports your multi-vendor data sets. So you have, let's say you have data set from Siemens vendor or the GE vendor. So what they used to done is they will generate the raw data format. Raw data means your main dynamic, let's say you've selected 80 dynamics, but before that whatever the raw series was there, 2, 3, even that images also you will get your system. So you can avoid that data and you can correct this temporal smoothing during the correction. The moment you do temporal smoothing, you can see the correction in the map. Okay, this correction is map, it is actually averaging out your temporal time points. Then second option is spatial smoothing. Again, if I make it weak, medium or large, my number of pixels will get average out. So let's say if I selected weak means 2 pixels will get average out. If I selected medium means it will average 4 pixels on the images. What you can select is you can use it none or the weak or medium based on the data set you have. Now select the mask. In the mask you can able to see the skull in the brain, right? You can remove the skull, so your result will be more precise. See how I corrected, you can look at the screen. Okay, only my skull area, complete skull area I removed it with the mask functionality. Now I can go and select my maps, what kind of maps I want, like relative CBF, CBV, mean transit time, and what are the maps I wanted. So this is the case of most probably the tumor case. So we are not going for the delay map or the perfusion diffusion mismatch. Generally we acquire perfusion diffusion mismatch in case of stroke cases. Coming to the bottom line, there is a measure ROI. So measure ROI will offer you two functions. One is the showing to mirror line. So let's say your patient is not lying down straight, his head is moved. So you can able to correct your middle line with this method. Okay, how this is help is, the moment you draw ROI on one side of the disease area, you can able to see the counter lateral light on the next to the brain, like you are drawing on the left, right side automatically the ROI will come. So you have to click on the ROI option. Now you can even draw on your map. So there is no limitation. You can draw any side of your map and you can get the ROI values done actually there.
You can choose any area where you wanted to. You can choose either on the normal tissue or on the abnormal tissue. You can draw an ROI.
If you click on the drop down, you have option called freehand counter. You can use even that freehand option as well. You see, the moment I drawn on the left side, my ROI 2 is drawn automatically on my right side. Why it is offering? Because a lot of time the subjectively if person drawing the ROI, second time may not be going to be draw the same ROI. So the ROI region will be differ. Your value again will come differing and it will create confusion during the quantification. So just to remove that confusion, we are drawing the ROI and second ROI will get automatically created on the contralateral side. Now below you can see your relative CBF, your relative CBV, then your mean transit time, and you can see your graph also. The best thing in this, you can also able to correlate your previous data series. So let's say in this you cannot able to differentiate where is my tumor. But if tumor is there, where it will be seen most or more clearly is one is FLAIR, T2 or the diffusion series. So just do a right click on the anatomical viewer, select series. Now here you can just align any of your series. Let's say I want to see the diffusion of this patient. Click OK. See. Now the real time I can able to view where is the lesion in diffusion, how it is looks like in diffusion. I can correct my ROI and I can see the same time I can see my other images on the parametric map as well. So that's a functionality it will offer you because it will register your series into your pre-contrast method and then automatically the flexibility it will offer you to compare the result with your previous series. You can use another anatomical viewer also. Click there, do a right click, select series, and now let's say you want to see post contrast T1, that is 13 number series. Near the graph anatomical viewer. Now on the in the inside you click on the right, inside you do the right click. Here, 1 minute. Right click here, select series. Now you want to compare with the post contrast. This is there, right? 13.1. So again it will come. Now you can see the real time registration of the data. If you move this, your map also will move. So the correlation will be much better in the reviewing format.
If you're not able to take it, you can drag and drop. You can go to the 3 dots like over here below the series. Click.
So it makes your workflow that much easier that even technologies can process and generate
So
your maps easily by comparing the results.
Drag and drop. You'll get, okay. So if it is not working with add the series, you can drag and drop whichever series you want.
Once this thing is done, you can able to generate the series with the map. So whatever the maps you have selected in this, all the maps will get generated in the color map. And then you can save like a screenshot here and make it for printing. Let's say now for this patient, I will take an entire screenshot directly to film. So just send screen to film, and here in the printing environment, you can able to see that data. So here again in the printer tools, I will simply go for landscape mode, 8:5 and with layout of 1:1. So this kind of nice images you can give in printing, and the data for the reporting part also. So follow-up study also you can compare it easily with this kind of formats. Done. ये आपका परफ्यूजन का पॉइंट पूरा हो गया है, इसमें आपको सारे डाटा मिल गए. तो आप इसको आइदर सेव कर लो और पैक्स पे भेज दो, या आप इसको प्रिंटिंग में डाल दो. लाइक जैसे हाँ, कैंसिल करो इसको, सेव पे वापस क्लिक करो एक बार. नहीं डायरेक्ट उस पर नहीं, उसके एरो वाले बटन पे क्लिक करो. हाँ, सेव डिस्प्ले करो. इस केस में सेव डिस्प्ले ज़्यादा मतलब सेंस बना रहा है बिकॉज आपको मैप भी दिख रहा है, ग्राफ भी दिख रहा है और आपकी वैल्यूज़ भी दिख रही है रियल टाइम में. अगर आप सेव रिजल्ट करोगे तो खाली एक पर्टिकुलर विंडो और सीरीज सेव होगी वहाँ पे. हाँ, सेव कर सकते हैं. अभी आप ऐसे जब से सेव करोगे, हाँ कर लीजिए, देन आप वापस अपने पेशेंट डायरेक्टरी में जाके तो रिजल्ट्स आपके सेव हो चुके हैं. सो लाइक दिस काइंड ऑफ रिजल्ट यू कैन एबल टू प्रिंट फ्रॉम योर सिस्टम. We'll shift to next application.
So again you can click on the patient directory.
Click on patient directory now.
Yeah, top corner.
Top left.
Left side you will have patient directory.
The patient name is Star Anu Dhingia.
So this case will be a simple perfusion for breast. So this will be based on a T1 processing method. You can click on the case or double click or choose the case and click on multimodality viewer. It will load on the
Again, your multimodality is by default is showing on your left upper side because you have used it recently. So again, no need to go and select it. First time when you click, it will ask you like you already opened previous study. Do you want to save the data or not? Just click OK and proceed for the next viewing. हाथ पे. Okay. Again, here also similar kind of things will come. It's like breast reading, right? We know in the breast MRI, we are doing multi-parametric kind of study. You are doing T1, T2, FATSAT, then diffusion, ADC. To search all these sequences is better to be prepared by the system itself. So that is what again we have done. Again, what I have done is display protocol is already aligned. Okay. Now you can see on the viewer on the screen. I have just removed the toolbox there because I know my all series are available here, and this is aligned in a way like if I do a zoom pan, everything will be synced across the series. I can able to scroll T2, my FATSAT T1, slice by slice it is scrolling well, so you don't have to do it manually. Here you can see your B0. Even if you want a higher B value, just click here with the left arrow key on the keyboard. So left arrow key, once you click on the keyboard, you can able to see your diffusion, ADC, and the post contrast SAS sequences, bilateral SAS sequences at one go. Hope everyone is able to see these kind of layout. If not, again you can go your toolbox, you can click on series, click on display protocol manager. Now click on MR breast and just select it, make a checkout there in the below. So automatically your series will get loaded in the same format how I am showing you there. MR breast once. Now click below. Come down. ये दिखाइए, ये आपका जो सिस्टम का जो विंडो है ना, ये रहा बटन, वो देखो, ठीक है. So these hanging protocol always helps you to fast your reading part, like how you are loading the data, how it is visualizing, and again you can do all the post processing also from this same window. Again, I'll go back to my series option, and now I have seen for this patient I have seen my T2, T1, FATSAT, and diffusion, ADC and all. But I want to check my T1 perfusion and the curves how it is coming. So I'll go to my perfusion section, which is dynamic E-thrive, series number 8,1. Series number 8,1 is showing 1020 images. Do a right click over there, select launch application from the downside. Again you will get plenty of application for MR. In MR you go and search for T1 MR T1 perfusion. MR T1 perfusion. So we have already got a session today morning like about the DCE MR imaging, dynamic contrast enhance. So this T1 MR perfusion is nothing but your simple perfusion method, simple wash in, wash out, those kind of map it will generate on the system. The moment you load the data sets, system will load all the dynamic series, and then it will create a automatic subsection in the below window. So here what you are seeing is it's your base dynamic series. These are your maps which we required, like your relative enhancement, maximum enhancement, and time to zero, time to peak, wash in, wash out, all these things will come here. So let me align time to peak, wash in rate, and wash out rate. So like this you can click on these buttons and change your maps. If I zoom it, so I can clearly see my current real time maps on the images, then my subtracted maps, Now again, here also we have given you the option called anatomical viewer, because again we understand lot of time it doesn't make sense to view your dynamic sequences for the review part. So you always wanted to compare your diffusion. So you select your anatomical viewer, right click on the on this window, you will get option called select series. You will again get this kind of whatever the sequence you have performed, you can able to visualize it. Let's say for this example I am selecting option called T2 FATSAT. Just click on OK. See, so nice FATSAT images, T2 FATSAT, then your dynamic sequences, and this table viewer is there because generally I have not drawn the ROA till now, so otherwise it will come here. So those also will come.
What happening is आपका विंडो ना स्क्रीन के साइज के हिसाब से छोटा हो गया है, तो यहाँ पे देखो एरो दिखने लग गया है, ये रहा एनाटॉमिकल व्यूअर। आप बस राइट क्लिक करो, सिलेक्ट, तो कुछ ऑप्शंस आप पे थोड़ा इधर उधर आ रहे हैं जो आपको सिलेक्ट करने पड़ेंगे, ठीक है, उस स्क्रीन साइज के हिसाब से चेंज हो जाता है। Now to draw the ROI, I generally refer to go for my subsected series. So in this case, I can see some enhancement in my subsected data here. I can scroll with my keyboard or the mouse. And then again, it's easy because you have all the option, verify and adjust data quality. Masking is already good in this case. Select maps, and then maps already we have selected, and this region of interest we can draw it here. If you click on this down arrow button, you can able to select smoothen counter, ellipse, freehand. So for this case again I will go for smoothen counter. How this ROI works is, let me see this particular lesion. I will do a multiple click, and moment my ROI is drawn, I will do double click to end it up. So moment to draw the ROI, this is right showing here, ROI 1. This is a particular enhancement part where I have drawn the ROI. Just see particularly ring enhancement is there. So I can see the correlated graph, and now in the table viewer I can also see my time to peak, wash in rate, washout rate, and all the functionality. That's how easy it is. Again, it supports all the multi-vendor data sets. So let's say in your hospital you have GE or Siemens or the other vendor machine, you can load those data set into this application and you can process it up. It's pretty easy application. If any questions, just let us know. We'll go for the next application, madam. Which one?
Shift, this system is getting hanged.
It depends, like we are all using so.
No, we'll go with the next application. This will not get hanged. We'll exit this. Exit. We'll go with the cardiac.
Yeah. Last actually, and it's basically our most selling application. There's one of the reason is like, if you see the cardiac imaging from the last 2 years, it's got a lot of appreciation in the market in terms of doing cardiac MRI in multiple sites. Previously, only selected site only we were doing the cardiac MRI, but with this new version, cardiac MRI got updates, like we have the selected vendors in India which will give this kind of application feasibility, like you can do all your multi-parametric kind of post-processing on cardiac. So first, let me load the case study for you. You select the patient name Anil Kumar and click on the review. Under the review section, we have a dedicated cardiac MR viewer. Why the dedicated separate cardiac MR viewer? That's a question. Like it's create a lot of confusion, right? We have CT viewer, multimodality viewer, then why separate cardiac MR viewer? Now the reason behind, you have seen in the session in the morning that lot of sequences we are performing in cardiac MRI. So there's a, if you compare with the normal MRI study, cardiac MRI usually will do triple time of sequences compared to the normal one. Although type of sequences are different because there we are only focusing about the bright blood, black blood, or the post-contrast, post-viability images or the perfusion images. So let me load the data set in cardiac MR viewer. First time when we launch the data, again, it has a defined hanging protocol or layouts. And it will load all your sequences in this particular hanging protocol. How this will help to you? These hanging protocol, actually we have sit with the Indian market. We have taken a feedback from lot of radiologists who are doing a good cardiac work. So they asked like we want to spend less time on the post processing and reading on MRI. So that's how these all layouts and the feedback we got designed, and we have created those protocol here. So once your application got load, all will come on this window, then we'll start it. Hope everyone will get it. Or otherwise, if anyone's system is not loading, you can able to see it directly on there. Okay, I'm explaining one by one step on the screen. So if you focus there also, it will like work for you. It's pretty easy application, so you don't have to invest much time actually.
So here you click on the cardiac analyzer on the MR viewer. Sir?
I need to check.
We need to KGMU T3 Tesla, which version there is?
We'll proceed then.
Cardiac MR viewer. Click on that. It will come.
Start?
Yeah, we'll start.
So you have two sections here. You can see currently you are having a viewing section or the labeling section. What happens is when you start doing the cardiac MRI in your institute first time, all the sequence will have a different naming nomenclature. So some will use it as a bright blood, some use as a black blood, some use the sequence like 2 chamber, 3 chamber, 4 chamber, short axis, like that of different naming conventions are there. So based on your institute, this system has to teach 3 to 5 studies what kind of sequence we are doing in what kind of cases or what kind of sequences we are taking. For example, here you can see survey, which is basically a survey. I don't need to inform system about it, or I can tell, okay, it's a survey scan only. Next, we have a BTFE. So BTFE in Philips is known for the balanced turbo field echo or the steady state kind of sequence, which will give a T2 weighted contrast we using cardiac. Then the black blood single shot. So basically by name is suggesting it's a black blood sequence. If you're doing T1, it's a morphological sequences. If you're doing fat sats, it's edema related sequences. So those all options are there. So we are doing the cine sequences in cardiac also, like 2 chamber, 4 chamber, in a kind of cine format or movie format. Those sequences are also mentioned as a functional imaging. So you can see sequence type as edema, sequence type is functional, or post contrast will come as a temporal enhancement or the spatial enhancement. So these all options we have to feed it for the first 3 to 5 cases. Next time system will automatically learn the moment it will come to your ISP IntelliSpace portal or the AVW server. So it will start reading it, this kind of methodology, okay, what sequence you have done for which kind of method. So now once you come in viewing, here I can see my functional sequences in one go. So let's say my doctor wanted to see only the functional series in 2 by 2 layout. You simply click here, system will generate all these functional series at one go. You don't have to do click or search for the studies. Even if the series is not get loaded here, you can click on this arrow. You can see all your series in the listing format. That's how easy it will manipulate for you all the data. Now you want to compare your short axis function and the spatial enhancement. Basically you want to compare your cine 2 short axis images with your post contrast viability. So just click on this protocol. See here, I can able to scroll post contrast images, and I can able to see the real time the function imaging as well. That's a kind of comparison it will create for you. Now if you wanted to report this study, you have the visual HA scoring. So before going to for the ejection fraction and all kind of post processing, beforehand only radiologist wanted to make some note, okay, this particular area is akinetic or is hypokinetic and all these things he wanted to mention, he can go for visual AHA scoring option. Let's say on the functional images, he told this particular area is hypokinetic. So these kind of map you can add in your finding reports, and it will generate one single template of report for your cardiologist preference, like which is the area you looked for the particular study. Now let me go back to my multi-view function option, and because I need to calculate the ejection fraction, I will select my short axis sequences. Okay, once I select that short axis sequence, I can able to see below function LV and RV in a blue color. So basically this is what the processing option available with this series. Now you click on the start analysis below. So once you click on this button, start analysis, मल्टीफंक्शन कुछ भी सेलेक्ट कर लो, शॉर्ट एक्सेस सेलेक्ट करो, बोला ना आपकी स्क्रीन छोटी आ रही है, यहाँ पे क्लिक करो और उसके बाद स्टार्ट एनालिसिस. So this is the window where you can see your 2 chamber, 4 chamber again automatically aligned, and this is something like system automatically detected which is end diastolic and the end systolic. Now because system is given us a value, we can always change it later, because it is we have the option code to change it in a later stage. You just click on the fix end diastolic and systolic, which is selected by the system. So moment you fix it, you cannot able to move your phases, you can only move your slices now. After this, there is an option called apply segmentation. So this is the part we are talking about. This is integrated with AI feature now. So previously what happens, the first era, all the radiologist has to draw counters over the myocardium manually and then process the data, which will take lot of time. Now here what happens is, once you click on this automatic segmentation, it will say it will take 1 minute to half minute for the processing. Just click on yes and wait for the result. First reload. This is a layout. Now fix end diastolic and systolic option. Apply segmenting, click on this star. It will tell it will take 1.5 minutes. Okay. Yes, so we can change this image, but changing those image, previously you have to go through the images for the identifying the end systolic and diastolic. Again, I feel you are spending time on that. What I can do is, after this post-processing, I'll show you there is a one graph will come, and that graph will show that over the time where the volume is maximum, and where is the volume is maximum during the entire retrospective acquired cine functional data. There you can define the end diastolic and systolic. That's the reason on the first step only, I just logged this fixed end diastolic and systolic. By doing this, I know that in the next step I will get the option to correct it. Okay, now you can see the counters got automatically drawn on the images, and if you scroll, you can believe like compared to our previous versions, now there is a 99.9% accuracy in this. So how I can assure you the accuracy even on the basal slices? You can see in this basal slice, right? After this, you see the accuracy even in the last slice as well. So wherever it's identified the chambers or your LV counter, it will draw on the ROI, otherwise it has not. So that's how the accurate it is now. Again, yes. So again, 100%. So coming to after doing by the system, you always have option to modify it. Like first option, after I apply segmentation, I have option to draw the segmentation. So let's say if any segmentation is not there during the tip of the LV counter, you can add it. Or now you don't want it means because it is drawn on end diastolic, because there it is visual very clearly, right? In systolic, that much clarity was not there. So basically system avoided. What we can do is, either we can draw one endo counter on the end systolic, or we can delete it completely only. In this case, let me delete, for example. Yes. So that we can correct. How we can correct is, the moment we go there, we can see multiple dots. Now these dots, let's say particular here the myocardium is not involved, means I can move it like this particular ROI. Okay. So manual work is always there. You can always correct it manually on your end. So that option we have not taken off. So let's say now here you have corrected on end diastolic phase. Now for end systolic you don't have to do this. You just click on the propagate edit over the phases. So moment you click, you can see some changes, it is done automatically on the systolic phase as well. Okay. Let me show you again. So I have corrected this here. Okay. And once I click on the propagate over the phase, see, it's corrected on the end systolic also. So that's how it will work. Again, the last part is the 1.5 minute is just taken by the AI option, actually not done this work. So this is very small work, I can say. It has also segmented the RV part as well at the same time. So let me show you that as well. If you click on the show RV counter in the option, now you can see. So this part till now all the software offers manually. So you have to draw each and every phase, these ROIs, and then your right ventricle ejection fraction used to come it. Now here it is also made it automatic with the AI feature only. Here also the accuracy got increased compared to previous option method of the algorithm. If you click on the create verify spoke field, so we know we wanted a AHA kind of reporting format. So I will come middle of my LV cavity, and here I will correct it. So this spoke field I can correct, like second and third should come in this LV area. So I can correct it, I can rotate it. Once this is drawn, sorry, yeah, you can go for the, after segmentation you can go for your view result. The moment you click on the view result, top segment, so this is the message actually. So now system detected the volume over the phases is differ. So whatever the end systolic and diastolic we have selected is not correct. So it is asking us to whether we want to update or not. Moment we click it yes, I'll get two graph here. One is end systolic LV, and then one more L diastolic also will come. 1 minute. Yeah. So these graph I can correct it now. Calculation done on slice and the phases, entire slice, entire phases, not on single slice. It always takes a volume of the data in MR. That's the advantage we got. It's not a 2D segmentation, it's a 3D segment.
Volume calculations will be spurious, no? Because that is not the entire sleep phase or the entire sleep phase that you have taken.
And we have corrected here.
Okay, so this provides the correction.
This provides the correction. That's the method actually. Now, so instead of going each and every slice and identifying the systolic and diastolic, now you have a graph where I can tell you like what is my most volume during the entire cycle of the acquisition and where is my least volume in the entire volume of the cycle. So I can correct it based on my graph. Now I can see my AHA report and all the formats. I can see my regional segmentation. So my ejection fraction always there. If I want to compare the result with the same patient age criteria, I will just have to update my BSA parameter. So do a right click on the graph, click on the global LV first. Now click on the graph. Sorry, in the table, sorry. In the table, do a right click, select set BSA parameter. So weight automatically came because you have entered the weight on the machine. Height will come when you enter it manually here, or if you have a HIA system where we are entering all the patient data, again that part also will come automated. For this sake of example, I am just taking height is 163 centimeter. So now based on the patient age criteria also, all the result got updated. That's how easy it is. So again, next method is perfusion. So you can calculate your perfusion temporal enhancement part. You can do your spatial quantification, like how much myocardium got enhanced in the viability. So that transmurality result you can share it, and you can do your mapping to calculate the ECV map also. So all this processing is enabled in the cardiac part. That's for the these data are Asian Pacific, because I told we have research collaboration with Indian centers like Narayana Rudralaya and other centers. Yes, yes. This one, yeah. So that's, if you see, this is very tedious work actually. If you click here now, okay, so it's very tedious work to do it. Here you can also see automatically your papillary muscles got excluded when you go for blood volume and all. And if you go for the slice, like now you are in AHA reporting format. Now you wanted to see, okay, I want to compare my apical lateral slice. You just click it here, same slice will get navigated here. So that's all feasibility registration of data is available. When we have calculation with blood volume or the complete myocardium volume. Yeah. Excluding. You're excluding. Now again, if I go for segment, this is the last step now, because your LV is automatically get calculated here. Even you can see your LV result as well. Yes. That formula I will show you, because that formula we can correct it here. You can see the table type, what kind of table you want, what kind of unit you want. That also you can able to correct it actually. That's about the cardiac MRI ejection fraction. If you want to calculate the Q flow, those options also available. Let me load the same data sets again. I'll go for all series in the cardiac MR viewer. Below is my Q flow data sets. Here, now I can see the Q flow application got enabled. So I'll just click on the start analysis. Let me see which one they have done for iota. So if you want to quantify the study, you just click on this drop seed functionality. Click here, and then from pencil you drop the ROI on the descending aorta here. It will ask you which particular anatomy it is. Select the anatomy, and it will give you all the graphs and measurements. In cardiac MRI, generally, with all the acquisition, we are acquiring aortic Q flow and pulmonary. Why aortic? Because the ejection fraction comes post my analysis. There is always question by the cardiologist. My echo is showing ejection fraction of 44, 48, and your MR is showing less or more. So to correlate that, the stroke volume I am comparing with my Q flow data sets and from my short axis functional images, where exactly the volume is matching, and then we are verifying on that level, yes, MR is giving more accurate data or not. Otherwise, we'll. So here they have not acquired any iota. That's what I was searching for, iota 1. हाँ, that's what. हाँ, इन्होंने लिया नहीं है actually इस केस में. with this AI method now, it is more accurate with the cardiac function option. So we have done the study. This is a site of Siemens where they are acquiring from their console. We compared the ejection fraction producing by Siemens system, our system, and the echo reports. Now everything matching with AI option. The reason it was coming because it's a variability within the users. One will take the section in the LV tip, like the base of the LV, he will, sometime it will cover by one user, another user won't cover it. So that accuracy will differ, and automatically ejection fraction, if you won't include a single slice, 3 to 4% accuracy will differ. Q-flow is always better, but Q-flow also gives different answers than this one. Yeah. And now we have for the cardiac part, this is about the basic workflow. Even the now cardiac will support your strain analysis, 4D Q-flow quantification. So instead of acquiring multiple Q-flow data sets and for a like 4 chamber, mitral, tricuspid, aortic, pulmonary, so it takes time, lot of time during the acquisition, right? You acquire one 4D flow data set and then MPR and get the values done. T1 need to be post contrast always generated by the system itself. But if you want to calculate the ECV maps, then either so there was two option. When the software was not available, people used to do it getting the ROI value, then calculating on the Excel sheets. Now those things are not required. The software will give the EC values. So yeah, this was the advancement part on the cardiac.
Yeah. We have sir. T1 mapping, T2 mapping, both you have. And other advancement is, it is vendor neutral. In case if you have a G data or a Siemens data, you can still analyze with the same steps.
So like Siemens is using, our is using short Molly, Siemens using Shasha, GE is using Shasha, then Molly is using. So all this vendor neutral part is there in the system. So you can process even the other vendor data is also in there. So we have the customer who is having machine from GE, Siemens, they are using IntelliSpace Portal for the processing.
So they are not able to go with the advanced processing. You can see the case, but you can't do the processing.
That is a unique possibility in Philips, sir. If you ask, like EDW, the GE, Singovia from Siemens, they doesn't support this functionality. They only work with their own data. That's what they
So
claim.
only the viewing part is given. The major post-processing part is like how we are vendor neutral. That is not enabled in the other competitions. No. You can view anytime. You can view the data of any vendor.
But post-processing
is the main thing where you get the report, final results. So that will be a challenge part.
So 100% using third-party software.
Third-party solutions. So they have a lot of third-party solutions.
Any question in this?
There are a lot of questions, sir. Yes, sir.
आपने 12 वर्जन यूज किया हुआ, राइट? जम्मू में भी एक पुराना भी एक नया वाला दोनों ही है. नहीं, दो है.
2016 means it is the old one, sir. It is the old one. You will have semi-automatic segmentation. You will not have the full. This is fully updated, like fully automatic.
Next batch also you can call. If next batch is there, you can call, otherwise we conclude. Because sir wanted to conclude it, that's why. Yes.
Anyone next wanted to try? We can just step forward.
ये तो आपके सारे फंक्शन आ गए. यहाँ पे आपका पोस्ट कॉन्ट्रास्ट आ गया सारे. बट अगर मान लीजिए यहाँ पे आपको कुछ और चीज़, जैसे अभी राइट टू चैम्बर दिखा रहा है आपको, तो क्लिक तो ये वाला हाईलाइट है. आप दूसरा क्लिक करिए यहाँ पे वापस, तो ये आपका बेसिकली लेफ्ट टू चैम्बर है, ये राइट टू चैम्बर है. अगर आपको सीरीज चेंज करनी है तो आप यहाँ से भी चेंज कर सकते हैं. तो यूज़र ने जितने सीक्वेंस किए होंगे ना 4 चैम्बर, वो सब इस पर अलाइंड हो जाएंगे.
समझ सकते हैं मैं देख ही नहीं पाया
Yeah, we'll show. We want